Hello everyone, and today has been sometimes labeled as a dark day of 9/11. Disha Metabolic Summit. All those delegates and our pharma partners, I welcome to this Disha Metabolic Summit. You might have seen, we thought we'll just have to form some group, doctors, non-doctors, with some social responsibility apart from conducting medical meetings and CMEs. So that's how it started. So we had adopted 2 villages, but thanks to COVID, we couldn't continue to do the work. And then few paramedical workshops we have done and camps, healthathons. Some of us are into a good bit of fitness and we keep inspiring others. And of course, the CMEs. So today's program is a long one, as people can see it, right? You will not mind staying glued to it throughout. The course director is Dr. Sanjeev Rao, and Aish Shekhar and Hem Kumar will be the reporters. We take turns and do it. So I think if we can switch to the presentation mode, we'll not waste any more time. For the first topic, I would like to call Amal Selvam. He was chosen mainly because his name starts with A as a chairperson. He's a good friend, consultant physician onto the stage. He is a senior consultant physician and vice chairman of KRSSDI. Thanks for coming and gracing the occasion. And over to the chairpersons. The first topic is, I think, very interesting, the iceberg of diabetic cardiomyopathy. What are the implications from the Emperor Preserved study? Over to the chairpersons. Mics for the chairpersons, please.
This Disha Metabolic. I welcome Dr. Basavaraj GS. He's a consultant endocrinologist to come and give a talk.
Yeah. Not much with trains then, and just to continue the legacy, Amala Selvam, doctor starts with A, I start with B, so I think we can keep on going. So these are all the problems of the alphabets we have been facing, I think, right from our childhood days, right? And Dr. Amal Selvam would agree definitely that probably we used to be the front very difficult for us to just peep through the answer examination sheets and all that. So doing the justice and to start the ball rolling, I am Dr. Basavaraj. For the people who do not know me, I am consultant endocrinology at Narayana Group of Hospitals, Bangalore. Cardiomyopathy, implications from Emperor Preserved study. So I've been fortunate enough to be a part of this trial held at NH Health City, Bangalore. So we all know about the risk of CV events occurring in patients with ASCVD and heart failure. So on the left-hand side, you can see people with a higher risk of ASCVD. You see there are people who are at low risk, who are at borderline risk, intermediate risk, and gradually worsening of the Indian data. But it comes roughly from the personal experiences of the cardiologist, it comes down to around 10%. The same thing, if someone has an event of a heart failure, so then the risk event rate of cardiac death or hospitalization starts basically at 10% and above. So they are stable outpatients who are having heart failure with reduced ejection fraction, NYHA class 2, class 3, no recent hospitalization in the last 6 months. Then they are the patients who have got a high risk, and then very extreme high risk, the super red of them, who are having advanced heart failure with reduced ejection fraction, intolerant or refractory to the therapy, and having recurrent heart failure hospitalization. So we'll start with a case study then. This is a 60-year-old gentleman, non-alcoholic, who has not consumed alcohol, who is not a smoker, diabetes, type 2 diabetes for the past 10 years, hypertension for the past 20 years. He has got worsening breathlessness on exertion for the past 6 months. Pride of 1 gram and 2 milligram respectively, telmisartan, amlodipine, thiazide twice daily, and rosuvastatin of 10 milligram month. So his A1C is on the higher side. HbA1c is 8.1%. I would preferably fairly doing elderly sort of a gentleman, A1C should be urea. Moderate grade albuminuria, exercise TMT was positive. CT angio was done by the cardiologist, which showed a 70% stenosis in the LAD territory. He had got grade 2 diastolic dysfunction, LVEF of 58%. We do not have an NT-proBNP in him. So this is the consensus statement for the heart failure. So we divide it into stage A, B, C, and D. A is at risk of heart failure, who have got the harbinger. The soil is very rich for an heart failure to occur. And then there is something called as pre-heart failure, who have got one of these higher risks from this, who have got a structural heart disease, a functional cardiac abnormality, or a high NT-proBNP, BNP, or a troponin T. And then there is this stage C, the heart failure, and the stage D with advanced heart failure, which AD or hypertension. These are products, autonomic dysfunction, the neurosis, the mitochondrial dysfunction, increased oxidative stress posed by the diabetes, effects of RAS activation, and this sodium hydrogen exchange abnormalities, lipid accumulation issue on which we are also working very actively in NH, and then lipid accumulation in cardiac myocytes, lipotoxicity, lipoapoptosis, and then the effect of adipose cytokines all together independently increasing the risk of heart failure. Yes, which did show that there was 46% of people with type 2 diabetes have some LV diastolic dysfunction. The trials which have been done in heart failure patients with heart failure, the broad classification criteria or differentiating characters include the preserved ejection fraction patients are usually elderly than that of the reduced, actually are more seen or more prominent in patients with preserved ejection fraction. Definitely yes. What is the percentage? Around 20 patients with diabetes. So then in them, 25% of them would be having some amount of heart failure in them, who are at least more than 60 years of age. Heart failure in females, it was slightly greater than that of the males. So clinical diagnosis of heart failure dysfunction, the typical symptoms of heart failure includes your shortness of breath, orthopnea, PND, reduced exercise tolerance, fatigue, and more time to recovery than usually required, ankle swelling, pitting pedal edema, classically which we know, and then the signs includes your elevated JVP, hepatojugular reflex, third heart sound, and in them who had a dilated cardiomyopathy, a laterally displaced apical impulse. X-ray, natriuretic peptide, brain BNP, if possible, and a 12-lead ECG is a must. So then again, comorbidity assessment, management of patients with heart failure, thyroid function test, one of the most important causes of secondary causes of heart failure is thyrotoxicosis, uncontrolled thyroid. Correction of the thyroid dysfunction, the hyperthyroidism, usually settles the heart failure worsening. The glycemic and the lipid parameters. And so natriuretic peptide should always be used in conjunction with all other investigations and the clinical information. Obese patients who have lower failure. For patients with dyspnea, natriuretic peptide testing have a very high diagnostic accuracy. And then in patients with other severe risk factors, screening or the management of heart failure, BNP and NT-proBNP are almost of a similar diagnostic. And patients with diabetes and diabetes, specifically now I'll be concentrating on the cardiac comorbidity functions. So now there are CKD, in them probably SGLT2 inhibitors or GLP-1 receptor agonists with proven benefits are to be used. And then in patients with heart failure, definitely the evidence more tilt towards the SGLT2 inhibitors than the GLP-1 agonists. So then going forward, ACVD effects are predominantly more seen with your empagliflozin and cana. This is again the ADA standards of care. And then the heart failure benefits, probably it's more of a class effect, sagliflozin also. And again, this is one of the very, very, very recent of the papers published by Dr. A.K. Singh and my friend Viral Shah. So then what they just looked upon the cardiorenal benefits of GLP-1 receptor agonists vis-a-vis SGLT2 inhibitors in type 2 diabetes. Now these beautiful inhibitors, they have again classified into confirmed, almost confirmed, being confirmed on the way, and yet to be explored. So probably confirmed are its effects on type 2 diabetes, and the DAPA-HF, and heart failure, preserved ejection fraction from the Emperor preserved and the DELIVER trial. So then again, almost confirmed is your stable impulse, even which I am a part of the trial. So these are all probably we need to look on to these things. So being confirmed, there are again evidences being generated for NAFL, post-MI, and then PCOS. So results are mostly awaited. And then again, the risk of atrial fibrillation also yet to be. It improves the preload reduction by improving the free water clearance, decrease in the stress blood volume, decrease in the pulmonary vascular pressures, decrease in the intragranular pressures. Myocardium improves the metabolic efficiency, diastolic relaxation improves the oxygen demand supply balance, improvement in the LV hypertrophy and remodeling and fiber vascular stiffness, decrease in the neurohumoral stimulation and autonomic balance. One of those things, very prominent things, is improvement in the epicardial adipose tissue thickness and also the volume, which can actually modulate these effects. So some of that LV hypertrophy, cytokine and inflammation, and extracellular remodeling, cardiac metabolism, and apoptosis are all improved, which actually improve the showing about the interstitial fluid regulation with that of the SGLT2 inhibitors. The sodium hydrogen ion exchange, SGLT2 receptors prominently. So these effects have to be mediated through non-SGLT2 inhibition mechanism. So probably sodium hydrated in the improvement. So coming to the talk, the evidences of empagliflozin. So we all know about this classical trial of overall 3P MACE. And then the Asian patient subgroup had a better 54% reduction in the overall hospitalization, 4% reduction in the all-cause mortality. 3 years, we have got 10 CV events, leukemia events prevented, 12 patients who have been insulin initiation has been prevented, and then systolic blood pressure goals achieved in almost number of years, life years added to these things. So coming on to the same, when we see this slide, we have theoretical workups which have been done, which show that empiric outcome was better with the major adverse CV events, and the canvas was also better. The cardiovascular death was only seen with empiric outcome. Heart failure hospitalization was seen with everything else, all the other SGLT2 inhibitors. So then the Emperor Preserve trial, this was a phase 3 trial done in patients with heart failure and LV ejection fraction. 40 to 50 is mid-range and more than 50 is preserved. So then they tried to look on to the effects of EMPA versus placebo in patients with heart failure and LV ejection fraction of more than 40%. So it randomized almost 6,000 patients to EMPA 10 or placebo and followed up for more than 2 years. Their composite primary endpoint, key secondary endpoints were first or recurrent heart failure hospitalization and change in the eGFR divided around there. And then diabetes patients were almost 50% of them had diabetes. And then what benefit in the CV death or hospitalization for heart failure. According to baseline diabetes, whether the patient had diabetes, did not have diabetes, the effects were seen in both of the groups. Effects were seen in both the sexes, both eGFR categories, less than 60 and more than 60 with or without history of atrial fibrillation. So then again, the adverse effect profile was similar to that of placebo. Vis-a-vis, according to other trials which have been done in patients with preserved ejection fraction, Emperor Preserve showed a relative risk reduction of the primary composite endpoint to the tune of 21%, whereas your Paragon, that's your sacubitril valsartan, Topcat, spironolactone, are all very fairly lesser. Only sacubitril and valsartan had a primary composite endpoint which was statistically significant along with that of the empagliflozin. So again, empagliflozin and heart failure benefits in patients across the risk continuum, in patients who had a low to medium CV, ASCVD risk factors with diabetes, ASCVD without prior event or with prior event across the categories ranging from 30 to 59% relative risk reduction was there. So in patients with heart failure with preserved ejection fraction, there was a 17% relative risk reduction, mid-range 29%, and reduced also, we also know from the Emperor reduced, a fantastic 25% relative risk reduction. So that brings us to the AHA guideline recommendations for primary prevention. It tells that in patients with type 2 diabetes and established CVD or at higher cardiovascular risk patients, SGLT2 inhibitors
Just
should
2
be
minutes
used
left.
to prevent hospitalization for heart failure. And then in patients with heart failure with preserved ejection fraction, SGLT2 inhibitor can be beneficial in decreasing heart failure, hospitalization, and cardiovascular mortality. With this, I'll end my talk. Please remember what John Maynard Keynes told us. Thank you.
Thank you, Dr. Raj, for your excellent presentation. It was very self-explanatory, updated study. And thank you so much ending this on time.
Thank you.
Any questions?
First, most commonly with heart failure, it is the diuretics. You need to diurese or SGLT2 inhibitors. In some patients who are already like MRA, mineralocorticoid receptor antagonist, then adjustment of the diuretic dosage definitely helps in these patients. please remember the adverse effects of these agents, the hyperkalemia, the factor because of the volume contraction. But don't get alarmed. Stop only when the decline in EGFR is more than 30%, and then be careful while initiating these agents. But
Coming to this,
yes, please.
you showed a slide where SGLT2 and DPP4 inhibitor, they were compared. Nowadays, we get this combination.
Yes.
Does it have any role in, is
Yeah.
it better in cardiac failure or?
Correct. So the newer combinations which are available, which are probably out of the patency things, and we have got DAPA-CETA combinations. The long-term effects of these things we are probably not very sure, but they definitely reduce the pill burden. The very long-term effects we have to wait and watch. But again, having said that, we can derive, if at all, if I can, then these things have to be taken up from again the combinations of empagliflozin and linagliptin, which do tell us that there was a reduced risk of genital tract infections and they were cardiovascular safe. But short-term data says definitely we do have.
If you have to choose between myopathy
Okay.
or failure, like, which one you suggest?
So definitely, I don't think we have a direct answer for this. ACE inhibitors are a different class of drugs. SGLT2 inhibitors are a different class of drugs. And then statins have a totally different class of drugs. Now, for someone with a preserved ejection fraction, with someone who is having a borderline renal failure, definitely ACE inhibitors are there, SGLT2 inhibitors there. Picking up one among them would be a difficult choice for me. Definitely, there's nothing like, yes, definitely, if you look on to the preserved ejection fraction trials, then it has shown better benefits as compared to that of the ACE inhibitors, definitely with respect to that of thing, but definitely, like, there's nothing head-to-head comparison or nothing of that sort of data which I could find of.
Thank you.
I think with this we will just end the talk and go ahead with the next topic.
Thank you.
And before that, we'll facilitate Dr.
One second,
Basura.
yeah. Yeah, please do that. Like to request the chairperson to felicitate the speaker. And it's a Disha tradition to always give the flower pots rather than the bouquets which we have carried forward. I'd request Dr. Hem Kumar to felicitate our chairpersons. I think Dr. Sridhar's question, I think he was talking about number needed to treat to prevent ASCVD. I think SGLT2 inhibitors have done well, even on top of statin and ACE inhibitor therapy. I think SGLT2 inhibitors are a phenomenal group of drugs. They opened the doors of cardio, diabeto, nephrology is what I see. Now in non-diabetics also we are seeing its use. Well, moving on to the next session, I would like to invite Dr. Vishwanath K. as the chairperson. Is a professor of medicine at MS Ramaya Medical College. Welcome, sir. I would request Dr. Sanjeev Rao, sir, to join him. We all know Dr. Sanjeev Rao very well, and I think I'll start off, instead of introducing him, I'll start off with his quote. A way to a man's heart and also heart attack is through the gut. So who better to talk on what gut holds in for us? Is just the intestines, or it is much more to it? We have seen a lot of evidence pouring out in various metabolic disorders that gut is all important. So to talk about gut microbiota, probably a game changer in many metabolic disorders, let alone diabetes, we have Pariksha Rao. I welcome her. She's a very prolific speaker, and I don't know, many must have been following her on Insta and Facebook with her very, very short, very, very informative, educative videos on this. Welcome, Pariksha. And over to the chairpersons.
Good morning, ladies and gentlemen. I will begin with a quote. Man is what he eats. And so, depending what you eat, you are what you are. So we'll let Dr. Pratiksha Rao elaborate on this.
Thank you, sir. Good morning, everyone. Understanding that gut microbiome is taking the lead in any discussion in any scientific forum, me as a clinical nutritionist have learned a lot that how different gut microbiome composition is actually impacting our precision nutrition. And that's where I thought I'll quickly talk about how this entire piece is changing nutrition lifestyle management for our patients. Just like our fingerprints, I think it's unique to everyone. It's involved in degradation of non-digestible polysaccharides or fiber, strengthening the microvilli, and I am observing that there is a lot happening with the gut permeability at this particular point where we are saying the PPGR response or the postprandial response to bread, rice, or any other carbohydrate that we are used to is going to that level. It also protects the host from pathogens by maintaining healthy gut-brain barrier. Also, there is marked specializations when it comes to type 2 diabetes or metabolic diseases that we will be talking about. Not a news that, our gut microbiome changes the way we are born, whether it's a vaginal delivery or a C-section, that's where the gut microbiome changes. We earlier knew that bottle-fed children had a different kind of a response in their adulthood and why breastfed children had a different response, but it goes before that, through the vaginal birth or even C-section, and that's where we see the most important gut microbiome that forms from the very first day in a neonate comes from that particular event of our life. A lot of factors that impact our gut microbiome, from diet to prebiotics to probiotics, from stress to our, we all know the reasons behind IBS today, which is our gut-brain barrier. And not to stop there, everything that we eat or the environment that we are surrounded with has an impact on our gut microbiome. Testing is becoming fairly easy in India as well, though it still is expensive, but the sequencing 16S RNA is becoming very, very validated now. A lot of data coming in from Indian microbiome labs as well. And it's just, they come and collect your poop sample, and then, the entire genetic composition is done. 4 to 6 weeks, you get your report. And we understand that Indian gut microbiome is very, very different when compared to Western. Of course, we eat different, we are born different, and our environment is different. And the main bacterium, which is 75 to 76% in a healthy gut, is eubacterium. And that's where we started finalizing that where the dysbiosis occurs. And that's what these reports talk about. They will talk about vitamin K2, which is produced by bacteria in our gut, vitamin B12, which is produced by bacteria in our gut, and then we can understand what is a normal gut, what is a dysbiotic gut, and what is leading to different metabolic issues as well. Like I was mentioning, a beautiful study that we are doing internally, not a clinical trial, just an observation trial, how an individual or Indian in different regions also has an impact on their gut with their local food as well as food that is coming from Western origin. So if we can see that Indians, we eat high fiber diet, not very high, but comparatively it's much better than the Western counterparts. So our diet is rich in carbohydrate, I agree. Our diet is rich in fiber when compared to Western counterpart. And you can see the difference between the species that we have, or the taxa or the genre of bacteria that is there in our gut microbiome, very different from Western diets. That's why I generally do not prefer following ketos and Atkins, because I know it's not going to work for our Indian population. So Previtola species, especially the Previtola copri, which are more protective, and not the other species which are pro-inflammatory. That's what we see in our gut microbiome. But the westernization, the eating of junk food and high sugar, high fat diets, they are leading to all the nuisance that's happening in our gut today. Like I said, a lot of studies have reported that because we eat a high carbohydrate diet, our genetic composition is also there to metabolize that. So we don't find it difficult. If I give a big piece of bread to a American and I give a big bowl of rice to Indian, we have a better tolerance to that. But again, it can't be out of balance. So we have to make sure that every bit is balanced. But yes, the point is our gut is ready to handle that carbohydrate, and we can't handle such high fat and high protein diets. That leads to pro-inflammatory markers, and that's why no keto again. Dysbiosis setting in, we have a lot of data. We understand it very clearly. All the protective toxa like combination of bacteroids and firmicutes, the balance or the ratio, which is actually anti-inflammatory in nature, that's where the whole protection is coming in for us. And the dysbiotic gut, we understand that, our IL-10 factors are reducing, our short-chain fatty acid production is reducing, and the short-chain fatty acid production is the key to develop the entire good things that these good bacteria is contributing to our health. Type 2 diabetes, completely clear, it is impacting the intestinal permeability where the blood sugar regulation is happening. Insulin resistance and type 2 diabetes, and at least 8 to 10 type of genre of microbiome is clearly correlated with a positive or an inverse correlation with them. Obesity, PCOS, thyroid, osteoporosis, we name any metabolic disease, and gut microbiome is the mother of taking care of either leading to a dysbiotic gut and leading to a metabolic, a poor metabolic outcome, or we can be improving it at the very first day when diagnosis is done or we know there is a predisposition in the family itself. This is these are the four areas where most of the research is focused, that how gut permeability is modified, how the fatty acid oxidation and synthesis is happening. We all know that 10% of energy that we utilize is produced in our gut by the bacteria. So, you know, how the person feels energetic at the end of the day or losing energy at the end of the day is really going down to their gut. And like rightly said, there is a big saying that death begins in gut and any disease begins in the gut. So that's where we see the composition of gut microbiome leading to poor outcomes if it's in the dysbiotic stage. Glucose and insulin homeostasis and inflammation. And inflammation, there is a particular set of rhamnococcus or the bifidobacteria balance that is leading to pro-inflammatory markers, which are directly correlated to predicting the onset of diabetes, pre-diabetes, or even predicting the kind of medication that can be put in place for a better outcome. These are the good ones, which actually have shown to reduce the entire inflammatory process, improve the gut permeability, and control blood sugar. Whereas Bloschia, Vlersa, there is a Japanese control trial going on currently, which is showing that this particular taxa of gut microbiome as a probiotic, when introduced to the daily diet along with anti-diabetic medications, actually had a very beneficial effect in controlling blood sugar. Interaction between gut microbiome and anti-diabetic drugs. A lot was seen earlier also as a dietitian when I used to see a pre-diabetic or a diabetic coming back with a prescription of metformin. We knew that it is going to lead to GI disturbances. At least in 70 to 80% of people that I was talking to were having that. And we understood that maybe there is something happening at the gut level, and now we know exactly what's happening. We understand that metformin actually reduces our ability to form B12, and you know that's where the dysbiosis starts happening, and maybe that's why there are GI disturbances due to other factors as well, but gut microbiome has a massive role to play with metformin itself. The inflammatory reaction, it can impact the drug's bioactivity, bioavailability, and even toxicity. There are a couple of trials that are happening in US as well, Japan as well, which are talking about exact dosage of medication along with the presence of good and bad bacteria and an impact on blood sugar control. Traditional Chinese medicine, you will see a steep increase in adoption of these kind of trials like bilberine, curcumin. I mean, you talk about it and it's everywhere, but we now understand that how this particular bioactive coming from a nutraceutical product or from a prebiotic, probiotic product, why they are so effective when given in a complete scientific manner, understanding the individual's gut and planning in place. This is what I was talking about, that metformin and a different type of gut microbiome, if a person has higher firmicutes or lesser bacteroidetes, they show that they lead to discomfort of gut, which we know. And certain individuals, this dysbiosis is very, very common. And in Indian cohort, there is a lot of study going on in North, and we are observing from Haryana and Uttar Pradesh what kind of dysbiosis is happening, because that's the zone where we saw that metformin-related GI disturbance was reported the most. On the other side, alpha-glucosidase inhibitors also reduces the drug's activity. We knew that it's actually reducing the polysaccharides or the sugars being absorbed back by the gut. Of course, when it's remaining in the gut, it actually is altering quite a bit of gut microbiome. And again, the balance is going off. Maybe this is the new thing today, though it's an evolving science. We are definitely practicing quite a bit on precision nutrition. You all are the experts on precision medicine, but whatever studies I come across, there is a lot of work happening around which talks about understanding the composition of an individualized gut and how to modify the type 2 diabetes management. coming to what we do, we understand that lifestyle modification is the first treatment protocol for any metabolic disease. If we understand the gut composition at that particular time and understand that a particular probiotic can actually enhance the blood sugar regulation, it is a good idea to add that at particular time. Like I said, Bloschia, certain species of bifidobacterium and lactobacillus have been showing good response. We are doing a comparative study of a very small cohort of 10 plus 10, where we are trying to add prebiotics and probiotics to regular anti-diabetics that has been prescribed by the doctor. And we are seeing good response when pre and probiotics are added, actually reducing the drug load or the pill load. Understanding that preventive nutrition concerns are very high. We understand reversal of diabetes is possible, and the whole world is now talking about it. It has to be done in a scientific manner, in control with precision nutrition as well as precision medicine, and we can actually support individuals to a very great level. This is a beautiful study done by Zivi et al., where they picked up a personalized nutrition platform. They created a perfect tool which could have predicted that this kind of particular carbohydrate will not be an issue for a particular gut. And that precision nutrition protocol actually gave a lot of insights talking about that how going to an individual's gut can be a wonderful game changer in actually reducing the incidence of diabetes in our country as well. So if you can see, a standardized meal was given to all the participants, and the chart on the right talks about how 4 different people had 4 different blood sugar response to only bread. And here I'm only talking about bread. So me, if I'm trying to do a stratified nutrition and I talk to a diabetic and I say no bread, doesn't apply today. No rice. I mean, sitting in South when people are born and brought up on rice, when my gut microbiome is ready to digest rice, why will I say no rice? I need to find out what the person's response is, and that's where we do CGMS, and that's where we try and understand whether this person is digesting rice or not, whether the gut microbiome is helping me or not. And that's clearly understood. If a person has very high sensitivity to white rice, I see the same for the brown rice as well, and it doesn't make any sense. I just reduce the quantity of rice and I'm good. So the idea is that the stratified nutrition or lifestyle practices that we followed so far, it's time that we can go to a personalized and a precision nutrition. Rather than saying everybody no rice and no bananas, I think we can dig deeper, have a CGMS data in front of us, if not a gut microbiome test, have a 14-day pattern and understanding what is working and what is not working. Because if we can see, it is as low as staying in the limit for subject number 358 and very high for subject 67. With 2 slices of bread, it spikes above 260. So reasons for these variability, we all knew genetic plays a role, environment plays a role, your stress plays a role, but again, we wanted to get down to what kind of species of gut microbiome actually is having an impact on blood sugar utilization. So Keck pathway observed, they tried to individualize the response with their gut microbiome. And ideally, we understood that proteobacteria, enterobacteria, actinobacteria, and certain specific species of rhamno and bacteroids, these are the ones who are the culprits. So as soon as the balance of these bacteria go off in our body, that's where the blood sugar regulation goes for a toss. And if we try and keep these in control through prebiotics, probiotics, or with the personalized nutrition that can be put in place, we can actually take care of the pill load as well and the management of entire lifestyle management. So they planned a high PPGR diet and a low PPGR diet. I mean, no wonder a healthy Indian diet is what we are looking at. We're not talking about a high-fat keto Western diet. And these were the responses. So green is the low PPGR diet, red is the high PPGR diet, and it was clearly understood with the same kind of intervention done to individuals when we try and understand their gut microbiome, along with the entire medication that they are on, adding prebiotics, probiotics, or symbiotics, which are going to be the game changers in lifestyle management for type 2 diabetes, actually added a lot of importance. Same study, we understood that Bifidobacterium adolescentes decreases after the low PPGR diet. So it has been seen that obese individuals have low levels. So if you reduce that, weight management can be taken care of. On the other side, rosbera involved in type 2 diabetes, once you reduce that levels, of course the incidence of type 2 diabetes comes down. So understanding families where it's running in genes, generally I get an idea that, I don't eat bad, it's running in my family. So, these are the patient-centric discussions that I'm having these days, that it is a part of it. I completely agree, but you can modify with lifestyle modification. So gut microbiome and precision nutrition can do wonders. Diet diversity, what we talk about is that eat local, eat the way grandmas eat, and whatever local new food you can find, that's where our gut microbiome becomes stronger and stronger day by day. At least 5 colorful fruits and vegetables are pulses and legumes, not quinoas and broccolis. I'm talking about local produce where the soil microbiome can actually support our gut microbiome for the environment, for the temperatures that we live in. And God has done wonders for that matter, that every place the food that is cultivated or grown actually supports the microbiome in our gut to handle that temperature, handle that environment, and manage that kind of stress. So go for local, maximum amount of local foods. Only one thing that I talk to my patients is that one dark green leafy vegetables, which is new to you from that local area, that does wonders. And we've seen a lot of rejuvenation of the gut microbiome, handling the dysbiosis taken care of, just with one fact of one new food a week from your local environment, local produce, and it'll support your farmers also around you. Lot of discussion on low carbohydrate diet and high fat diet. Indians, Asian Indians, we are very prepared to handle good carbohydrate, high fiber carbohydrates. I'm talking about complex carbohydrates. Maida and starches were never in our diet. We have been eating millets and pulses and legumes, and that's what we need to do today as well. Yes, the composition of fiber or carbohydrate on our plate are changing today. Instead of going for 45 to 50%, now we are saying that it'll be a good balance of having at least 40 to 45% of carbs, good amount of 20 to 30% coming from fat, and remaining can come from protein. And there has been a beautiful study done by Nutrition Association of Gut Therapies. They are also talking about how a particular balance of protein and carbs is actually supporting this dysbiosis or good homeostasis in our gut. Impact of non-nutritive sweeteners, these are actually killing our gut microbiome, if I can put it this way. Understanding that non-nutritive sweeteners trick our brains to release the same amount of sugar, that was proven, right? Our brain gets tricked from neuropod cells, just like GLP-1 analogs and GLP-1 works. Same way, neuropod cells are very, very important when they're talking about gut-brain axis or gut-brain communication. All these artificial sweeteners, from sucralose to aspartame, even stevia, have been found to dysregulate the gut-brain connection. So when your brain keeps getting tricked into releasing, or senses that the sugar has come in your body, hyperinsulinemia is seen very often. And we have seen that gut microbiome changes are to a very, very negative level. It has been observed that from inter to intra-individual variability, non-nutritive sweeteners, especially the two worst ones, which are now everybody knows probably, the acesulfame and sucralose, it's better to stick to probably a little bit of jaggery or a little bit of natural sugar coming from fruits rather than going for non-nutritive sweeteners. Even the natural ones, I generally do not recommend. If a patient is really, really comfortable using stevia and stevia extract, I think the best is to use it in moderation.
Can you please summarize? 1 minute, please.
And just to summarize, individual gut microbiota, like I said, it's like a fingerprint. Dysbiotic gut is leading to a lot of metabolic disorders, and we understand which are the ones contributing to it. Microbial-based therapeutics, including FMT, I'm sure it's a very evolving science, and it is gross at the level, but have been showing beautiful response in controlling blood sugar levels. Prebiotics and symbiotics. Symbiotics are showing good response in managing type 2 diabetes or even type 1 diabetes. Blood sugar regulation and reduction in insulin dose demand have been observed. And pre-diabetics, pro-diabetics, or a diet which is high in fiber, an Indian diet which is balanced and high in fiber, actually can be the core of leading to a good, healthy gut microbiome and controlling the entire incidence. Thank you.
Thank you very much. I think it was a very comprehensive lecture from personalized nutrition to gut-brain axis. If there are any questions, probably we had. Oh yeah.
True. So that's what I was talking about. We Indians are Asian. I mean, gut. The way we've born and brought up, we've never eaten pastrami's and chicken and fish, which are very high fat, right? Our diet has been predominantly been based on carb and legume balance. Our gut is not prepared to handle 50 to 60 grams of fat. Typical keto was prepared for epileptic management, right? Epilepsy diet was keto diet, which we have now modified, and we say that 80% of fat is needed for keto. Our gut gives a very bad inflammatory response to that. And if I have observed the weight reduction and a gut microbiome composition on keto diet for more than 3 months, I have seen pro-inflammatory markers increasing in Indian population. So, yeah. So for a very small period of time, what we have seen is the way it changes your gut microbiome, it shakens it up. That's where the bacteria which is responsible for weight gain actually reduces, and we see some response. And of course, your body is burning good amount of fat because you're remaining in the zone of ketosis, right? In a long term, if I observe after 8 to 10 weeks of keto diet consumption in Indian population, it actually reverses. And because we can't sustain that kind of a diet, people bounce back. And there is double weight gain because the bad bacteria has increased in our gut. So it's not been a long-term outcome that I have seen so far. Very motivated patients who actually don't mind complying to that kind of a specific diet, only there I see results.
Where do you get this gut microbiota profiling done? You said it is now commonly available.
There are a lot of labs now, that I'm working with, sir. I can definitely share the names and details.
The approximate cost?
Around 10,000 to 12,000 for one sample processing. So they come home, they collect the sample.
With respect to Indian
yes,
data?
Yes, yeah. Absolutely, sir. Absolutely. So they have, they send you a video link also how the sample needs to be collected. They come home, they collect the sample, and then the test report comes to you, like a blood test report.
Yeah, just to quickly, very nice elaborate talk. We had also our experiences in patients with type 2 diabetes and COVID. We looked at a small group of 50 patients. We are ready to publish that data. As Dr. Pariksha mentioned, there was definitely some of these negative bacteria, which we had fusobacterium, I think, which was more predominant in patients who stayed longer in ICUs with COVID and diabetes than patients who were discharged early. So probably it's all about what we eat. The same holds true with our thoughts also.
True,
probably, yeah. Thank you.
Thank you.
Madam, your comments on organic food, which is being propagated a lot on the internet otherwise, and quite costly also, almost 1.5 to 2 times. Your comments.
True, sir. My personal belief, if you ask me, I'm not sure about how the industry is handling it, but for me, if there is a plot of land which is organic and the next plot is not organic, right? They are using fertilizers and everything. Earth is connected, right? Everything is leaching from one root to the other root. So I don't know how much organic is organic today. If we have a local farmer, I rather prefer going to that, having that farm adopted with them, and I know that whatever is going in is to just safe levels. Nothing extra is done. I understand that there is some amount of protection that is needed for crop as well, and with the right kind of washing and things like that, it can be taken care of. But I do not understand the pattern, the way we have a farm, right? Molecules are coming on our food as well, molecules are coming on our food as well, or they can come from organic. I do not spend that money as of now.
Any other questions, ladies and gentlemen?
Yes. Yes. Cheese also, because they're very good with, which is a postbiotic, which we call. So if the gut is, and they work wonders with the energy.
Dr. Smal, just want to know, environment plays a major role in this, because we have seen a lot of cases, the patients who go abroad,
right,
their control becomes much better compared to Indians. I really don't know what's the real scenario behind, but I feel that environment really plays a major role in this.
I completely agree with you, Doc. So I mean, same observation. Two things are there. We are correlating a lot of families which are based around industrial setups where there is a lot of environmental pollution, water pollution, and water is the main source for soil and everything that we are consuming. From there to our stress levels. So we have seen that if the person is happier there and the stress levels are coming down, that also has an impact on gut-brain axis. So agreed, completely agreed.
Any more questions? So I think we'll conclude this session with the saying that it's better to go back to nature.
Absolutely.
Thank you so much. I would I think she was vocal about local than global, and I'm sure further questions. And I would like to request Dr. Sridhar to felicitate. Anyway, moving on to the next. I hope I was at least here they can acknowledge that I was a good student. And I would like to invite Dr. Anil Kumar, Professor of Medicine from Ramaya Medical College, decoding and well known to every one of us, prolific speaker to take over. Dr. Anil sir, you want to say some comments before we move on?
Very committed. I asked some question regarding myself. Should I take a statin for primary prevention? And she gave a...
Thank you, Dr. Anil. And incidentally, both of us left Ramaya together. Meetings again. So today I'll be talking about decoding and preventing CV events in dyslipidemia management. I'm not talking about statins, just a disclaimer in the beginning. So another disclosure, this talk is supported by Biocon. And basically, very, very early on, somewhere in 1984, there was a very big study called InterHeart. I'm sure many of the people in this room would have heard about that. And for the first time, we realized what was the relative risk of each of the risk factors that we had. Earlier, lipids was the most relevant when it comes to a CV event of an MI. The next was hypertension. Of course, all the rest, smoking. So let's look at one case. This is a 49-year-old woman who has type 2 diabetes and hypertension. She is dyslipidemic and she had knee surgery, not too much, and she never had symptoms of CHD. Her lipid profile shows the LDL is still 130, 8, and her glycemic control is pretty good. So minimal alcohol intake, family history of rosuvastatin 40 milligrams, like I told you, and antihypertensive and antiglycemic metformin. So if you look at the class is what we target, if you say if you're at 130, but now it is 150, 70, and very high risk, maybe who have already had a heart attack should be less than 55. So CV risk increases, they need to reduce, touching the tip of the iceberg with the current prevention of cardiovascular risk, especially myocardial infarction. There was always a residual risk. These were huge trials which start before and after little detection. So if you look at each of these studies, just look at one study, the 4S study, which had a significant around 4,500 people, and post-statin, there was a reduction SIBO and with statin, but we still had some reduction. So we know we need some other drugs for reduction of LDL cholesterol. 1,000 people who were diabetics, around 71,000 who were non-diabetics, and they found that with statin, the residual risk was there, but higher than a non-diabetic patient. So coming back to Our Lady, so she was on 40 milligrams, her LDL still continues to be high. So what should we do? How do we, that is an option. But let's look, is there anything else we can do? What are the newer therapies? So at maximally tolerated are some of the problems we have. So which target, which was for 1-year study, which was called Clear, they did 4 studies. There was Clear Harmony and Clear Wisdom. This was people who were there, already had a heart disease, ASCVD, or they had a hereditary hypercholesterolemia, familial, they were on maximum dose, this was increased. One could not tolerate more than this dose, and then they were increased. So this was the dose, and we found that in these studies, statin and 15% in both the trials respectively. This is general. was around 24, lower moderate intensity was 14.9, and those who were on high intensity was roughly around 14. And trials have shown to, if you add it to a background of statin, that's what is the recommendation now, you will have reduction in LDL, non-HDL, ApoB, and HSCRP. So this down to 93, not that great, seeing that she's high risk, but we wanted still further. Of pain in his thigh and arms, and this was typically after he increased the dose from 10 mg to 20 mg. He has no other reason why he has body pain. So, Torva or added drug. So this was the other two studies which were done, which is called the Clear Serenity and the Clear Tranquility. So these were on a small dose, and then they could not spike up the dose of statin. Pathway starts off with citrate, then goes on to ATP citrate lyase, and at this level is where bempedoic acid works. Bempedoic ATP related, no receptor for this in the muscle. So that is why it does not cause any muscle ache, because this is just one step ahead of the HMG-CoA reductase, which statin works on. 6. The reason is that they were not on the maximum tolerated dose. They either could not tolerate the maximum dose, or they did not want to take, which is one of the very next time and start statins. Somehow the statin fear is in many of the small number, with 653 receiving the drug and 343 receiving placebo. So this is what they found in many reduction in LDL. And majorly there was no muscle-related problems in any of them. Tolerated drug or looked at very low levels or no statin, they did find a reduction in people who are taking maximal doses of statin. So, so what is the regulatory status of bempedoic acid? It is a US FDA drug approved way back in February 2020 as an adjunct to diet and maximal tolerated statin therapy for patients with heterozygous familial hypercholesterolemia. This you can understand this, that is what I showed as an inclusion criteria. Those were people and also established ASCVD who required further reduction of LDL cholesterol. The European Society also recommended it and approved it in April 2020, and they said that other lipid-lowering therapies unable to reach our LDL goals. You can also use it in alone or in combination with other lipid and is contraindicated. I did have patients, he is a doctor, I started him on statin, and after a couple of months, there was no other reason why he should have it. So we said, what could be the cause? What could be the cause? And then we said, okay, let's stop statin. That was the only new drug I had started for him. The whole RBCs and WBCs disappeared. Again, we started statin, who can get interstitial nephritis with a statin. So all this we have to keep in mind when we do this and follow up the patient very carefully when on any therapy for that matter of fact. Citrate lyase inhibitor. The first step in the cholesterol synthesis, that is where it works. It's a hike in statin, or he's on a hike in statin, or he's on already a maximal tolerated dose, but he is not able to reach target. These are all areas in which of patients have, what do I find? I don't find this is not done, so I really don't know what will be the effect, but next time I'll definitely tell you. What is the dose? It is 180 milligrams once daily, with or without food, it does not matter, and that's how it is available in the market. We all know that this is a soft marker. Anything, cholesterol is a lipid, is a soft point of fracture, would not reduce. So now we know that we need to understand what happens to cardiovascular outcome trials. This is very, very important. So that benefit we will have in the recipe. Does that residual risk further reduce to, let's say, 20% after adding bempedoic acid is what is the outcome we are waiting for. This is those Pre-diabetics we have seen with dyslipidemia, and we are thinking, should we add for this patient? Will I cause him new onset diabetes? This is at least what I think in a patient who has sugar. We are worried. New diabetes, as we all know, is about 9% in patients who are started on statin. Found that the adverse events were, of course, muscle pain, etc., or rhabdomyolysis. But yes, fasting plasma glucose over 24 months increased, trending towards significance, but didn't reach significance. But HbA1c definitely increased, reaching significance was statin. Then glycemic parameters with bempedoic acid reduces. Why does it reduce? It is possibly associated different. They have found that it reduces the blood glucose both in diabetes and in pre-diabetes by 0.12% in diabetes, which is significantly reduced. So the unmet needs, to conclude, who are they? Residual risk, more than 50 to 80%, don't achieve LDL goals, 50% residual risk in spite of statin therapy, statin intolerant patients around pain. If you really ask history, you will really get these answers. And those who we find that worsening of hyperglycemia, not only seeing worsening, patients themselves come and tell us, doctor, will I get diabetes if I take this drug? Doctor, will my sugar go up? And in those cases, especially, I pay to disadvantage, but yes, so helps in additional reduction of LDL, can be added to patients who are intolerant and doesn't alter glucose parameters. So thank you very much for a patient hearing.
So, Dr. Maladharamlingam has given very important information. That statins is always a problem, whatever is available with all the studies. And even she's now started the medicine very recently. And
no, actually, they are not saying that there is any increase in uric acid with this drug. But yes, it's good to monitor milligram increase in uric acid. Yeah.
Madam, will this bempedoic acid
not
first
at
line?
this line in those who are intolerant to statin. However, when the patient is sitting in front of you, there are some patients, they say, no doctor, I don't want a statin. Maybe in those patients you should be putting, but you should not offer it as a first line. Your first line offering is a statin, and if they have side effects or intolerant, you add this. And if they are not controlling well, then you can add this drug.
And in pre-diabetics with dyslipidemia?
Yeah, that is one area I feel it may be useful, because actually I'm very scared to add. Though the risk is 28%, we don't know. We say really worried in those pre-diabetics that I may be pushing on this, that to an Indian population where we have...
Minimum alcohol intake was there in that lady.
Oh, I don't think that's significant. Thank you so much.
its role, I think it will be difficult to replace endothelial protection effects. So I think we have to be more skeptical and wait and watch. Thank you.
Maybe if it shows good results, maybe instead of stepping up statin, this could come as an add-on maybe. All of you to stay there. We won't bore you with the long inauguration. So Team Disha members, please come to the stage. Dr. Lokande sir, Dr. Syed Jawaz, and one of the delegates, I think that gentleman was one of the first to come. You please come, and one of the pharma representatives, at least, okay, two of the. Yeah, at this juncture, I would like to say that we are missing in physical presence our two proud patrons. Most of you should be knowing Professor K.J. Shetty and Professor Lily John. Please join.
नायकाय नमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि गजेशाय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थाय
I would request senior consultant physician and neighbor of mine, Dr. Lokande, to come down to chair the session. The speaker is Dr. Pramila Kalra, across broad range of patients. Slides, please.
Dr. Pramila Kalra, she is a consultant endocrinologist. I don't think she needs it. I will now request Dr. Pramila Kalra to talk to us about gliptins, the new decade of simplifying diabetes care with gliptins across broad range of patients. Dr. Pramila Kalra.
So good afternoon, everyone. Very nicely. And I'll be talking about treatment of type 2 diabetes. But whenever we are talking about treatment of type 2, there are a few things which come to our mind, or when the patient is sitting in front. The second thing is obviously it has to be efficacious. The third thing is there should be minuscule or no side effects. And the major side effect, what we are worried about, is hypoglycemia. And also we want that patient should have a durable action of that drug. That drug should work for a longer period. So there, where we think about, 15 years back, we were thinking more in terms of SUs after metformin, and we were always talking about that. But over a period of time, from 2006, when we got first gliptin in Indian market, and then we got many more drugs like SGLT2, GLP-1s, now we have oral GLP-1s. So we have many more things to offer to the patient before we add a SU. So that's what we are going to discuss, that where all we put this, what is the evidence with the gliptin, and then we will be discussing one or two cases just to see which are the correct case scenarios where we definitely think about gliptins. Not that we don't think about gliptins in the other case scenarios, but these are the point of time when we definitely think that yes, gliptin is a good choice of drug for this patient. Now, we know that the burden of diabetes is increasing day by day. It's not that it's coming down, it's increasing, unfortunately. And more so in the last 2 years, we have even seen that the obesity is increasing, more patients are coming with weight gain, there is lack of exercise and lifestyle modification even more. And now patients have an excuse that there was lockdown. Now also if you ask, why are you not going for walking? First there was lockdown, now there's rain. So patients have all the excuses. So we know that there are a lot of things which need to be taken care of when we are talking about the diabetes management. And also we need to see that now we talk about long-term cost. We used to talk about short-term cost in diabetes. Like we used to say, okay, what is the cost today for the medication, or what is the cost for the investigation today? But now we don't talk like that. Now we have understood that it's not the short-term cost which needs to be talked about in chronic diseases, but it's the long-term cost. Long-term cost means like over a period of 5 years, what will happen to this patient's quality of life? How much expenditure this patient will do if the patient gets one episode of hypoglycemia? How much expenditure the patient will do if the patient lands up with a renal failure? So this is what we talk about, and that's how we manage diabetes now, rather than the approach of a single day cost about the medications. And this is true, that because if we don't talk about the long-term cost, we know that the burden is for the future. So we know that now we have diabetes patients coming to us at a very early age. Like they'll come to you at 20, 22, 25 when they get type 2. And they will be in their productive years of their lives around 40, 40 plus. When they'll be in the most productive years of their lives, they would have had diabetes for at least 15 years or so. And that's the point of time when you're worried. So we have to know and we have to understand that whatever data or whatever studies have been done for diabetes, they have clearly shown that you have to hit early and hit hard. If we hit late, then we may not give the requisite benefits. Now, when we are talking about the use of gliptins, we know that when we talk about our South Asian population, though they have a low BMI, they have insulin resistance, they also have an insulin secretory defect. and they have higher DPP-4, and we know that they have more of visceral fat. Now, is the Asian phenotype more responsive to DPP-4 or SUs? Obviously, we know that there is now data that South Asians respond better to the DPP-4 as compared to their Caucasian counterparts. And we also know that there is a durability of these DPP-4 which is seen. We have data from the verified trial now where the patients who were newly diagnosed and they were started on a DPP-4 with metformin, and we know that they did much better for the durability of the control as compared to patients who were put on metformin alone. So we clearly know that it's the durability which is very important. We have to start early, we have to start on time, but also when we compare them with SUs, we know that over a period of time, the glycemic control comes down or wanes off. So that also we know. So we know that we need to have drugs which have more durability. But we know that it is not one drug which is going to work. We know that after metformin, we add a gliptin, we need a durable action. But over a period of time, diabetes is a progressive disease. There's going to be a progressive beta cell damage, and we need to add more drugs. Now, when we are talking about the DPP-4, like we discussed that there is some better action or we see a better HbA1c drop, we know that DPP-4 inhibitors, they have many mechanisms, but we know that they lower the blood glucose levels by restoring the first phase insulin secretion in a glucose-dependent manner. That's very important, this glucose-dependent manner, because if the patient has a lower value of glucose, that DPP-4 won't be very much effective, the inhibition. And that's the reason these drugs don't cause much of hypoglycemia, or the hypoglycemia risk is almost zero. And they also suppress the glucagon levels. That's why they are effective across all stages. So when we say why DPP-4 works when the patient is on insulin, because they have multiple mechanisms. So even in a later stage, they also work by suppressing the glucagon. And that's why they form a very good synergistic combination with SGLT2. That's one of the reasons, because we know that SGLT2 raise the glucagon. And they also it has been seen that in Asians, there is restoration of the first phase insulin secretion defect. Also, we know that the Asians may have a lower level of insulin resistance as compared to their Caucasian or European origin counterparts. Now, when you talk about the differences in the glucose-lowering efficacy of the DPP-4 inhibitors between the Asians and the non-Asians, there are multiple studies which have shown that, and most of the studies have shown that in Asians we do see a better response, like the reasons I have told you already. So these are all the studies where they have seen that in Asians the response is much better as compared to the non-Asians. That doesn't mean that they don't work, but it is a better response. So when we talk about the use of these type of drugs like DPP-4 or SGLT2 or GLP-1, we know that these drugs are definitely beneficial. As I told you, when we talk about DPP-4, the mechanism is definitely like that they'll hardly cause any hypoglycemia until and unless they're used in conjunction with SUs or insulin. And they will give a good glycemic efficacy. We know that now we say we don't want the glucocentric approach. We always say that. But if you see the data of all the studies, glycemic control has to be there. Over and above, we want the cardiorenal benefit. So we want drugs which can cause better effect on the cardiorenal outcome, or at least they are cardio neutral or renal neutral, or they have some better effect. So let us see some of the evidence with gliptins. Now we know that when we talk about the gliptins, we know they have multiple mechanisms. They have an effect on the increase of the incretin hormones. They block the DPP-4 enzyme, which degrade the incretin hormones. They also help to take care of the insulin resistance to some extent, and we know now there is data even with reduction of inflammation with the use of gliptins. So we know they have multiple mechanisms of action. Now, when we are talking about the use of DPP-4 for a dependable glycemic control, we know that if you see the efficacy, like if you see in this data, the use of DPP-4 inhibitors or the efficacy of DPP-4 inhibitors as compared to placebo, we can say that an average drop which is seen is to the tune of 0.8 to 0.9%. Some patients you can see even a higher drop like this, up to like 1.2, because it depends on what level of the HbA1c you start with. If the HbA1c to start with is initially higher, you can even see a higher drop. So if you see the reduction in the HbA1c as an add-on to metformin, because whenever we talk about any drug for glycemic control, we need to see that as a monotherapy, what is the HbA1c reduction? Then as an add-on to the other drugs, what is the HbA1c reduction? And if you see that overall the HbA1c reduction is to the tune of 0.9 to 0.8 to 0.9 to 1.2, depending on a lot of other factors, what is the duration of diabetes, what is the initial HbA1c, all these factors also do play a role. And also, if you see across broad range of diabetes therapy, thinking about adding a gliptin to a SU, adding a gliptin to a TZD, or adding a gliptin to even insulin, we know that they have shown good efficacy. And you can see that if you use it as a monotherapy, we were talking about like 0.6 to 0.8, and then we talk about combinations as an add-on to metformin, add-on to SU. You can see here like 0.6, 0.4 drop. As an add-on to pioglitazone, like it's around 0.51, and triple combination also, you can see that the drop is persistent around 0.6 to 0.7. And also, this question is always asked, will they be effective in patients who are on insulin who have diabetes for 10 years? The answer is yes, because I showed you the mechanisms. They have multiple mechanisms, including the reduction of the glucagon. So they do work even in late stages of diabetes. And you can see, even with the duration of diabetes, whether it is less than 1 year, 1 to 5 years, or more than 5 years, gliptins have shown efficacy to the tune of drop of HbA1c of 0.54, 0.61 to 0.68%. And if you see the long history, even more than 10 years, you can see this data with linagliptin here. The patients did show a good glycemic efficacy with the HbA1c reduction. Now, the next question which comes to our mind is whether they'll be beneficial in patients who are high risk. High risk means what for diabetes? It is mostly cardiac and the renal. So we know that diabetes is an inflammatory disease. There is an endothelial dysfunction which starts even in the pre-diabetes and even before that, and it progresses. So we need to have drugs which have a good effect on the cardiac and the renal outcome, and at least they are cardio-neutral. So let us see the evidence of the DPP-4 in high-risk groups with type 2 diabetes. And we know that we have the data. We have the data from the TCOS. We have the data from the Carmelina with linagliptin. We have the data from Carolina with linagliptin, where they have been shown to be having a good effect on the cardiac and the renal outcome. So coming to the use of these gliptins in nephropathy, we know that when you talk about gliptins, for example, if we take here linagliptin, we know that it has shown efficacy across all stages of renal insufficiency. For this, we can use it without dose adjustment, but for other gliptins, we have to do the dose adjustment. For most of it, like for sitagliptin and Saxa and Vilda, we have to do the dose adjustment as per the EGFR values. But if you can see here, even to the stage of CKD5, you can see a reduction of 0.72%. And they are safe, also well tolerated. And in the MADLINA 2D type 2 diabetes study, they did see that linagliptin did improve the urine albumin creatinine response. There was a 20% reduction in patients with type 2 diabetes who had early signs of kidney disease. Now, if you see the Carmelina study data, we know that it was clearly seen that linagliptin delayed the progression to albuminuria. So you can see this graph here, and you can clearly see here that how linagliptin did delay the progression to albuminuria in the Carmelina study and reduction of the albuminuria. So in addition to the improvement in the glucose, there was a reduction in the albuminuria which was seen. So when you talk about the use of gliptins like linagliptin, we know that like from the Carmelina, from the Carolina data, we have understood that a big cohort of patients have been taken and they have been assessed and used. And these gliptins have been used in those patients. They took different sets of patients. Like if you see for the Carmelina, they took around 6,979 patients with established CV disease or CKD, and with the HbA1c between the 6.5 and 10. And in the Carolina, if you see, they took patients with relatively early type 2 at increased risk of cardiovascular event with HbA1c between 6.5 to 8.5. And you can see that there was a broad range of patients which were included in these studies, and it was shown to be efficacious and safe. And if you see across all the EGFR categories in the Carmelina trial, there was no difference in any of the other risk or the cardiovascular for the 3-point MACE or the hospitalization with heart failure or the composite kidney outcomes versus placebo on the kidney outcomes as well as the cardiac, that is the 3-point MACE across all stages of the EGFR categories. And now when we started off this talk, we all said that, yeah, the hypoglycemia is the thing which we are all worried about. Whenever we talk about diabetes treatment, that's always the question in our mind. And we know that with gliptins alone, the risk of hypoglycemia is very less unless they are used in conjunction with SUs or with insulin. So we did see that in the Carmelina, there was a similar rate of hypoglycemia with linagliptin versus placebo across, again, all the EGFR categories. So we did see that across all the EGFR categories, there was a reduction in the 3-point MACE, there was a betterment of the albuminuria risk or the kidney disease progression risk, as well as the hypoglycemia risk was not increased, because that's another worry in patients, especially beyond the CKD stage 3, where we are worried more about the hypoglycemia risk in those patients. And also, same thing in Carmelina, also the CV and the kidney safety profiles were consistent across all age groups also. So that's another thing, because we will also think about a higher risk group, which is an older group, because that's the group where we are worried that patients may get more hypo, they may get more side effects, and that was also not seen. And the overall or the severe hypoglycemic events in older patients were not different from the younger lot. So what we are trying to say here is it was consistently shown to be beneficial across all age groups, across all stages of CKD. So this we have already seen, that the CV and the hypoglycemic safety profile was across all age groups was consistent with its profile in the overall study population of Carolina. So it was consistent. It wasn't that it was different in a particular group or an older age group or the patients who were higher in the CKD stage. It was consistent across that. So then another thing which is always there in our mind, that we always think that SUs will be working better than the gliptins. But if you see the overall efficacy or comparison of the data here, we clearly saw that in the Carolina, that it was not shown to be inferior to glimepiride. So let us come to the case scenarios now, because we know that whenever we talk about the use of gliptins, what we have understood till now, they are pretty safe drugs. We need to modify dose of few of the gliptins with the CKD stage, and few of the gliptins like linagliptin we don't have to modify. We can use it across all stages of diabetes. They are effective across all stages, starting from the time when you're using it after metformin, or in a small subset of patients who don't tolerate metformin, like they have GI side effects, or they have some contraindication to the use of metformin, like EGFR is less than 30 at the outset. And you can use it to the stage when the patient is on insulin as well. There is some data to show that DPP-4 inhibitors may be more effective in an Asian cohort as compared to the other ethnic groups. And also we know that these drugs are pretty durable over a period of time. The average HbA1c drop may range from 0.7, 0.8 to 1.2, depending on the HbA1c we start with. And we can see an even better drop if we have a higher HbA1c. Now coming to a few of the case scenarios, like this is, suppose one middle-aged man with CKD comes to us, who is like around 50 years and has diabetes for quite some time, and has been diagnosed with CKD now, and was on a sulfonylurea metformin-based therapy. And these are the common types of patients who are referred to us, where now the EGFR is 18. So obviously we can't continue metformin. We mostly would think about withdrawing SUs, though we know that glipizide can be still used in a low dose, but we normally would avoid, because we know that we run the risk of hypoglycemia in this patient. So patient is on insulin, dialysis has been started, but still the glycemic control is not apt. Patient does not want to increase the dose of insulin, not interested to increase further shots. And now this is one type of a case scenario where you still find the glucose values a bit higher. We may say that 220 is not too high, but we would like to bring it better. He's going up to 300 in between. So this is another type of a patient who is a young person, who is like 38 years old lady, who has come to you, who is a busy person who is working all throughout the day, driving 8 kilometers to her office, and she has come to you and she was put on metformin. She was doing okay on metformin, but now her HbA1c has gone up, and we need to give something else to her to control her glucose levels. She's not tolerating glimepiride. We can understand that if the timing of the food is not maintained, or they are driving, they run the risk of hypoglycemia. We are always worried when we write SUs and we have a patient scenario like this. We always have this in mind, whether my patient will go into hypoglycemia while driving. It can be very dangerous also, and in Bangalore traffic, we don't even know for how long they'll be driving for 18 kilometers. So that's another thing. So this lady did not tolerate glimepiride, so her glimepiride was withdrawn. And what is the next best step. So these two patient scenarios from the audience, what do you think will be the best option in this patient scenarios? We can have different options, not necessary that we need to have gliptins only. So one option, I'll go with that, is gliptin, yes, but in this scenario, we can have other options as well. We can discuss, but if you see her BMI is 22, so she's a good candidate for gliptin because we want a weight neutral drug which has the least side effect profile with the least risk of hypoglycemia, better for her. If her BMI would have been higher, maybe 26, 28, I would have still discussed the option of SGLT2, GLP-1 analogs, maybe oral would be a better option for her. But gliptins are also one of the good options for her, for this lady in the present case scenario. And the previous patient also, because the EGFR is 18, we are already put the patient on insulin. We want some extra benefit. We want to give one OAD benefit. Patient doesn't want increase in the number of shots. Gliptin, again, would be a better option in that scenario as well. So gliptins work in all patients whenever it is indicated without change in the efficacy, ranging from CKD to a cardiovascular patient to an older patient. They are efficacious across all stages of diabetes, and they hardly have any adverse events. If we choose the right patient, we are pretty okay when we start gliptins. We don't worry much. And the efficacy has been proven as a monotherapy in combination with metformin and in combination with most of the oral anti-diabetic drugs. And gliptins which have an established kidney safe profile or the cardiovascular safety profile can be safely used, and they are one of the simple ways to manage. We know that diabetes cannot be managed with one drug, so it has to be a combination of drugs. So once we add some gliptin to metformin, over a period of time, we might need to add more drugs. But the question is that these are one of the safe drugs which we can definitely use for our patient scenario. So I will end with that, yeah, thank you.
I'm sure you all agree that it was a nice, exhaustive presentation on gliptins. And what she tried to highlight was gliptins do not carry the risk of hypoglycemia. They are durable medicines. They are effective in controlling diabetes, and it can be used in all stages of diabetes. As far as safety is concerned, they are quite safe, except for the SAVOR-TIMI trial, which showed saxagliptin increased the hospitalization for heart failure. And Carolina trial, the Carmelina trial, TICOS trial have shown that gliptins are non-inferior and they are safe in all the patients. Carmelina trial also showed that they are safe in patients with CKD and heart failure. Another thing is, gliptins, when it is combined with SGLT2 inhibitors, have shown to reduce the incidence of urinary tract infection, probably because they inhibit the DPP4 in the bacteria. So that could be an added feature. Thank you very much, doctor. It's always nice listening to you. We all enjoy your lectures. Thanks a lot.
Thank you.
If there are any questions, please.
You mentioned about one case, this thing scenario. How about using this alpha glucosidase inhibitors?
See, in the first patient, no, because that patient's EGFR is 18. Already in those type of patients, they already have so much of nausea and all those problems. DPP4 is the choice. In the second patient with a BMI of 22, a young patient, a DPP4 inhibitor would be a good option. Alpha glucosidase inhibitors can be used if you are targeting particularly the post-breakfast or the post-lunch or whichever time of hyperglycemia. Can be a good option, but you might have to give twice a day dose or something, and you have to see she tolerates. So if she tolerates, yes, that option can be discussed because they also take care of the postprandial hyperglycemia. But gliptins can be a good durable option because once a day dose can suffice for most of the gliptins. Some of the gliptins we need to give twice a day dose, but they mostly do well without much side effects. This lady who is a busy executive, a lawyer who is working, driving, DPP4 would be a safer bet for me rather than alpha glucosidase inhibitor, but alpha glucosidase inhibitor is not the wrong choice. Can be used, but you might have to give twice or thrice a day dose. Only one time may not suffice because she may be having postprandial, post-lunch, post-dinner hyperglycemias as well.
Thank you.
Madam, the usage of gliptins has been there for almost 15 years now. Benefits we have seen, and added benefits we have heard from you now, with all those trials that have come up. But is there any chance that maybe these gliptins are causing a little bit of hyponatremia cases here and there.
Not exactly, because most of the times whatever data is there, they are pretty safe. Until unless, see what happens, many of these diabetic patients are also on diuretics. I would say we should worry more about untreated hypothyroidism, thiazide diuretics as the cause of hyponatremia rather than gliptins, because most of the data which has come up has shown an excellent safety profile, I would say.
I've had 2 patients recently, in the last 4 to 6 weeks, I would say. Both these patients were diabetics for almost 20 years, not on any diuretics. They are not hypothyroid or hyperthyroid individuals.
Yes, then
and I have seen they end up with hyponatremia once in every week, 10 days.
Yeah, so then I would say we should go, see, if you are telling a long-standing diabetic, I would think of CIAD, because they all have multi-infarcts. These patients have a high propensity to get CIAD. So we have to see the urine spot sodium. Now, if that patient is having more urine spot sodium and it is going in favor of a diagnosis of CIAD, the serum osmolality will do, because this type of a patient scenario which you are telling who come with hyponatremia, if it is not untreated hypothyroidism, it is not thiazide diuretics, and the investigations are favoring CIAD, then this would be more of a CIAD rather than a hyponatremia caused by a DPP-4 inhibitor. And a long-standing diabetic, a very common scenario is they'll have multi-infarcts. And these are the patients who commonly come with CIAD type of picture. So that's more of a possibility in this case rather than a DPP-4 induced. But I would like to investigate this patient and then take a call.
I would like to tell what I have done. I stopped gliptin. And last 3 weeks, he has not had even 1 episode of hyponatremia.
But how many times he had the hyponatremia?
Last 1 year, he has been having.
Last?
1 year.
1 year he had multiple episodes? Unlikely, but to attribute only to this. But yes, I would also like to see the other drug scenarios, because if there was some concomitant drug which was causing CIAD, because many times it happens, there are other concomitant drugs. And we think that this was the drug, but there was a possibility that the other drug might have been also removed. Not the thiazide diuretic, but drugs which can cause CIAD. So those drugs also need to be seen. So I would still like to go back, review the whole drug history, see what exactly was the scenario, and see the investigations where it was favoring something else. Then I would be comfortable in telling that whether this was not CIAD.
Thank you, ma'am.
Time constraint, I think we'll stop the questions.
Just an add-on answer to the gentleman with alpha-glucosidase inhibitors. By delaying carbohydrate absorption, they may have a modest TPP-4 inhibitor-like benefit also. Anyway, I would like to request Dr. Amal Selvam to felicitate both our faculty. So now we'll move on to another endocrine organ which is very important and a very important clinical scenario of pregnancy. So I would like to invite Dr. Guru Prasad Udupi, consultant from Bangalore, to chair the session, and the speaker for this session is Dr. P.K. Jabbar, consultant endocrinologist from Trivandrum, and an interesting topic. I would like to thank Dr. Jabbar for changing the topic, and I always say we should provide variety. So he said, okay, I'll talk on approach to thyrotoxicosis in pregnancy. Very, very important entity. I'm sure it will be very, very useful to our day-to-day practice. Welcome, sir. And over to Dr. Guru Prasad, consultant diabetologist. He has his own healthcare setup, and he does a lot of work, and we keep interacting on many fronts. Thank you.
Good afternoon, my dear friends and colleagues. At the outset, I would like to thank the organizers for giving me this opportunity to chair this session. And the topic is quite interesting, the approach to thyrotoxicosis in pregnancy. And to give a brief introduction, in pregnancy, there is an increased need for thyroid hormones. So we have this player HCG, which has a structural homology to TSH and thereby stimulates the TSH receptors and causes increase in thyroid hormones. But in certain circumstances, this can exaggerate and can cause what we call as transient gestational hypothyroidism. So at the same time, we have other pathological entities playing around. There could be Graves' disease during pregnancy, either the pre-existing or the new onset, or we can have certain rarer conditions like toxic nodules or trophoblastic diseases. So as a physician, it's very important for us to know how to and when to evaluate these different entities in a pregnant lady. So to enlighten us, we have a very enlightened, very reputed speaker, Dr. P.K. Jabbar. He has a lot of publications to his credit. He is a director and chief executive officer at the Indian Institute of Diabetes Trivandrum. And in fact, he had recently edited a book on Ramadan and diabetes. Unfortunately, I had contributed a chapter in that book under Dr. Harish Kumar, head of the department, Cochin. So over to you, sir.
Good morning, respected chair, senior members, Dr. Pramila, my colleague, friends, ladies and gentlemen. I'm extremely happy to come to this beautiful place and to give a different topic. Okay, so I think it's everywhere diabetes and diabetes, right? Now we'll change the topic to thyroid. Now my first agenda is special thanks to Dr. Manohar and Disha Group for the excellent and wonderful opportunity, and About Pharma also Mr. Jitu. And topic second agenda is I'll be discussing certain epidemiological data. What is going to happen in pregnancy? How do you manage pregnancy in thyrotoxicosis? What are the problems which we had at Trivandrum Medical College? That's my plan of action for today here. So these are all probably, see, my usual word is faltu slides, epidemiological slides. But one thing I would like to share with you, this is the data from my own institute, Came Hospital. The prevalence of thyroid disease is such a common problem. See, if you look into the data from any country, hypothyroidism, subclinical hypothyroidism is a huge problem. Whereas thyrotoxicosis in pregnancy, probably somewhere around 0.6 or 1%. That's what's happening. And mind you, even this 1% of the problems are real clinical enigma or clinical challenge for a practicing physician. Now, these are the basic slides. Just to only one or two sentences. You have syncytial trophoblast of placenta, which produces HCG, which has got a structural homology with the TSH. So what is going to happen is HCG is going up because of it's produced from the syncytial trophoblast of placenta. And because of the structural similarity, the HCG will come down as in like this. So HCG is coming down, HCG is going up and TSH is coming down. Because of these important physiological alteration, T4 and T3 is also increasing. That is what is going to happen. And the binding globulin is also increased. So eventually what will happen, if you look into the T3 and T4, that level will be high. Apparently you will become panic because see, apparent values are thyrotoxicosis. Mind you, just look into the history of the patient. If the patient is pregnant or if the patient is taking some other drugs also, that possibility you should keep in mind. This is what is going to happen in normal pregnancy. So these are the changes in T3 and T4. By and large, all these values will be normal range, or if you take total T4, that will be elevated. So if the upper limit is 100, that may go up to 140 or 150, something like that. That physiological alteration, please remember, because I had a very bitter experience in Trivandrum. One of the VAP's wife got admitted for delivery. See, that time, sir, see, they thought, if they will go for cesarean section. One poor house officer, she did T3 and T4, it was quite high. That situation became little panic, right? It's a VAP's wife. So they called me. I was sitting in some other city. I had to fly to Trivandrum to see these patients. It's only physiological alteration, which is very common. Any ladies, and if the patient or if the individual is taking oral contraceptive tablet, also this type of changes can occur. So please remember, if you read the thyroid function report, just look into the sex of the patient and age of the patient, because neonates also and pediatric age group also you can get lot of physiological alteration that is not pathological. Please remember that. Now, what will be the effect on pregnancy and Graves' disease? The first trimester, little aggravation of symptom will occur. That's because of HCG. And second trimester, that aggravation will come down. In the third trimester, the significant reduction immediately after delivery, you will get exaggeration of the thyroid status. That is what is going to happen. All these things are important if you choose the molecule for the treatment. Now, we'll discuss. There are two important differentiators. Suppose you have a patient. First trimester, there are two diagnoses. One is simple physiological gestational thyrotoxicosis. That could be a Graves' disease also. Let us read this history. So patient gravida 2, lot of non-specific symptomatology, and somebody asked for thyroid function test also. You can see the thyroid function test here. T3 is little elevated, FT4 is also little or probably high normal level. And unfortunately or fortunately, TSH came down to 0.09. So we got frightened, or so we got little upset. So is it a gestational thyrotoxicosis or is it a Graves' disease? These are the differential diagnosis for us. How to sort out the issue? Clinical profile, probably useful, but it definitely is useful. See, this is the commonest situation. The gestational thyrotoxicosis is the commonest issue, and you will have mild symptoms. Most of the time, patient will give a history of persistent vomiting, okay, and weight loss. That's a clinical picture. Clinical picture always, or most of the time, you'll get the answer, but sometimes difficult. So what are the investigation? All these investigations are useful. Mind you should be very careful if you are interpreting these reports of the thyroid receptor antibodies. Fortunately, that was negative in this patient. What is the role of nuclear scan or nuclear pharmaceutical studies? Absolutely contraindicated. Absolutely contraindicated. Okay, absolutely contraindicated. So you have another method, the Doppler study also it's available. Doppler study, what will happen is if you have a good sonologist trained in assessing this type of patient, you can give a reasonable assessment of the blood flow, and you can pick up the Graves' disease in a case of suspected thyrotoxicosis. Okay, this is what is going to happen. If the thyroid artery velocity is significantly elevated, that indicates mostly you are dealing with a Graves' disease, not gestational thyrotoxicosis. My dear friends, it's very easy to discuss like that, but in clinical practice, extremely difficult. Then what will you do? That's a problem. Practically, you see, you're a physician, you want to do something for this patient. So such a situation, all these investigations sometimes equivocal under your supervision. Please remember, under your supervision, probably you can give treatment also, provided the patient has got other features which can suggest a diagnostic label of Graves' disease. Mind you, it's an absolutely benign situation. After 20th week of pregnancy, see, you will have resolution of thyrotoxicosis. Now, second agenda, when to treat, why to treat, which drug, is it propionate or other drug, how long you want to continue, and what will be the effect on fetus. We'll look into that. So basically, you are dealing with two lives. One is baby and second is mother. So you should be very careful. So this data is very clearly showed if you have treated, fully treated thyrotoxicosis, euthyroid, all these complication rates you can reduce by giving proper treatment or appropriate treatment for thyrotoxicosis. I think it's very, very important to remember this fellow who only described antithyroid drugs in clinical practice. Now, what are the pharmaceutical changes between PTU and carbimazole or methimazole? Basically, please remember that both drugs can transfer or shift to the fetal compartment also, but the gradation is important. So if you are using PTU, less amount of the PTU is transferring to the fetal compartment. So theoretically speaking and practically also the complication rate is significantly reduced if you are using PTU. Now these are the probably very primitive paper. It's a long back. The rat studies showed in a little transfer of PTU from maternal compartment to fetal compartment, and subsequently we got lot of papers. Human studies also showed the PTU crossing is negligible and carbimazole transfer is a little significant. So that is a conclusion that so probably in the first trimester of pregnancy, that to see before completing the organogenesis, the treatment of choice probably PTU. Now, so far, in first trimester of pregnancy, PTU is a treatment of choice for thyrotoxicosis or Graves' disease in pregnancy, because if you are using this PTU before completing the organogenesis, probably the risk is less. So a number of complications have been described in the literature with the other drugs also. But don't think that as a PT is absolutely safe. So these are the various complications. Aplasia. See, what I want to tell you, my teacher, Dr. Bhandarkar, he did not see a case of aplasia cutis with the neomycosal treatment, corneal atresia, and omphalocele. A number of complications, probably dozens of complications have been described with the antithyroid drugs. Now, this is the classical phenotype of antithyroid drug-induced changes. Now, my dear friends, so far I was discussing so PTU in the first trimester, right? Say, but don't think that PTU is an absolutely benign molecule. PTU can produce liver problems. Acute hepatic failure also is possible. Okay, I will discuss one case which happened in Trivandrum Medical College Gastroenterology Department. 20th week of pregnancy with a diagnostic label of hyperthyroidism. This was the picture. Patient was having classical thyrotoxicosis. Okay, liver function was okay initially, and somebody had given a beautiful prescription of PTU and carbimazole. Don't laugh at the prescription. These things are happening in our clinical practice. At least in Trivandrum's happen, right? Okay, patient came to our department with a lot of metabolic encephalopathy in the form of acute hepatic failure. Patient was drowsy, jaundice, tremor you could document, or you can call it as flapping tremor, and patient was having a diffuse goiter also, and patient was clinically toxic, difficult to say. So this was a picture, and we thought we'll go for some other drugs, like say alternative drugs in the form of dexamethasone, lithium, with difficulty, propanol, and cholestyramine. These are the treatment given for the patient at that moment. And we thought, why don't you go for radioactive iodine treatment also? It was not easy. Patient was in ICU. We can't give because the technical problem we could not give. So we had a medical board, and we decided to go for plasma exchange. We did plasma exchange for this patient. This was a picture before giving plasma exchange. After giving multiple sittings of plasmapheresis, patient thyroid status became normal. Almost he became normal, but she finally succumbed. So what I want to tell you, my dear friends, please remember, if you are giving PTU, anticipate other complications also. You can think about organogenesis and congenital abnormalities also. PTU, please restrict the use. Be careful with the PTU. But so far, we did not see a lot of cases of hepatic failure, but that's theoretically and practically is possible. Now, that's the reason that this is FDA. So, severe liver injury and acute failure, hepatic failure with the PTU, fetal abnormalities associated with methimazole, and PTU may be preferred. Now, people are thinking that, even obstetric and gynecology colleagues are thinking, why don't you go for methimazole or carbimazole? People are thinking like that. Okay, so as the thing stands, Alexander or American Thyroid Association recommendation, PTU is a drug of choice in the first trimester of pregnancy. That's a message. So if you see all the recommendation by ATA, College of Obstetricians, Brazilian Society, Endocrine Society, by and large, they feel that the PTU is the best line of management in the first trimester. And if the patient is taking PTU in the first trimester of pregnancy, when they complete the first trimester of pregnancy, shift to carbimazole. That is the current thinking. That is what we are practicing now. This is a recommendation by Indian Thyroid Society and obstetricians also. The recommendation number 1 for overt hyperthyroidism during pregnancy, thianamides are the treatment of choice. And PTU is recommended during the first trimester, followed by switch off to other drugs in the second trimester. That's a recommendation by ITS. Now, surgery is indicated if the patient is showing resistance in the second trimester, but it's very, very rare. Probably you can ask the opinion of Dr. Pramila also. Very rarely, I think in KM Hospital, we did not do, even the Trivandrum Medical College, we did not do surgery for thyrotoxicosis in pregnancy. And regarding the monitoring also, what are the tools you should look for? One is your T3, T4, or if the lab is good, FT3 and FT4 is good, and you try to maintain high normal level. That is your target. And second molecule or method is TRAP or TSH receptor antibodies. What are the situations you will ask for TRAP or TSH receptor antibody? You take a patient, Graves' disease, on treatment, becoming pregnant today. So such type of patient, definitely you should go for antibody. Those who had treatment with iodine 131 or thyrotoxic surgery, there also. Another scene comes, Graves' disease, fully treated, very happy. Now, after some time, she is becoming pregnant. There is no need of looking for TSH receptor antibodies. Mind you, these TSH receptor antibody has got its own limitations also, which also you should remember. Now, let me discuss one more case for today. A very young lady, 26-year-old, primary gravida. As usual, diagnosis of Graves' disease was given during first trimester of pregnancy. As usual, PT was started, subsequently shifted to neomacrozole. Patient simply disappeared, and patient came to our department with absolutely normal, but a small goiter was there. This was a picture. Patient already developed the drug-induced hypothyroidism, as evidenced by, you can see the TSH value of 31.2 microinternational units, and fetal goiter was picked up. And TRAP or TSH receptor antibodies was strongly positive. In such a situation, it is mandatory to look for the fetal status also. We looked into the fetal goiter. Fetal goiter was positive. It was very significantly elevated, and baby was in the hyper-extended phase. So this was a picture. Those who are the interested in ultrasonogram of fetus, you can look into that. And fetal goiter doesn't mean the patient's thyroid status is euthyroid, hypothyroid, and hyperthyroid. How to sort out? You can't go for invasive measures, cordosynthesis, amniotic, all those things are not possible during pregnancy. Simple method, as per Dr. Susan Mundell, is look into the mother's thyroid status. So if mother is hypo, that indicates probably fetus is also hypo, and mother is the active Graves' disease, not controlled with antithyroid drugs. Think about the possibility of hyperthyroidism. Hypothyroid mom with a history of Graves' disease after surgery or iodine ablation, think about the possibility of hyperthyroidism. So these are the simple method in Bangalore or Kerala or any other city. Cordosynthesis probably is not routinely practiced in our patients. So if the facilities are available, yes, you can go for that, and you can assess the thyroid status appropriately. You can give treatment also for thyroid disease in fetus. Now, what we did from Trivandrum Medical College, of course, we stopped neomacrozole, and subsequently patient became normal. Even the baby is fine. The last week also, patient came to my OP, very absolutely fine. So what I want to tell you that if you are giving drugs for thyrotoxicosis, please educate the patient, try to call the patient to assess the thyroid status, and don't forget to assess the fetal status, and appropriately you should look for TSH receptor antibodies also. Another crucial question I'm going to ask you, is it possible to stop treatment for thyrotoxicosis in pregnancy? Theoretically, yes, it's possible, because in the last phase of pregnancy, antibody or the immune status is okay, and if the patient is taking very small drug, like in a 2.5 milligrams or 5 milligrams of neomacrozole, and no goiter and short duration of disease, and patient showed good response to treatment as evidenced by normalization TSH and T4, T3, yes, you can. This is a recommendation by Alexander, American Thyroid Association recommendation number 46A. So certain situations you can, but mind you, my dear friends, if the patient goes for thyrotoxicosis again, that will be a problem. So the physicians think that you can give very small or small as possible dose during pregnancy. Okay. Now this is a recommendation by ITS, Indian Thyroid Society, feel that women on very low dose of antithyroid drugs, 80 antithyroid drugs may be stopped. There are recommendations. If you are stopping it, you have legal support also. But mind you, certain things, sometimes you'll go wrong also. But mind you, monitoring is very important. And you call the patient for monitoring, for assessment of the thyroid status, probably after 10 or 14 days after stopping the treatment. There are future treatment also, not for me, for my grandchild. Okay, so these are the drugs available. You can just think about that. Probably this at 2032, they'll be discussing the newer treatment for the thyrotoxicosis. My dear friends, ladies and gentlemen, let me conclude with the take-home messages. Gestational thyrotoxicosis is such a common situation in our clinical practice. Most of the time, treatment is not needed. Only reassurance is a treatment. Graves' disease, if you are dealing with the Graves' disease, you need to go for a supervised multidisciplinary approach. PTU is preferred in first trimester. Both maternal and fetal monitoring is very, very important in clinical practice. And after delivery, just think about the government policy, Salabam policy. Look for the thyroid status. You can pick up hypo or hyperthyroidism in baby. That's all from me. Thank you very much for the kind attention.
Thank you, sir, for that enlightening talk. So the take-home message would be, we have to be very careful in differentiating the physiological, the transient gestational hyperthyroidism from Graves. And the TRAB should be used, the TSH receptor antibodies, and not the radionuclide scan. And first trimester, if you are using, it's a propylthyroxine, but be careful about the fulminant hepatic failure. And second trimester should be the carbimazole and methimazole. But please be sure that you are monitoring the fetal heart rate and fetal goiter. So thank you very much for this. Any questions?
People will ask questions for diabetes talk, okay, not for thyroid talk.
Sir, are there any case here, any case reports of this post-pandemic, any COVID-related subacute thyroiditis?
I think it's very
particularly in
common now.
pregnancy, we are seeing more.
Pregnancy, I'm not very sure. See, COVID-related thyroiditis is very common. There are a lot of articles also coming up in a big ways. Even the Lancet of Endocrinology last month also we had a lot of discussion. Very common situation. We have seen VAPs also. That's a most real issue for practitioners and administrators like me. Thank you very much.
So I think along with the physiological and Graves in this pandemic, I think we have to keep thyroiditis could be one of the leading cause maybe later on.
Possible, sir. Pregnancy, the problem is differentiating between these two is not that easy. Only clinical or time will tell you the final diagnosis. That's the problem.
Sir, in one second one you said it is hyper. Third one you said after ablation and
because
surgery.
now what is happening, say after iodine treatment, iodine 131 treatment, TRAB is the issue, right? Okay. So theoretically, this TRAB can stimulate the thyroid gland of fetus that can produce hyperthyroidism. That's possible. Yeah, see, it's very clearly written here. If the requirement of antithyroidic is small, okay, what is written in the textbook is 5, but we used to discuss 2.5 milligrams. You can ask Dr. Pramila also. And we are all giving very smallest possible dose for maintaining euthyroid. So if the requirement is very small and your thyroid profile is very good, even TSH shows good recovery, no goiter, no ophthalmopathy, okay, TRAB is negative. Such a situation you can. But it's a double-edged weapon. Sometimes you'll burn your finger, but you have a legal support from various professional forums. No, I think, see, you are stopping in the last phase of pregnancy. Even it's 10 days or 14 days, I think that should be the duration. Now, what we are doing, say, to Antrim Medical College, we don't any hesitation to look for thyroid function test every month because of pre-treatment. No, we are all going for T4. T4, and say, of course, in a hospital, there are two methods. One is under superintendent care and my control. In my laboratory, we used to go for FT4, and general patients will go for T4. T4 has got its own, like, credibility. Okay, FT4 in a different lab, we can't say, but both are acceptable. I would say again controversial question. Some people saying that so fasting is preferred. That's all, right? Okay. Even if the patient comes after food, there is no much issue. And like say, I did not take आज गोली नहीं लिया था. इसका TSH elevation and all. These are all absolutely like say, it's not really useful. Any time you can take it. We should look into the acceptance also by patients.
I think we'll wind up the session. Thank you, sir. Thank you once again.
Thank you very much.
Request Dr. Haim to felicitate both the faculty. Thanks for a power-packed talk, sir. It was really, it's not the end of the day, but pre-lunch, I don't think anyone would be dozing off after that power-packed talk. But what next now? If you are to keep that tempo going, we need to have an equally power-packed performance. And we won't disappoint you. A person who is as steady as an elephant and thinks like a cheetah. Yes, that's the topic that's given to Professor Basavangodappa, sir. Doesn't need any introduction in any forums. And I would request Dr. Suman, my friend and chairman of the Karnataka RSSDI and CEO of Madhumeha, to chair this session. And the topic is elephant and cheetah approach in managing postprandial hyperglycemia. So over to Basavangodappa, sir, and Suman can do the needful.
At the outset, I'd like to thank Disha for this wonderful opportunity. Well, it's quite interesting talk. And I really don't know what made Manohar to put it as elephant and cheetah. Is it because Mysore House zoo and probably in zoo a lot of cheetah and elephants are there? Or is it elephant means the cost of the treatment and cheetah means the fastest of the treatment is what it means? But anyhow, Dr. Basavangodappa sir requires no introduction. He's a professor of medicine and principal of JSS Medical College. And he's a dean faculty of medicine and JSS University. So over to you to elaborately explain to us what does the elephant and cheetah means.
Good afternoon to all of you. At the outset, I thank Disha team for giving me this opportunity to stand before all of you and make my presentation. These are my credentials. Greetings from JSS Medical College, Mysore. Disha team has been doing so well, and I'm seeing a lot of milestones beautifully depicting their activities, and I wish the team to do many things, and all the best for the entire team. And there's a blend of very enthusiastic youngsters guided by Sanjeev Rao and then the youngsters who are taking it very forward. Don't get flabbergasted by the title. The title, I am talking on two molecules which are known to you, digging into some depth of newer knowledge for the last more than 1 decade. And any diabetes forum, you will only keep hearing those aspects. But I'll take you back to what has been evolving 2 decades back or so. Cheetah is the fastest elephant on the earth. Powerful brakes. It can adopt the speed very, very quickly, which no vehicle can have that kind of activity. Very rapid, but it is only transient. It cannot sustain for a longer time. It cannot keep running. If animal has to escape, make it keep running. It will end up an animal on the land, one of the largest. These are the only attractive things about the title. Okay, so rest, I'll leave it to you. I have deleted some of the slides, and then there is increased burden of diabetes in young age kids earlier when we were type 2 diabetes never increased. And we all know about all these things. Management process of just looking at the molecules which are available can be modified to reasons why younger and younger described was dietary component. Visceral adiposity. Having said this, the prelude for L2 is because the Indians have a different diet habit. Several studies have ultimately summarizing to say, West, Central, what is our carbohydrate content? 64.1% average. That means we are different from rest of the world. In fact, that makes me postprandial hyperglycemia, which has been spoken to, all of you might have heard on several occasions. We all know the target values. We want to keep 30 and peak postprandial acceptable PPG, the capable glucose of the 180. Natural history of diabetes, the fasting starts rising, markedly exaggerated in diabetic population, liver and peripheral tissues. And we all know the triangular fight between the gut, the liver and the pancreas failing because of DIP4 enzyme, which gets exaggerated in diabetes, and higher hepatic glucose production of postprandial sugar when compared to fasting sugar in determining the HbA1c of an individual. It is between 7.3 fasting, the HbA1c is 7%, but his postprandial sugar will be uncontrolled sugar, and that's why we are now talking about with fixing the fasting fast. That was the earlier concept. Now we know the importance of postprandial sugar and relative contribution of postprandial sugar had PPG more than 180 in the range of uncontrolled, with the A1C being just around 7.5. And what is the impact of postprandial hyperglycemia? Why should we worry about that? It is very, very clear when there is glycemic excursion enhancement and oxidative stress gets enhanced, vulnerably making the vascular injury to be very profound. Each time you eat, there is a surge, is vascular injury prone entity. Just read the highlighted points, make you to understand we should not be happy with A1C 7%, should not be happy with just FBS, PPVS calculated. Ask them randomly to check their post-meal, post-lunch, post-dinner. Threefold increase in retinopathy with a higher PPH. Incidence of diabetic neuropathy is high, and twofold increase in the mortality with CAD, and 17% increase with 2-hour PPH blood sugar in the rise of 18 milligrams of postprandial sugar. All these are evidence-dependent risk for MI and cardiac death. Intellectual functions get deteriorated when your postprandial sugars are high, more strongly associated with CIMT. So what is combination of enhanced oxidative stress, enhanced insulin resistance, inflammatory process, ultimately culminating to endothelial dysfunction and vascular injury and outcomes. Now, how do we manage this? Both the quantity and quality of carbohydrate that is important, very, very important in this thing, and all these are evidences to say how important it is to cut down carbs from 64.1% in the Indian average diet to 45 to 50% or less than that. It makes enormous difference in terms of your therapeutic outcomes of whatever molecule that you're going to use in controlling that. These are all the evidences of importance of cutting the carbs to around 45% from 64% in the average Indian diet across the country, north, south, east, west. And how do you manage that? Of course, having learned today morning's talk, non-pharmacological therapy, the diet. Suitable diet to improve or modify your microbiota. Suitable diet which can have less easy carbs and more fiber and physical activity. That is a dictum for everything and more so for preventing postprandial spikes. Pharmacotherapy, isolated or in combination. And then, of course, self-monitoring is very essential. Don't be happy if he always walks in with his fasting sugar was very fine. 85, sir, 90, 95, 100, always 110. But he has never checked post-lunch, never checked post-dinner, which is always 240, 250. Believe this is very commonly happening in Indians because of PPHG is not, it is unmasked because they don't check it. Self-monitoring is very, very important. That enhances the clinician's adaptability to modify the treatment and screening tests and then so on. And that is what is important. And we need to know non-pharmacological measures, pharmacological measures, and if pharmacological measures, what do we choose? Now, we can control blood sugars by using any of these drugs in isolation as a monotherapy or in combination. Each one of them have their own way to control blood sugars. They control A1C, they control fasting, they control postprandial. But when we are talking about targeting the normal fasting but higher postprandial, we need to understand the differences in the molecular effect of these drugs which are available with us in a given clinical situation. So the glinides, which is cheetah, and the alpha glucoside inhibitors, which is elephant, may be playing a role. When you get them married, they may do better for control of PPHG. The glinides, we all know, they are non-sulfonylurea secretagogues. They work differently because they induce calcium influx dependent exocytosis of insulin containing granules. The binding site in the specificity is different from sulfonylurea. They act differently, though they also work like a secretagogue, but they work in a different way because of different site and which is transiently lasting. That's why if you ask your patient to take this drug when they take a meal, it works like a glucose-dependent molecule. Like your DP4 inhibitors and SGLT inhibitors, they are not hypoglycemic agents. They are anti-hyperglycemic agents. They work on glucose-dependent manner. But all secretagogues, they don't work on glucose-dependent manner. Whether you want it or not, they go and secrete insulin. But you shut down transiently like a cheetah. Rapidly works for a short time, doesn't produce hypoglycemia like sulfonylurea. That is cheetah effect. Then the insulinotropic effect, faster onset of action for peak insulin release than glumenclamide or glimepiride or glycoside. So insulin release is glucose dependent, which is not true with sulfonylureas. And that's why we call it as cheetah among the secretagogues. And clinical trials have proven beyond doubt that improved fasting insulin levels and postprandial insulin levels and beta cell function with a definite reduction in the PP glucose levels with this molecule when it is taken with meal. There are evidences to prove that, and there are umpteen evidences to that effect. Efficacy of preprandial dipoglycinide compared to with a placebo, definitely A1C reduction as well as fasting and postprandial reduction is significant, and similar effects are seen in several studies. The range of glucose reduction, the A1C reduction would be anywhere between 0.5 to 1.2. Though these two drugs are not very strong hypoglycemic agents, they are milder ones, but they are working in a situation where your PPHG has to be handled and where your Indian diet, where you continue to enjoy a carbohydrate, but you want a molecule which works for you. That is the evidence that is there. To compare it to tolerability of ripaglinide in type 2 diabetes, when compared to sulfonylurea, there is relatively better tolerable in terms of all these things which are listed here. So RIPA works as a better secretagogue for a given transient time for a prandial glucose control or postprandial surge control. And coming to the elephant, the AGIs, the oglibos, we all know when we eat, the first thing that happens is there is a quick breakdown of disaccharides by your alpha-glucosidase enzyme, which breaks it down quickly to monosaccharides and glucose, and that is what happens. A surge of sugar postprandially happens because of this enzyme effect. If you inhibit this, the consequent breakdown is delayed, so naturally glucose absorption is delayed, it slows down. It doesn't walk like cheetah, it walks slowly but steadily, elephant. So this is the evidence for that. With oglibos, you can see higher disaccharide content below the small intestine entering at the last portion of the intestine. Without AGIs, look at this. Most of it gets absorbed, broken down by alpha-glucosidase. All complex carbohydrates are broken down to monosaccharides and glucose, and it surges floods the blood, and that's why you have a postprandial spike, which is very abnormal in diabetics when compared to normal non-diabetic individual, which can be taken care by inducing or inhibiting the alpha-glucosidase enzyme. That's how it acts. It is a basic pharmacology that we all know. So when you look at the several study data, more effective than placebo naturally, and more so in a Indian patient who eat a lot of carbohydrates. That's why, though alpha-glucosidase inhibitors may not be enjoying their profile elsewhere in the world, but it has a place in Indians because our diet is different than Americans or Europeans and so on. And these are all the several evidences to prove that, and the evidence in published articles in DMJ. And this is the evidence to say what would happen if you give only metformin monotherapy when you combine with Oglibose with metformin, this is the distinct difference that happens over a period of 24 weeks. You can see the diverging curve as early as 4 weeks and sustained effect when you combine the Oglibose with metformin. So this is the evidence to say the reduction in fasting, postprandial and A1C. Other reports about Oglibose on metabolic profile in type 2 diabetics, overall effects on fasting, A1C, and more so the postprandial is significantly higher with a neutrality on the lipid profile. So what are the advantages of Oglibose and what are the disadvantages? It is a limited with little or no risk of hypoglycemia, Oglibose. It is a weaker anti-hypoglycemic and it is going to work for those who need it. And individualized titration is possible and negligible renal excretion, so you can safely give till the last part of the renal disease. It can be given as a monotherapy or it can go with any antidiabetic drugs. Okay? Whereas the disadvantage is that it is milder. You don't expect miracle reduction of A1C. But it does reduce PPHG much better than any other molecule. GI side effects are the only bothersome problems with Oglibose. There are rare cases of pneumomatosis cystoides intestinalis, which is very rare thing to happen. Having said this, when you combine or marry a cheetah with elephant, fixed dose combination of Oglibose and repuglinide are available in the management of postprandial hyperglycemia for Indian patients because we are different in our dietary styles. So this would happen, this is the evidence. Mean postprandial the glucose is reduced by 61 milligram percentage on average over a period of 24 weeks or 30 days, as well as that. Then mean fasting glucose also comes down by 42, much more profound effect on PPG than fasting. And then also the reduction of the sustained reduction of postprandial glucose over 30 days and 90 days to this effect. And the A1C reduction also from 7.9 to 7%. As I told you, it's not a very strong hypoglycemic agent, but does reduce anywhere between 0.5 to 1% of A1C. That is what is seen in this the study. So mean fasting also comes down, and ultimately percentage reduction of fasting, postprandial and A1C is well seen. Dear friend, there are several evidences of combination therapy of Ripa and Ogli. What happens on A1C, postprandial, and what are the adverse reactions? The key understanding is that it significantly brings down postprandial blood sugar, which is the key problem with Indian diabetics. Having understood this, let me take the last slide to take home message. Now we have understood, we've been understanding the importance of postprandial glucose as an independent risk factor for cardiovascular complications in diabetes. And don't ever be happy with A1C or be happy with normal fasting sugar. Please have a look at now and then on postprandial sugar. It is a better predictor of glycemic control than fasting plasma glucose. Patients who are seemingly well controlled with diet, exercise and medical therapy, even those with normal fasting sugar, with normal HbA1c, could have an uncontrolled, unacceptable postprandial sugar. That is true with Indians. Repuglinide is a rapid and short-acting insulin secretagogue which work. Oglibose is an enzyme inhibitor with a longer duration of action which retards the carbohydrate absorption. The ideal treatment for patients with type 2 diabetes should include a combination of cheetah and elephant to control if your patient is having predominant bothersome postprandial hyperglycemia with a normal A1C, with a normal fasting sugar. A combination of this would do better. And I thank the Disha for giving me this opportunity to make presentation different.
Yes, sir. Thank you, sir. It was really elaborated and very nice presentation of telling that not just the fasting, the postprandial is also very important. But no doubt, whether we have an elephant, we have a cheetah, but still we always have to have a human to put it in place because it's the human who always relate to a lot of things. And it's a human who can really marry elephant and cheetah, but not together. Thank you for that.
We have been having such wonderful molecules in treating diabetes, like especially as I told you, the last 1 decade is the decade of DP4 inhibitors and SGLT inhibitors, and they have done wonderful. Not adequately control your PPHG, and there we can pray for one of these or combination of these. Yes, sir.
Sir, this is regarding, can this combination which you are specifying for Indian patients be used prophylactically when they are due to attend functions, marriage, munji, etc., etc.?
Of course.
Or is it a continuously given drug when you have documented postprandial hyperglycemia?
Now, my presentation is basically focusing on the patients' sectors who are really bothering a clinician to coming with, if they are coming with a self-monitored blood glucose levels done, 5 points or 6 point blood glucose done, you always see fasting being very happy, he's very happy, but he's unhappy because his post-lunch, post-dinner is shooting up. These are the individuals where this combination will work wonderfully. If answer your first question about can they be used prophylactically for dinner before a function, my answer is yes as well as no, because it may not be an ideal advice that we can give them, but it may work on one and it may not work on another. But if you look at the people with IGT or pre-diabetic state, there was a study as long ago, stop diabetes study, but acarbol also helped in preventing or postponing onset of diabetes. So if that is true, that taking the analogy, it may be working in some individuals to prevent the surge postprandially, but it will not prevent the overall glucose load if he goes and eats a lot of sweets and a lot of indulges in a lot of calorie intake. It may surge the sugar overall, may blunt expected surge of postprandial.
I think this is an excellent molecule in the month of Ramzan also.
Okay.
During Sahri and Iftari time. And there is a gap, of course, of 16 to 17 hours. So due to the fear of such a big gap, the religious people, those who keep fast in the month of especially Ramzan for a longer time of a month. So this is an excellent molecule, especially in the fasting time, to control the postprandial
because they
peaks.
eat twice a day, before sunrise and after sunset. If they take one ripoglinide with the morning meal, what they take, and then one, don't take in between, and it doesn't work till beyond 1 hour or 1.5 hours. So postprandial surge can be blunted with this. It may be a wonderful combination if it can be given pre-meal in the morning and early morning when they take, and then pre-meal in the evening when they take. It may, yeah, please.
This postprandial, you said that it will have a vessel perfusion in the
Vascular injury.
Yeah. Now suppose, the demographic age, for instance, if it is elderly patients and all, like what is your take on that, sir? Like, above 70 especially, or 65 and 70 above, like, I generally we do not maintain too much of a glycemic control over there.
Correct.
So how to, improvise on the...
No, the overall in DP4 or SGLT inhibitors are these molecules. Ultimately, we consider it beyond 65, beyond 75, beyond 80. We are going to relax our targets, and same analogy has to be followed. I don't think we have to be tighter by using these drugs, and these will not do that because they are not very, very strong hypoglycemic agents. Even if you want, it may not bring down too much. Yes.
C remains normal and postprandial is on the higher side, and we all miss it. So now, this being the case, how reliable is HbA1c?
HbA1c is reliable generally overall, but as you saw the graphic depiction or when you see anywhere between 7 up to 8.5, it is predominantly determined by the higher postprandial sugars. Whereas both fasting and postprandial are higher, then your A1C is more than 8.5. So what I'm telling is, if your A1C is 7, don't be happy that you have achieved the target. Keep monitoring now and then. That's why the SMBG, 5-point SMBG is very, very important. 2 or 3 occasions he has done, say, 5-point glucose testing, and he comes to you. You'll be surprised to see fasting is 100, post-lunch is 240, and with A1C is 7. So act on controlling these 2 components by whatever mechanism that is possible. time in range is, because especially A1C between 7 to 8, fairly normal fasting. This is the postprandial that determines that. Whereas beyond that, both may be contributing, but more so by fasting.
To take the same tablet, or how exactly?
Actually,
it goes?
when you are giving only Oglibos, you better give pre-meal. You are only giving Ripaglinide, give with the meal. When you are giving combination, better to give just need not be half an hour before, 10-15 minutes before.
If there are no more questions, one more.
Yeah, again, as I told you, individualization in determining the dosage and frequency is also important. I have a patient, let us say he comes with a 5-point SMBG with only his diet or this combination are high. You can advise in his diet because he may be having large lunch, small breakfast and a modest dinner. His sugars may be rising because of that habit. It's on his profile of spikes, times or once, depending on that. So it is a highly taking large lunch.
Thank you, sir. It was an excellent talk, and we just landed on time. I just hand over the mic to the organizers to take over.
Very much. Lunch is served just outside.
Wow!
heart failure. And many patients will have heart failure with preserved ejection fraction because CKD will have invariably hypertension and LVH will be their ejection fraction of 60-65%. Whereas the patient is symptomatic, the patient will have kidneys to excrete the BNP. You cannot clearly tell us patient with end-stage renal disease have heart is the cardiovascular mortality. That as the GFR comes down, for example, from 60 ml to 40 ml, the mortality is baseline GFR. You will have a high risk of mortality because of arrhythmia. LV mass is directly proportional to the mortality because any hypertrophied ventricle is prone for arrhythmia, hypertension during dialysis and succumb, which we cannot able to make out because we don't put the ECG leads during dialysis. So patient will have an on and off myocardial stunning and automatically recover. So the cardiovascular mortality is one of the important is on AC inhibitor, AC inhibitor, beta blocker, and MRA. So next, the important drugs which has shown the mortality benefit is the carvedilol, especially on dialysis population. An RCT from Italy shows that the carvedilol used among dialysis patients reduced the mortality, and ejection fraction, which was 26%, has increased to 37% after 2 years of usage of carvedilol. So any treating physician who does rounds in dialysis room, you see that the patient is on carvedilol or not because it reduces the mortality. And if you come to ivabradine can be used if the beta blockers are already used but heart rate is still high because this gets metabolized in the gut because of cytochrome P450 enzyme and also in the liver. So no much dose reduction in CKD, you can use ivabradine. And the drug like ARNI definitely can be next choice in this patient because in spite of being AC inhibitor, this patient is not responding. So the better choice will be ARNI. Of course, SGLT2 inhibitors and the hydrolazine and isosapropyl are there, but they don't have strong evidence to reduce the mortality. So these are all the various trials where the drug has been used. That SOLVE trial, enalapril has been used. And you can see the cutoff GFR. I put this slide because you need to know till what level of creatinine we can use the ACE-ARBs. Here, these various trials, they have used up to 2.5 milligram per deciliter because many times you cannot able to calculate GFR and many times there are various formula use various values. If you just look at the 2.5 milligram, up to 2.5, you can take a risk. But beyond that, the risk of worsening renal function may come in. So the CHARM trial where they use a candicertan, they have used up to 3 milligram per deciliter the drug. And the CBIS trial where bisoprolol up to 3.4 milligram. And Copernicus, carvedilol, 2.8 milligram, Merit-HF, that is metoprolol, they've used 2.8 milligram, seniors, nebuvolol. So all these beta blockers have been clearly used in mild to moderate CKDs. You need not worry about that. Only during the patient with a severe renal failure, you need to be cautious when you use these drugs because that may worsen creatinine. And MRAs, again, rails, where they use spironolactone, FSS and FSS, where they use eplerenone up to 2.5 milligram. And also paradigm heart failure trial, which we'll discuss in future slides. And the cardiac resynchronization therapy, SGLT2 inhibitor, the off late up to 20 ml of GFR, you can use SGLT2 inhibitor, especially after the EMPA kidney trial. After EMPA kidney trial, where they used up to 20 ml per minute per 0.73 meter square. So these are all the various drugs are in the armamentarium. But this patient is already on AC, beta blocker, and MRA. So the next choice would be removing AC inhibitor and introducing ARNI, despite the GFR is 40, because up to 30 ml we can use as per the guidelines. But the studies have proved, like UK, the HARP trial, where they used up to 20 ml, where this ARNI has been used. So we can use the drug in this patient. If you look at the level of evidence of heart failure patients in CKD, the strong evidence, you can see the GFR up to 30 ml, the evidence of beta blockers, ACE-ARBs is almost very, very strong. If you look at the GFR, when it is coming down below 30, the evidence becomes weaker. So even apart from carvedilol, the beta blockers, ACE-ARBs, when the GFR is less than 20 ml, we don't have very, very strong evidence that they prevent the mortality. Again, if you look at the last about line where even patient is on dialysis, the drug of choice will be ACE-ARBs, unless otherwise patient has hyperkalemia. Because the commonest cause of death in dialysis patient is cardiovascular disease. So you have to reduce the cardiovascular mortality. You can use ACE-ARBs among dialysis patients. Only in patient with a stage 4 CKD you should be cautious. Up to 30 ml to 15 ml be cautious. Because that will push the patient from stage 4 to stage 5. Or a patient who is non-dialysis dependent will become dialysis dependent if you use the ACE-ARBs in such patients. Otherwise, they're all wonderful drugs. And then the challenges, what we have to use these ACE-ARBs in the management of heart failure is that because patient is already on diuretics, so ACE-ARBs or SGLT2 inhibitor and diuretics definitely is going to increase the creatinine. So you have to remember a term called permissive AKI or inducible AKI. where the creatinine will go high transiently because of hemodynamic mediated. You need not worry about it because the only creatinine will go high if you measure the urinary biomarkers of tubular injury like NGAL, encystatin, and KIM1, kidney injury molecule 1, it will not be elevated. So it is purely hemodynamic mediated, and patient will come back. Once you reduce the dose, once the patient improves of heart failure, the creatinine will come back to normal. So you need not worry about transient rise of creatinine in such patient because it may be a permissive or inducible AKI, it may not be a worsening AKI. So these are all the challenges. If this fellow comes in acute breathlessness, the management goes a little bit ahead. We have to use the diuretics because the diuretics will reduce the pulmonary volume overload state because most of the CKDs will have heart failure because of volume overload state. So the diuretics, they are compared the bolus versus the infusion, and there is no much difference between that. And the study from NHLBI where they use the furosemide up to 72 hours around 580 milligram, around 60 mg TID per day, 180 milligram per day for 3 days, where a patient had a urine output around 3 liters per day for 3 days, have shown decreased mortality despite increased creatinine. So patient may have transient elevation of creatinine, mild AKI, permissive AKI, but mortality comes down. So no need to worry about the diuretics in acute setting, but you need not continue for a longer time. And you have to keep a watch on hemoconcentration. You have to look about the PCV. If the hematocrit is going high, it means that indirectly the patient is receiving more diuretics, and you have to tune it because that is also increases the mortality. So these are all the various drugs. I don't want to go in detail because of time, because I start with the ACFs from the down up, and the beta blockers and MRAs, and the ivabradine, and then the hydralazine and isosorbate dinitrate. And digoxin has got no role because it increases the hyperkalemia. In fact, in the patient with severe renal failure, it causes increased mortality. So it is not recommended at all. Only in presence of atrial fibrillation and heart failure, digoxin has a role. And also nocturnal hemodialysis. Anybody who doesn't have improvement with the regular thrice weekly dialysis, whole night dialysis with a ecodextrin in peritoneal dialysis or whole nocturnal hemodialysis will have increased survival rate. So if you use the ACAPs, there is increased risk of mortality in patient with a worsening renal function. You should also remember a point that anybody who has a worsening creatinine, not only worsening, even coming down creatinine. Somebody has a creatinine 1.5, after diuretic therapy, decongestion, the creatinine becomes 1.2. So it's improving. So either side of the thing, if it is worsening or improving, that indicates the patient has a lot of hemodynamic activity in the kidneys. So you should be very cautious when treating such patient because those are the patients go for increased mortality in management. I think I gave some.
Thank you, Dr. Niranjan, for that comprehensive description. So our patient is already on ACE inhibitors. So is it good enough? Is it adequate, only a ACE inhibitor in the management of heart failure? Dr. Srikanth will take this question.
Thank you, Dr. Manvilkar. So thank you, Disha, for inviting me. Going to the topic. So we just discussed that heart failure patients don't do well. So whatever is available, we have to use to reduce their mortality and improve the quality of life. So we should look at their quality of life, we should look at the mortality, and the third thing is heart failure hospitalizations. These are the three areas which we have to reduce so that the patient is better. So we are already using ACRB, will it help? Yeah, that's what we are going to see. What should we be doing? We should be trying to reduce this morbidity, mortality further. So we just, the mortality we heard like up to 30%, 50% in the next 3 to 5 years. So all the molecules, although most of the molecules like ACE inhibitor, beta blocker, MRA, ARB, all of them have showed reduction in mortality. So if I see a lesser percentage, it doesn't mean anything. It just means that the patient is already on more heart failure therapies. So when beta blockers were studied, patients were only being given ACE inhibitor, diuretic, or digoxin. Or similarly, when ARBs were studied, the background therapy of the patient was only digoxin and diuretics. Nothing else was there. So the mortality, as the patient is on more number of heart failure medications, the reduction in mortality will not be great. However, all of them have showed more than 30% individually reduction in mortality. So we are already blocking the angiotensin converting enzyme or pathway So what is this sacubitril valsartan? What is it doing more than that? It not only blocks the angiotensin 1 receptor, which we are regularly using in the form of ACE or ARB, it is also inhibiting the neprilysin. So this allows the vasodilatory peptides to be present in the body for a longer time, and that causes vasorelaxation and increases the diuresis. We just read that NT-proBNP, when we use neprilysin inhibitor, the BNP will elevate because the BNP degradation is also prevented by neprilysin. So for a patient who is being treated with sacubitril valsartan, you have to do only NT-proBNP. If you do BNP, it is falsely elevated because this molecule itself prevents the degradation of BNP. So BNP levels will be high, something similar to CKD. So because of this additional pathway, there is inhibition of cardiac fibrosis and reduction in the cardiac myocyte hypertrophy. So majority of the molecules target this, and we have an additional pathway which is more, this is the theory behind it. And Paradigm HF showed that the molecule is beneficial. This was almost in 2015, and from that most of the recommendations have been approving usage of sacubitril valsartan in preference or shifting. So the latest guidelines tell that in ESC 2021 recommends that as a first line therapy of heart failure. So heart failure, as soon as we hear, we should, in the introduction we were told there are 4 pillars. One pillar is beta blocker. The second pillar is MRA, that is aldosterone or eplerenone. The third pillar is ACE inhibitor ARB or sacubitril valsartan. So the ESC now tells that it has to be used as a first line. So most of the recommendations are combining the ACE inhibitor ARB or sacubitril valsartan. If we can use without any problems, sacubitril valsartan should be the first choice in this arm. The fourth arm is SGLT2 inhibitors. So these are the 4 molecules which if we use, the patient is getting the best therapy for heart failure. So in the ACC 2022 also, ARNI, that is sacubitril valsartan, was recommended as the first line of therapy. Either if the patient is on ACE inhibitor or ARB, you can switch it over, or if he has never been on it, that can be the first choice medication to be started. So as I told you, we have to look at the quality of life, prevent the hospitalizations, and keep them alive. So what is this helping? It is helping reduce the CV death and heart failure hospitalization as a combination, as well as individually CV death. And the additional thing is it is also reducing all-cause mortality. So many of the molecules don't show this kind of a reduction. So 20% reduction in combined death and hospitalization, CV death alone 20% reduction, and all-cause mortality also is reduced by 16%. So in the background of beta blocker and MRA, definitely it is going to help. And similar reduction in the Indian subset of patients, almost 30% reduction in CV death was noticed by using the sacubitril valsartan. And the same, CV death is also reduced, all-cause mortality is also reduced by 12%. So essentially, if we come back to our patient Karthik, so this is one molecule we need to add on, or we can shift from ACE inhibitor ARB to sacubitril valsartan. And the second thing which we may not have been, the other thing we should look at is SGLT2 inhibitor, irrespective of whether he is a diabetic or a non-diabetic. Whether the patient is, irrespective of his glycemic status, SGLT2 inhibitors have to be used in every patient with heart failure, because that also has shown to be beneficial significantly in reduction in all the 3 aspects. One is symptoms, second is hospitalization, third is mortality. Dr. Bharat.
Thank you for that excellent description. So we know that angiotensin blockers are a cornerstone of heart failure treatment. So ARNI is not a replacement, or it's not an antagonist for this class of drugs. ARNI is basically neprilysin inhibitor and angiotensin receptor blocker, both combined in a single pill. So it is a refinement over the ACE inhibitors or pure ARBs. So after this discussion, we'll go to the next question. So based on the various clinical trials, there are several parameters which we use to evaluate the effect of a drug. So one common parameter which we use is the hazard ratio. However, there are certain pitfalls to it. So to discuss this, we'll go to the next question. So is there any other outcome measures other than hazard ratio which can tell us about the long-term benefit of a drug?
This is more of a statistical juggling. However, we can learn something new aspect here. Whenever we read a trial, when we see like hazard rate, that is supposing simplifying thing, like in a school there are 100 students and 5 students fail. We take them that 5% is the event rate in that particular school, and a school next to it, a private school, comes up and tells like we are reducing the failure rate by 20%. That means instead of 5 students failing in 100, 4 students fail. So that's how statistics play a thing. Anyway, that's a part and parcel of our life now, evidence-based medicine. However, so when we take, like I just gave an example, 5 students failed in one school and then 4 students failed in the other school. So that means there is a difference of out of 5 is the baseline and then the other thing is there. So the ratio is around 0.2, that becomes the hazard ratio. So over the background of any therapy, when we use a new molecule or a new therapeutic agent, what is the changes we are going to bring? These are the things. And restricted mean survival time is what they are trying to highlight. Average survival up to a given time point. So if you are looking at supposing some event like patient is getting hospitalized for the next time or he's having a death. So what is it that the molecule is doing? And so there are many aspects. Like if you say recruit a patient who is very young, then he will definitely survive longer. And if our patient is 61 and you compare another patient of 75, we can't really compare the hazard ratios. So here younger patient invariably performs better. To mitigate these aspects of hazard ratio, we are using RMST, which provides a long-term estimate of a specific therapy. And event-free survival, like whether we can prevent a hospitalization till he gets into a more severe situation, we can use a aspect called RMST. And when we studied the sacubitril valsartan, what is it doing to the RMST? It extends the life without primary event, that is hospitalization or worsening of symptoms, by 1.5 years when compared to enalapril. So this is what you call a fine-tuning your outcome measures when we use a new therapeutic agent. And so similarly, all-cause death also was increased by say 8 years, almost 0.8 years when we use sacubitril valsartan. And event-free survival of 6 months was achieved with sacubitril valsartan irrespective of functional class, whether they are in class 1 or 2. The improvement was almost up to 1.5 years, almost 2 years, and in the more sicker patient was almost up to 6 months. So what I would like to highlight is most of these 4 classes of drugs, whether it is beta blockers or ARB, ACE inhibitor, and ACE inhibitor, ARB, or sacubitril valsartan, MRAs, and SGLT2 inhibitors. These are the cornerstones, and if we analyze these kind of things, we will definitely come with such similar data. All of them have been shown to be beneficial. The other thing I would like to add is digoxin. Although we keep telling it's not showing any benefits, you will see next another set of molecules coming. Patients who have been recently hospitalized, vericiguat is going to be launched soon. The only advantage is reduction in hospitalization. if we analyze digoxin trial, DIG trial very delicately, it showed almost 28% reduction in heart failure hospitalization. 28%. Any new molecule, company would come and bombard us. Please, sir, this is a new molecule, 28% reduction in heart failure. What will we all do? Would we not prescribe? Yeah, so only thing is use it in a dose at which they don't exceed. An interesting history of digoxin is probably somewhere in 12th or 13th century, digoxin was used to kill people who were political prisoners. Digoxin was a way of exterminating their political prisoners in 12th century in Europe. So it's obviously a molecule it's going to kill when you use it in a toxic dose. So if we don't use it in the right doses, it is going to harm us. So digoxin is another molecule. I almost try to see that if there is a reason why I should be using it. If it has reduced 28% reduction in heart failure hospitalization, we should probably also use it. Diuretics, as we just discussed, not only in symptom reduction, it will also, and diuretics has never been, have you ever heard of a trial with diuretics that it reduced heart failure hospitalization? It will be rejected. The reason why a trial with diuretics is never conducted is it will be rejected for ethical reasons. You cannot conduct a trial telling, I will give diuretic to 100 patients and no diuretic to another 100 patients. So it will not be approved from your ethics committee. So diuretics are again another therapy. I would call digoxin and diuretics as orphans. Nobody pushes you to do them because they are molecules which are very essential to be used judiciously. And with that, I would like to thank you.
That's an excellent point. So the message of this particular discussion is that whenever you use sacubitril valsartan, you are adding up to 1 to 2 years on top of ACE inhibitors such as enalapril and ramipril. So we'll go to the next question. Sudden cardiac death can occur without any apparent worsening of symptoms. So I would request Dr. Dominic to discuss the role of this molecule in preventing sudden death.
Thank you. Just to carry from what you said, I think any medicine that is used in a wrong dose is pretty much lethal. I just want to say this: when you're dealing with older people, I think the slogan is "Go slow and go low." I think that's one thing that you need to be aware of. Now, I think one of the reasons why heart failure is such an unpredictable, brutal disease is the first slide that we saw is the progressive decline in one's function. And once they start having dips, you know that the quality of life is very poor. They live less than 1 year. That's the time you need to start talking about advanced care planning, I won't be seeing you for the next Ganesha festival. What do you want to do? Do you want to die in the hospital? Do you want to die with your loved ones? Do you want to go on a ventilator? Do you want to go to ICU where tubes will be shoved in every orifice that's possible? So I think that's what you need to do as a clinician. Although I'm just deviating from there. Now, sudden cardiac death in heart failure, yes, it is. Because why? There's remodeling of the heart. There is a poor supply of the blood. It's very much irritable. It does throw up abnormal rhythms that can kill. So I think it's in the paradigm sub-analysis study show that it is very clear that 6 out of 10 NYHA class 2 patients died due to sudden cardiac death in the study that was published here. So I think it is quite common. And it's devastating because there's sudden loss. And also for a patient who's going through a chronic illness, it is also a horrible feeling that you are existing, not living, and you're not able to perform your activities. They feel totally invalued and invalid, to be honest with you. They feel that it's not worth living at all. Now, what's the impact on the mode of death? And we know sacubitril valsartan ARNI significantly reduced the number of sudden cardiac death and death due to worsening heart failure. I'm not able to see the numbers here. I think it's clear that it's all cause, it's 16% reduction. CB causes 20% reduction. Sudden cardiac death is 20% reduction, 1 in 5, and 21% reduction is worsening heart failure. Guidelines recommended by European Society of Cardiology is that ARNI has been recommended for prevention of sudden cardiac death, not ACE inhibitors or receptor blockers. Okay, now we talked about the pillars, we used various figures of speech, But yes, I think the question is always the elephant in the room. I think we as Indians are very adapted the heart of, dodging the cows in the street and forgetting the elephants in the room. The elephant in the room is money. It's money. So is it value for money? Yes, it's absolutely value for money from what we know and what I've been using for the patients. Yeah, next slide, please.
So I would like to add that a couple of decades back, there are a lot of clinical trials which were published with implantable defibrillators for reducing sudden cardiac death. However, with the advent of beta blockers, aldosterone antagonists, and now ARNI, I would say that there is significant reverse remodeling which is happening. So the chambers, the fibrosis within the myocardium is getting reduced, the chamber volumes are coming down, and then ejection fraction improves beyond 35% in most of these patients. So most of them, with the usage of these medications, we can avoid or we can delay a defibrillator implant in these patients. So in that way, I think ARNI has been a major advance vis-a-vis ACE inhibitors. So I would request Dr. Niranjan to talk on the role of ARNI in patients with CKD.
Just before moving on to this molecule, I want to add a few points about other two therapies which you often ignore. One is the iron therapy, especially in patients with the CKD and heart failure. The usage of 400 milligram of iron per month will reduce the cardiovascular mortality and also especially the heart failure. So anybody who is anemic, who has a renal anemia, secondary to diabetic kidney disease or whatever it is, try to treat iron deficiency state because it reduces the heart failure hospitalization. And the second one is we often neglect about the vaptans. Whenever it is required, in maybe mild to moderate CKD with the heart failure, if it's a responsive, along with the mild to moderate hyponatremia, maybe a better choice. We can add that also. These are the drugs which often we don't consider at all. So let me move on to this question. What is the effect of sacubitril and valsartan in heart failure patient with a CKD and dose recommendation? So already we discussed about a paradigm heart failure sub-analysis where this lower rate of decrease in EGFR and there is an improved cardiovascular outcome even in CKD patients. So up to stage 4, up to 30 ml of GFR, there is a significant improvement of heart failure risk or hospitalization. And also even in a trial with the pioneer heart failure where they are used in acute decompensated heart failure, that also shown the lower risk of hospitalization or the death. And if you look at these various trials, the paradigm heart failure, Paragon HF, Paramount, Pioneer, and I would like to highlight the last trial, that is UK HARP 3, where they have used irbesartan versus ARNI. And look at the GFR, they're taken 20 to 60. So though the guidelines mention about 30, more than 30 ml per minute, you can use the ARNI with a dose modification. With a small dose, you can start. But even up to 20 ml, it has been proved that it is safe and efficacious. So up to 20, we can use this molecule. So if you look at the various stages of CKD, if anybody has a GFR more than 60, no dose reduction at all. Even 30 to 59, no dose adjustment is required. If anybody has a less than 30, that is stage 4 CKD, you have to start with a small dose, 50 milligram. You have to start 50 milligram BD. I will start 50 milligram half BAD, and every 2 weeks I increase the 50 milligram BD and then 100 milligram BD as much as the patient tolerates. So you can keep increasing and go up to 200 mg BD over 2 to 4 weeks if the patient tolerates. So the real world studies shows that patient with a EGFR of less EGFR, when they use the heart failure, use this RNA drug, look at this significant improvement in EGFR. That is, the real world study says that patient who has been used the ACE around the 55 ml per minute, whereas the RNA it is 65. So compared to ACE versus RNA, there is a significant improvement in EGFR. Do not worry, because apart from valsartan, it has a sacubitril, which is a natriuretic peptide, which definitely has a diuretic effects and also the favoring effects. Even the patient who has a mild hyperkalemia, if you compare EAB and ARNI, you are around 0.1 to 0.2 milliequivalent of reduction of potassium is appreciated when you use ARNI compared to the ACE inhibitor. And also it lowers the dose of the diuretics. Anybody is already on furosemide 100 mg or 200 mg, whatever it is end-stage kidney disease. If you use this ARNI up to stage 4, definitely it reduces the need of the diuretics. So to summarize, a patient like Mr. Karthik, who has a mild worsening heart failure symptoms, is at increased risk of mortality and renal impairment, further increases the risk of mortality. So the better choice would be sacubitril valsartan, and we have to start with a small dose of 50 milligram BAD, and you have to uptitrate according to the tolerance and the need, and that will reduce the mortality in that patient. And to conclude, the RAS inhibitors like ACABs can lead to temporary worsening of renal function, and the RNA reduces the risk of cardiovascular death and all-cause mortality in heart failure with a reduced ejection fraction patient, irrespective of the CKD, and extends survival time in heart failure with reduced ejection fraction by 1 to 2 years. So we can give a life of 1 to 2 years if you use this drug at the right time, at the right dose. And RNA shows significant reduction in the risk of CV death or heart failure hospitalization with CKD up to 20 ml per minute of GFR. With this, I would like to conclude the presentation. I hand over to the chairperson.
So, as we have already seen, RNA causes a significant reverse remodeling. So, it is always judicious to initiate the molecule with the greatest outcome, to initiate as early as possible in the natural history of heart failure. So I would recommend, the guidelines recommend that RNA should be initiated prevent progression to heart failure. And I am an electrophysiologist. I do a lot of defibrillator implants. But then I would say that in future, with extensive use of RNAs, the number of defibrillators for primary prevention of sudden death is likely to come down because of reverse remodeling with these newer molecules, RNA as well as SGLT2 inhibitors. I would request the audience to ask some questions.
If we do this global strain, because they say that global strain will be the ejection fraction of future.
Yes, sir. I totally agree with you. GLS or global longitudinal strain is a new way of detecting LV function. It's more easily reproducible, and inter-observer variation will be lesser. COVID taught us, like many patients with tachycardia, we were seeing the LV function is normal. Why are they having tachycardia? So we started doing cardiac MRIs, but then MRIs were expensive. And during the COVID times, the difficulty to shift the COVID patient, non-COVID patient. So we had and almost 15 to 20,000 just to see the reason. We did find that a lot of them had myocarditis, although their LV functions are normal. And then we started using GLS. Then all of them invariably had GLS lower. And once their symptoms improved, they become better. Definitely, as sir pointed out, as a screening tool, if they are seeing LV function is normal, and we also have a new class of heart failure with preserved ejection fraction. And they are having breathing difficulty. We don't know what to do with them, whether it's cardiac, non-cardiac. And as sir pointed out, preclinical, subclinically, if they are having some subtle LV dysfunction, GLS is a very important tool. Of course, at this point of time, we can definitely use the other, if there is a lesser indication or a borderline indication for an ACE inhibitor or ARB, we should probably be insisting them on to continue. More aggressive management of other risk factors is what we can offer them. Probably, definitely, we will have in future on the basis of GLS, low GLS, normal LV function, use the small, probably usage of SGLT2 or sacubitril valsartan. Information will be probably coming in to tell that, okay, you use this and reduce the onset of heart failure. Definitely, sir.
Nowadays, they say sacubitril valsartan can be used also in patients with preserved ejection fraction. What is your...
So the trial, up to 50%, it has, they have dissected out and showed that up to 50% it's helping. If we are using ACE inhibitor or ARB, in that we can definitely use. But the trial per se was not positive trial like paradigm heart failure. But then when we dissected out up to 50 or 55% EF, you are going to benefit the patient. Above 55%, sacubitril valsartan may not really help. But if you are using a ACE inhibitor or ARB, I would probably be happier to be keeping them on that. And maybe some other trial may come with the information. And of course, we have SGLT2 inhibitors, which are now recommended. So.
Yeah. The Paragon heart failure trial evaluated RNA versus valsartan alone for patients with heart failure with preserved EF. And over a follow-up of 1 to 2 years, there was a trend towards reduction in heart failure hospitalization and all-cause mortality in the RNA arm. However, it did not reach statistical significance. Probably a longer follow-up might bring out the difference between the two drugs. So definitely, I mean, there is not a strong recommendation for starting ARNI in patients with EF more than 50%. However, there is definitely a trend towards reduction in hard outcomes. And as Sir mentioned, we can always look at strain using speckle tracking and pick up subtle systolic dysfunction, and then we can, if they develop systolic dysfunction based on strain rates, then we can always go for ARNI and SGLT2 inhibitors. We'll have to stabilize the patient, wait for a few days for the proBNP to come down, and then we can always start at a lower dose. So in a stable patient, we start generally at 100 milligrams twice a day. In a patient with elevated BNP, I would rather start at 50 milligrams twice a day or 50 milligrams half twice a day, and then gradually up titrate.
Thank you for the esteemed panel for the excellent. One last question, please. Yeah.
Consulted and treated Mr. Karthik. At what point would you come to a decision of taking towards an LV assist device, heart failure device, and all that, based on treatment? Any specific point where you would think of all those?
Yeah, definitely on the basis of symptoms. If patient is persistently in class 4, that is, patient is having symptoms of breathlessness even at rest, patient is not able to lie down, ejection fraction is significantly low, say less than 20 to 25%, or he is not able to tolerate any of the heart failure medications such as beta blockers and ARNIs, then definitely we need to register the patient for cardiac transplantation. Dr. Srikanth?
Although we've been talking only gloomy picture, we're posting most of the time, because the information is, if we use these 4 pillars properly, the reduction in mortality is 72%. 72% is the reduction when we use all the 4 pillars properly. So I would rather, of course I am a transplant cardiologist, I don't see him that probably he's into that stage so early. If you use the molecules well, they do extremely well. And the reason why I moved from interventional, my interest increased in heart failure is the patients are so happy when you treat them well. And the more patients post angioplasty, less patients, like hazard ratio. Number of patients not following with me after angioplasty was slightly higher rather than a patient who has been treated with heart failure and recovered well. They will diligently follow you. Use the reduction in mortality is almost 72% when we use it properly. So, early initiation is now the thing. So, they will do well. But
the session, we thank the esteemed panel for the excellent discussion. And the major risk factor for heart failure, in a funny note, is the doctors who make the patient live longer. So the longevity is. Dr. Arvind Kumar, consultant physician, to chair the next session.
Arvind, for chairing the session for us. And to speak, we have my colleague from Manipal Hospital, Dr. Anu, and tell us. So we always believe that they are unfairly victimized. So let's see what he has to say about it. Over to Dr. Anu.
Good afternoon. Continuing with the failure, the heart failure, we will come to one more interesting topic. Earlier, as we all know, older drugs were not tested for cardiac safety. So now new drugs have come with the label of cardiac safety. In fact, anti-diabetic drugs are used in heart failure. So sulfonylureas really end up in failure. Without wasting much time, I'll hand over to Dr. Anu.
Good afternoon, everyone, and thanks them for
having me here, and myself in the first slide. But I think areas and leading to, I would like to start on a philosophical note. You know, as a geriatrician, we know for sure that all cells fail in the end. It's a fact of life. And you know, how much of the sulfonylureas which lead to secondary failure is what we're going to look at now. What is the data behind it, and then the beta cell exhaustion, lack of durability, and whatever the data sets that we have. And finally, we'll summarize it and look at, you know, what we have going forward. So this is the conventional in beta cell function in due course. And sulfonylureas, by the nature, act by glucose lowering action. You know, they stimulate the pancreatic beta cells to secrete insulin, and thereby they're effective in glucose control. Wonderful drugs, been there for a long amount of time. But what happens eventually is, after this preliminary reduction in the overall FPG, PPG, A1C, eventually what we look at is that they stop functioning, or the reduction in A1C is much more compromised. And this exactly is failure in some cases. I'll come to that. But secondary failure is when you have something which improves the overall metabolic content, and then thereafter there is a failure, which is essentially a lack of durability. Secondary failure. But the question is there any way we can actually identify, you know, who are those patients who will have the secondary failure that we have? And if you're looking at the secondary failure rates, broadly speaking, we can see that at least about 33% is the rate where you look at secondary failure post-sulfonylurea therapy. There are specific and also this one, the DI, which is the disposition index. We'll have a look at it in detail shortly. But suffice to say that if you have patients who are coming in with high FPG, much more clinically relevant. So these are cases where we can predict that sulfonylureas are going to fail in due course. As I said earlier on, primary sulfonylurea failure is also something that we see. And that's as soon as you start it, when you don't see the reduction in FPG, PPG, A1C. But secondary failure is something which we look at very commonly. I'll go a bit more in detail about HOMA and DI, because these are... So this is a broad kind of guideline of as to how we calculate the disposition index. Now, disposition index, by definition, is the ability of your insulin secretion and insulin sensitivity. So DI calculation based on insulin secretion and sensitivity will give us a good chances of secondary failure are low. But if you have a low DI, the chances of secondary failure are high. However, this insulin secretion and sensitivity may not be something which you do on a day-to-day basis for all your patients. And hence the HOMA came in, which is the homeostasis model for assessment of beta cell function. And one of the advantages of HOMA versus DI is the fact that HOMA depends on fasting plasma glucose. So you don't have to actually go into the insulin sensitivity. So you create a model, the homeostasis model, use the fasting plasma levels in a lot of your patients who come into the clinic. But suffice to say that the idea behind HOMA and DI is this one. How well is the insulin secretion and insulin sensitivity happening, and how good the pancreatic function is? So based on DI and HOMA, you can actually make a prediction of who's going to have a secondary failure. And yes, these are some of the genetic markers, CYP. But no, that there are genetic markers, and especially in the middle sulfonylureas. And broadly, if you look in Caucasians, they are the ones who have a higher rate of secondary failure with sulfonylureas as compared to the Middle Eastern or the subcontinental population. In fact, the subcontinental population do better with sulfonylureas as against the Caucasian population. But in summary, you have predictors, whether it's genetic predictors, high fasting plasma glucose, high A1C, high or low DI, or a HOMA-B levels. I think these are all things which you can use to predict who's going to secondary fail using sulfonylureas. So with that background of what is sulfonylurea secondary failure, who is predicted to have secondary failure, let's look at a landmark study, the UK-PDS, and then I'll also share some more studies which talk about secondary failure. And this particular slide is very key because, I'll come back to this slide in the end. And if you see, this is what we were talking about. You have a brilliant reduction of A1C when you start off sulfonylureas. And then, you can see that over the course of the next 6 to 12 years, the A1C goes up. And then whether it's sulfonylureas, whether it's metformin or any other OHAs, eventually there is a failure of therapy. So secondary failure is something which we see with not just sulfonylureas, but it's pretty marked with these sulfonylureas. So you have a big dip, which is the primary success, and then you have the secondary failure. So this classical primary success and secondary failure happens with sulfonylurea. And then eventually, the glycemic index, HbA1c increases. But just keep an eye on this slide. I'll come back to it because, we'll toss this entire concept over the head of saying whether failure is indeed failure. I'll come back to it later on. But for now, let's suffice to say that you have a primary success with sulfonylureas, and then you have a secondary failure. So what exactly happens is, eventually they don't exert the effect that we want them to exert. Sulfonylureas don't have a protective effect on the beta cell function over course of time. And this is what I was talking about earlier on, the HOMA-B measurement, the homeostasis model for beta cell function. It clearly demonstrates that a relentless rise in HbA1c resulted in decline of beta cell function. So not just plain sulfonylureas, but combination of SU with metformin also results in a progressive decline in beta cell function because eventually the beta cells are going to give up. So beta cell exhaustion is the primary pathology, what happens when you use sulfonylureas. Apart from that, we're also looking at the lack of durability. So almost a 74% increase in the overall monotherapy failure when you use in the period of 5 years. So, monotherapy with sulfonylureas is very rare nowadays with the onset of things like DPP-4s, SGLT2s, and even oral GLP-1 analogs. But we can clearly see that it's a 74% increase in failure rates when you use it as monotherapy over course of time. And as we discussed earlier on, we know that it fails. We know why it fails is because there is, the beta cells stop functioning. But if you go a little bit more deeper into it, long-time overstimulation of beta cells, increasing beta cell defects, autophagy of the beta cells, then you have increasing insulin resistance, and then the glucose toxicity. So all these in toto are ones which contribute towards secondary failure with sulfonylurea. And sulfonylureas kind of exacerbate that, as we've seen in a lot of data sets. And then, although you may have a slight increase in the control of diabetes, but eventually, if you can see over time, the overall percentage, as I said, the first opening thing which I said in my talk, all cells fail in the end. So you can see that over course of time, entire thing fails. But then that's when you keep stepping up. But then what we need to look at is the beta cell function with sulfonylureas. And you do see that with sulfonylureas, the beta cell failure is more than what you see with the other molecules. The next few slides will look at data, not just with sulfonylureas, but what happens with sulfonylurea and the other molecules. So this is one of major studies which looked at secondary failure post-successful sulfonylurea therapy. And then if you see, it's associated with the level of A1C achieved in the first year of SU monotherapy. So what we're seeing is that apart from the markers that we earlier discussed of what would lead to sulfonylurea failure, I think it's a given that with sulfonylureas, eventually you will have secondary failure. There are no two ways about it. So that's the reality check, which we were discussing about. Having said that, if you look at this, the glycemic control, whether it's better with the other OHAs, even with metformin, this a very good study which we looked at in terms of glycemic control. So this does continue to deteriorate even when you have a metformin and sulfonylurea combination. And then, unsurprisingly, you will have secondary failure where you're adding sulfonylurea to metformin plus a thiazolidine dione. So eventually, what you're seeing is that it's not whether secondary failure happens. I think the only question is when the secondary failure happens. So I think that's the dictum which we need to look at. When does the secondary failure happen, and can we predict the secondary failure, and can use molecules which would increase the time duration between primary success and secondary failure. One of the telling data sets that you get when you look for sulfonylurea failure studies is that beyond a certain time, 2007 and 2010, not many papers at all. Because I think it's a foregone conclusion that there will be secondary failure. So there's no point in proving it again and again of whether sulfonylureas cause secondary failure. So I think that's a telling slide saying that, if there's not much, what they were discussing about ARNIs and, diuretics and heart failure and things like that. So one, the science needs to be predominantly absolute. So there is an absolutity over here saying that absolutity, I don't know if it's a word, but I'm using it. So, or there is an absoluteness over here that there's going to be a secondary failure. And hence, you don't see much of data or anyone looking at data at all beyond a certain point. Of course, there are other concerns with sulfonylureas. You have weight gain, hypoglycemia, mortality risk, especially in the elderly. Hypoglycemia is an independent risk factor for cognitive decline. So, and hence, we don't tend to use sulfonylureas independently. So, a lot of secondary issues with sulfonylureas. So, with this data, where we have proven unequivocally that sulfonylureas do lead to secondary failure, let's look at what can we do. You need therapies which have a better long-term glycemic durability, which preserve beta cell function, and there are loads of them. Somebody asked me the other day, is this a good time to be a diabetic? I don't know, because you have your DPP-4s, you have your SGLT2s, you have the continuous glucose monitors where you don't need to keep pricking yourself again and again. Then you have the oral GLP-1 analogs. And the thing about oral insulin I've been hearing since my college days. But then, that's a very tough question to answer. Is this the right time to be a diabetic? I think that's a debate for another talk as such. But having said that, I think there are a lot of molecules which have a better preservation of beta cell function. So in summary, I will go back to the other slide as I promised, but I think in summary, what we can clearly say is that secondary failure with sulfonylureas is a very common thing, proven beyond doubt. High A1C, FPGs, disposition index, HOMA-B, these are things which you can use to predict who will fail on a sulfonylurea. It's not just SU alone, but a combination also causes secondary failure, but lesser than SU monotherapy. And then alternate non-beta cell dependent therapies are something which we need to consider. And that's what we're doing of late, the non-beta cell related therapies, which give us a better control over diabetes. Now, we still have 4 minutes. I'll quickly go back to this slide as I had promised. So, is failure really a failure? Because eventually what you're doing is looking at A1C going 8%, 9%. But on clinical grounds, and also as per data, you see a lot of data coming in now saying that there's no fixed A1C. A1C depends on individual levels, individual age, functional ability, and these are where you set A1C levels. So that 7% holding good for all is no longer valid. So when you see an 80-year-old who's homebound, has a risk of hypoglycemia, and if I'm keeping the A1C at around 8.5 or 9%, would you call that as treatment failure? I don't think I would call that one. So it's a very debatable thing, probably for another session, where you actually redefine what is failure. Would you define failure only as saying A1C going up? I think that may not be right in due course. So as I said, that's something which is totally for another session. Suffice to say, when we started off asking the question, sulfonylureas, secondary failure, I think that's an unequivocal yes, and they do have a secondary failure rate more so than the other molecules. Thanks very much. Thank you.
Thank you, Dr. Anup. Session is open for discussion. I think we'll have more questions. But to begin with, since these were the early kits, sulfonylureas and metformin, we are discussing about the failure. Probably in Disha, after 10 years, we'll be discussing gliptin failures, secondary, or?
No, I think, goes back to what control less than 7% with a monotherapy, then yes, that is a failure. But then, we need to look at how we define failure. If you look at the latest guidelines, you still have A1C of 8% individualized to a person who's, say, functionally not very independent. There, this may not be considered as a failure at all. And all cells fail in the end. So eventually, we would be, Disha 2032, Dr. Manohar will probably discussing, oral GLP-1 analog failures. I'm happy to do that.
We can have a bit of a discussion here itself. I think the GRADE trial, you talked about many molecular level and so on. I think the GRADE trial primary outcome was post-metformin 4 arms for the benefit of who don't know. Sulfonylurea, GLP-1, basal insulin and DPP-4 inhibitor. That was sitagliptin. Actually, the primary outcome was to have an A1C of less than 7. And I think sulfonylurea did better than gliptins. I don't know if Dr. Arpan wants to add something to this about this topic. So even though we flog, like so many things are pitted against sulfonylureas, I think GRADE trial never gave anything too remarkably bad about the sulfonylureas. It actually did slightly better than the gliptins itself. I don't know, I can be corrected if I'm wrong. Anyone else has a comment? Because it's a very, very important topic. Because we always have been theoretically victimizing sulfonylureas. Of late, I had a debate in Diabetes India conference where I was batting for sulfonylurea.
No, I totally agree. If you see, when you're looking at the first, the one which I showed about what is failure, 8%, 9%, there, I think those are brilliant molecules to use. So if you're, I think the tough thing which goes against sulfonylurea is when you're using it in monotherapies. And I don't think anyone uses that anymore. But I think when you're using it in combination therapy, although the rate of decline is there, if you see the primary success versus secondary failure, rate of decline is much, much lesser than what with monotherapy as such.
Thank you.
Hello. I actually wanted to tell that only. Like monotherapy of sulfonylureas are not used, so how we can call it as a failure?
No, what I'm saying is that although we on clinical grounds don't use sulfonylureas as a monotherapy, what we are seeing over here is that whether you're, it's like what we discussed earlier on, sulfonylurea or sulfonylurea with metformin. So now those trials can never be done because metformin is clearly the first line of therapy. So you need to have metformin plus something else. So when you look at that, what you clearly see is that with sulfonylureas, the primary success and secondary failure versus with metformin and sulfonylurea. So it's just the trend of the graph. So with sulfonylurea and metformin, although the trend of the graph is still on a declining trend or on an ascending trend where the A1C keeps going up, the rate of ascent is what we look at. So I think that's the difference between the monotherapy, dual therapy, and the combination therapy. But at a molecular level, what you clearly see is how the beta cell function, as evidenced by the disposition index and HOMA, how they react to sulfonylureas. So clearly the disposition index, which has to be high, over course of time, it reduces with only sulfonylurea, whereas the DI and the HOMAs are much better with the combination therapies.
Thank you, Dr. Anup. With this, we'll close this session. Thank you.
Thank you.
I would request Dr. Shekhar to felicitate both the faculty. Quickly moving on to the next talk, I would like to invite Dr. Sanjeevra sir to change the session and the basal insulin, leveraging time in range. the in concept of late to improve patient outcome. Over to Sanjay Rao sir, and then I'll request Dr. Suresh Damodar to come over.
Good afternoon. I hope we keep you awake, but it is of prime importance that we individual, to prevent him developing diabetic complications, is to make sure that his sugars are within the range 24 hours of diabetology. So in this regard, I would request Dr. Suresh Damodar to enlighten us, please.
Opportunity. Basically, we are using HbA1c as the main things that we got. Now, the concept has changed. How practically we can use the different issue, but I think the concept and the science has evolved, and the technology is going to be one of the key things in future as well. But with current concepts, we all need to be updated so that we know how better we can provide a quality of treatment for our patients. So this is the thing. I want to talk about only one clinical trial during this talk, which is in range trial. So and I want to get you some concept of time in range if I can. So these are the two things that I want to get in this 20 minutes or so. So clinical implications of glycemic variability, what are the challenges, what happens when the blood excursions up and down if the blood sugar goes up, and what are the concept of time in range, and then as I mentioned about the in-range trial, which is one of the well-designed trial that I will talk about. So the clinical implications of glycemic variability and time in range. So as I mentioned, A1C was the primary way that we assess any glycemic diabetic patient. So, but apart from that, the GV, which is the glycemic variability, and TIR, which is the time in range, are the key metrics that has been increasingly used in all the big bodies. I'll show you some guidelines as well. So glycemic variability, we know that it's a very common challenge for people in diabetes, and excess variability and suboptimal time in range also impacts the quality of life of the patient. Not only quality of life, but I think the complications as well. And I'll show you some international guidelines. When the time in range, that is when the blood sugar is in the range, if it goes out of the range, what are the challenges? Almost 10% of drop in time in range will lead to increased frequency of the micro and macrovascular complications. So we're talking about retinopathy, microalbuminuria, neuropathy, and we're talking about mortality as well. So that is quite significant. So when the patients are all in the blood sugar range, which is about normal, and there is no up or down excursions in a big way, and also if they sustain the TIR, the impact for micro and microvascular complications mainly is almost 10%, is leading to quite a lot of complications. So what are the international guidelines say? ADA and standards of medical care, A1C does not provide the whole of a picture. You got a A1C of 6.4, but the patients might be getting multiple hypos. Patients will be getting up and down, and the A1C is 6.4. We can't treat that just like that. So the risk of microvascular complications will be very high, and then there's a consensus for time in range has come out in 2019. So glucose fluctuations are a process in time with two principles, it's amplitude and time. So you see the glycemic variability, assessment of amplitude of excursion. So this is the normal range in the green, and then low is red, and then yellow is above the blood sugar. So when you do a CGM or an Abbott sensor, for example, you can find out that a lot of people you thought was in very good control may not be. So these technologies will help us in a big way to assess and provide a better quality so that the complications are less. So understanding TAR, the targets for type 1 and type 2, so we have to know that for a type 1 and type 2, this is the way that less than 25% is acceptable for spending more than above the target, and 70% should be in the target, and 4% hypoglycemia is accepted. So this is the way to assess, and you form our guidelines. As I said, that the science will be evolving, And a lot of things are worked on this basis nowadays. So again, just to say that understanding time in range for older individuals, it makes sense that they don't get hypoglycemia. So the hypoglycemia rate, what it came up in the previous one, the 4% has come down to 1% here. So you want to get them, hyperglycemia is not a big issue, but just keeping them without a hypo in elderly patients will be a big challenge. And this is the thing that I mentioned about, talk is about glargine U300. These are the very, very good drugs that is available in the market. And I was giving a talk yesterday in Ahmedabad. We had a lot of questions came out for basal insulins, how clinician, what they used to have BD insulin and human insulin. Now, those days are gone, and with a lot of education and a lot of pharma support, the science have been spread across, and people are just starting the drugs just like that with the basal insulin. So when they have OAD maximizing, they're going in a basal insulin. And these are extremely good drugs. The new generation basal 2 insulins are extremely good drugs. And there is a head-to-head comparison with the PK/PD happen. And also, we had a discussion yesterday about what to use in renal failure and why we shouldn't be using certain drugs. And there are, apart from the RCTs, real-world evidences are also available. And I'm going to talk about in-range trial alone, if I can, in next 10 minutes or so. So in range, this is the recent evidence of time in range. So last 10 slides or so, I brought in a concept saying that time in range is one of the things that has evolved. And I've also mentioned how, when you get a graph, how much acceptable in a type 1 and a type 2 with excursions of high sugar and then hypo. And then with this one, what is the evidence of TIR in type 1? And this is a head-to-head RCT that's called an in-range trial. That is a study design, almost 12 weeks. It's a multi-centric trial. I can tell you it is quite a lot of centers have been involved in this. 18 to 70 age group population. During the titration, the basal increase, and then the CGM is blind weeks. The primary and secondary endpoints is measured at week 12. So primary endpoint is the TIR, that is to keep the blood sugar normal between 70 to 180 at 12 weeks. That's the primary endpoint. That is the percentage you can that has been looked into. And then the main secondary endpoint is the glucose total coefficient of variation, which is the CV at week 12. It's a measure of a glycemic variability. That's the way they measure the variability, GV. So secondary endpoints, again, changes in A1C, and then the TAR, which is above range, and TBR is below range. Below of 70 in week 12, and safety is with the hypos. So quite a lot of hypos has been labeled as in different categories, and incidence of adverse event and change in dose. These are all the secondary safety other endpoints. So baseline characteristics in glargine 300 and IDEC almost equal number, and the age group is similar, and the body weight is similar, and it has been a carefully done trial. So if you look at the other thing as well, the complications wise, at least one diabetic microvascular complications with the neuropathy and nephropathy has been again carefully selected with 2 molecules of glargine 300 and IDEC 100. So primary endpoint, I'll just come back, sorry, I just skipped a trial. So it shows that glargine 300 shows non-inferiority versus IDEC 100. This is showing with the percentage of TIR. So the concept is evolved, and we got some science behind it saying that TIR is provided better with this group of basal insulins of glargine 300. So it says that almost TIR 70 to 180 at the week 12, it's almost non-inferior to IDEC, this thing. So that's the primary endpoint. Now coming to the main secondary endpoint, which is glucose and total coefficient variation, that is the way to assess glycemic variability. The main secondary endpoint was met and it's non-inferior again was demonstrated. So the variability is also less. It maintained on range, and the variability is less with glargine 300, and it's a non-inferior trial. So the other secondary data endpoints I mentioned, A1C is almost equal from when you switching it from the first generation basal, the reduction of A1C is definitely observed in both treatment groups. Hypoglycemia, that's a safety issue. Any hypoglycemia of incidence of glargine 300 and 100, and then the event rate, it's almost comparable, and you see there is a favor in fact for glargine 300 and compared to deglutec 100, and the same thing applies with the number of event rate of hypos, documented hypos. But hypoglycemia nocturnal, which is also one of the important points, both has performed well, but I mean, severe hypoglycemia rate is much lesser in glargine 300. That has been demonstrated in this clinical trial of 12 weeks. So almost just to summarize, just the in-range trial is the first RCT comparing the second generation insulin of U300 and also IDEC 100, but TAR as the primary endpoint. This is real fascinating in that way that you got a concept and we got a study for that, and then it shows that's non-inferiority with the glycemic control, non-inferiority with the glycemic variability, and then the hypoglycemia risk is also less. So that summarizes saying that glargine 300 is a non-inferior molecule compared to IDEC 100 with type 1 diabetes in terms of glycemic control, with the no difference of occurrence of hypoglycemia or safety. Safety is very, very important. Yesterday we had again saying that we are comparing apples and oranges and apples and androids, but I just said that whatever are you comparing apples or oranges, whatever it is, I think you can say there is a flipping technologies there, or satellite connecting technology in iPhone is there, but the safety is very important. So hypoglycemia rate and the safety is very important, whatever you use. So within the day variability is also is much lesser when compared to the competitor of IDEC 100 with this thing, with glargine 300. So using clinically relevant blinded CGM metrics in range, comparable glycemic control in terms of almost day variability. So just to summarize within one slide, and then I'll come to my summary. Strengths of this study is multicentric and randomized and actively controlled and done in a very, very good centers, and using clinically relevant CGM metrics has been used, and blinded CGM data to show the properties of both molecules, and CGM data is collected for a period, and it's been correlated with 3 months glycemic outcome, for example, with the A1C and other things. So, but the limitations, it's an open label trial, and the long-term CGM data would provide more robust this thing more than 12 weeks, but that is a challenge. So what is the key takeaway points from my talk in last 20 minutes or so? CGM is the technology, as I mentioned. I mean, we were in an ad board last week, and they come out with a brand new molecule, and they were asking what is the next step. We got a molecule, we want to market it, and we want to get it to the patient. We want to get the patient to get more maximum benefit. See, the way forward is technology. I don't think anybody can disagree that our younger generation and whole of us, even just fiddling with the phone all the time, and the technology is going to be the way forward to come with any therapeutic intervention, what you're doing. So CGM allows more complete assessment of overall glycemia. So if you're having A1C of 6.1, don't take it granted that it's a good control. It might be the case that people may having a multiple hypos. And then there is no CGM literature to use CGM comparing to the second generation insulin, and this has been demonstrated in the multicentric randomized trial I mentioned about. The study is called in-range trial, and that's demonstrated that glargine 300 has got safety, less glycemic variability, and also time in range is maintained. So with that, I stop my talk, and if there is any questions, I'm happy to take.
For the sake of the audience, I'll ask Suresh one question.
Sure.
Lantus is U100. This Tujio is 300.
300.
Both, one will work for 22 hours, one will work for much more longer. Why is it the time in range in 24 hours is better with the U300 than U100?
Yeah, U100 has not been studied, sir. It is not, U100 is not been studied Lantus-wise, but that is a comparator of a Tresiba. So I'm talking about Deglutec. That has been
That's why
compared.
the question is, why is it, can Lantus maintain time in range?
Better in this thing. Now, I think if you've seen, both the molecules have performed well, and it's a non-inferior thing, and it doesn't show, I mean, the whole point is we are establishing a concept, and we are proving that the concept is better with both molecules, and I mean, if you see some other presentation, there will be, data will be, there will be another study that is comparing and saying apples are better than oranges. So I think what we got evidence now, and it shows this thing, you can't get an explanation, but probably protein bound, or we don't know much more about it, but I think clinically we know these are all excellent safe molecules of basal 2s, and it proves that even the technology wise also it's very good.
Any other questions from the audience?
What would be the starting dose for this thing? It's
Basal
like,
insulin.
Basal
Yeah.
insulin. 300 and 100, is there a difference? How we start?
Not really, not really. I think you can go, I mean, what we teach is 0.2 to 0.4 units per kilogram. So anything between, if it's a 60 kilo, you're talking about 10 to 12 units of insulin as a starter. And you can go as low as 6 to 8 units as a basal. And then you can titrate it, because the main thing, the patients, you want to get the patients in your side. How do you get the patients in your side? When you have an insulin, when they don't get a hypo, and it's a simple technique, and the pressure and the pen has to be very friendly. I remember those days of auto pen when I was in training in almost 2000, 2001, when Lantus been launched 22, 23 years ago. But at that time, you can imagine auto pen, you can't give more than 40 units. It's a horrible pen, but it's been evolved. So there are user-friendly things for patients, and simple thing, you get the patient in our side. And for that, I think you have to start with small dosage and get some basal insulin like this, and they will be in your side.
Thank you. Thanks for the excellent talk, Dr. Suresh.
Thank you so much.
I request Dr. Sanjeev Rao to felicitate Dr. Suresh Damodar. With that, we would like to invite Dr. Surekha Shetty to chair the next session, and welcome our speaker.
Good afternoon, everyone. It's indeed a pleasure to be part of this summit organized by Disha team. At the outset, I would like to highlight the fact that in our clinical practice, we all see how the newer molecules have changed the way we treat our patients. These newer molecules have not just significant glycemic benefit, but also come with a lot of non-glycemic benefits. To enlighten us more on this, we have with us an eminent speaker, Dr. Arpan Dev Bhattacharya. Without much ado, I would like to hand over the mic to him, sir.
Thank you. Good afternoon. Thanks, Dr. Surekha. And ultimately, I am here every time Manohar tells about Disha. Ultimately, I am here. Something or other comes in between, and Disha and me. So next around 20 minutes, we're going to take you through this multifactorial approach of type 2 diabetes, role of once weekly GLP-1 receptor analog. We are going to talk about cardiovascular outcomes. So some of these trials we have participated in, all of them, most of them are in Manipal Hospital, like Altitude, Alicardia, Canvas, Devote. Devote we actually compared with the Digludec and U100 glargine. It showed definitely the lesser hypoglycemia with the Tresiba. I do not have any share in the pharmaceutical company. This part of the meeting, I believe, is sponsored by Cipla. But looks a bit of very serious, and don't expect that I'm going to tell you anything that you've never heard. It's just a presentation. Sometimes we need this so that we can keep ourselves up to date with the information available to us and get a bit better quality of care to our people. So let's see the keywords. Now keywords are mainly two. One is a multifactorial approach. The days have gone that we are only treating people of diabetes for glucose control. We need to consider some other things, which will come to that. And we are going to talk about once weekly GLP-1 receptor analog. For now, it is only Trulicity. Nothing else is there. Injectable semaglutide is available abroad. It is not available yet. What we have, oral semaglutide, which is a daily one. So there is no comparison. We'll be talking only about once in a week GLP-1 receptor analog. Let's see the next bit of it. The case take-up, as you learned in the 1980s, when we are in the medical college. You remember that is very nostalgic memory. Whenever you go from your higher secondary school to the medical college, you are excited. I'm not talking about ladies. You're excited about the boys. That will be something. Picture will be like this, that I'm just going to flick out. And this gentleman is a bit old picture, but if now actually is here somewhere, it looks like this actually. Where is he? He's gone. Is your picture? Me. I am there. My job was, I only could do that. From a distance, I could see that only. Okay, forget it. So, our teacher showed that whenever people have diabetes, you should have a one-page format. And that's really a good teaching. Like, what's the age of the patient, sex of the patient, social status, osmotic symptom, how was diagnosed, infection, what is the treatment, what is the control, and then complication. There are two complications there, acute, chronic. Acute, hypo, decay, honk. Chronic, nephro, neuro, retino. That's all our diabetes approach. Now, in this context, if you see, we are talking about efficacy, glycemic efficacy. Now, this slide shows the gray color is placebo as opposed to Trulicity. Obviously, there is a good HbA1c control. So, no doubt that first thing, we are very clear, it is good in the glycemic efficacy. If you compare this with now liraglutide, that's interesting. So liraglutide is 1.8 milligram daily, and we are comparing with the dulaglutide 1.5 milligram once in a week. Okay, and most of our people in India, the liraglutide actually take 1.2 milligram. Very few people take 1.8 milligram, partly because of the cost also. And you see that very good comparable report. So once in a injection, once in a week injection is equally comparable to once in a day injection. Next question comes about durability. It reduces sugar. Does it stay back like that? Yes, it is. At least 2 years, randomized control trials are there, very nicely staying, and that's our clinical experience. Some of the people are so fond of this molecule, I can take 5 days or 8 days or 9 days, you just continue that. Weight control is very, very important. I think 3 million years of evolution, actually not much actually lost other than some hairs. It looks like same only. And somebody actually told some Egyptian proverb I could find out in preparing the talks. 1/4 of what you eat, it keeps you alive. And the rest 3/4 keeps your doctor alive. So weight control in diabetes is very important. Any medicine we are using, it should be weight friendly. It should reduce some weight, and that's very beneficial for us. And here, if you see the comparative data of the award series, first one comparing with liraglutide, background of metformin, good weight reduction. Comparing with insulin glargine, obviously you see insulin weight will go up. There's no surprise. It's favorable report. And also elderly people with a multiple short-acting insulin like insulin Lispro, is good weight reduction. That's beneficial point. Hypoglycemia, no hypoglycemia should happen with this, quote unquote. Diet also can get hypoglycemia. So basically there is nothing to worry about side effect other than the initial gastric side effect. Now, that's a composite outcome concept. The composite outcome means HbA1c less than 7, no weight gain, and no hypoglycemia. Now, if you see this award series, 1.5 milligram dulaglutide, the yellow bars are actually on the top of most of these award series. So basically what we are trying to tell, if you take 3 parameter, HbA1c less than 7, no weight gain, no hypoglycemia, it is better than all other existing molecules. Insulin also will reduce very good HbA1c. Obviously, the hypoglycemia chance will be there. Now, from 80s, you have seen that microvascular complication. Do we have any data? We have a little data from the REWIND study, which is a cardiovascular outcome trial with the dulaglutide, which showed some information that, so for the eye is concerned, the red color is the dulaglutide, blue was the placebo, and the macroalbuminuria is concerned, there are some benefit effect with the trulicity. And when you compare actually with the insulin, in this study with the insulin glargine, the bottom is, this pointer is, this bottom is actually dulaglutide. Is actually, you can see the big drop in the albuminuria status improvement. We have some data. We are not telling that we are going to use dulaglutide because of microvascular protection or something, but we have some data to suggest that this does good beyond glycemic control to the microvascular complication. Now from 80s, if you came today, you'll remember this is probably my picture only. I used to be very naughty and my mother used to do the whole day or outside only playing, come inside at home. And nowadays it is the opposite. Whole the day was with the gadget sitting in, no vitamin D is there, come, go outside and the play. So now the picture is little bit came. Now when you the complication status, you have made acute chronic same, but chronic you have a micro and macrovascular complication. And that's what is important because we understand that 75% of the people with the type 2 diabetes, the mode of exit is atherosclerotic cardiovascular disease, whether it is CAD, CVD or PVD. And also we came to know about the heart failure, whether it is reduced ejection fraction or preserved ejection fraction. Now question comes, why bother about ASCVD and heart failure? Simply because the macrovascular complication is a very big issue, stroke, heart disease and peripheral vascular disease. Whenever we are treating the person with the diabetes, glycemic control, we need to remember there is a big boss standing behind whom we need to control. Otherwise, just controlling HbA1c will not do any good. Impact of diabetes on the cardiovascular disease, the left, the men, right, women, and it is very, very clear that if you have diabetes and MI together, your cardiovascular mortality is much, much higher than anything else. So we have seen this data more than 20 years, so we know this. And also, important, a very important slide is that after around 10 years of duration of type 2 diabetes, your cardiovascular risk just worsens like anything. It's a very big risk factor. So whenever we are treating, we are talking about multifactorial approach of the GLP-1 receptor analog, we need to think of this. And this gives us the concept of better vascular protection with the GLP-1 receptor analog, and that's the REWIND study. India was not part of this trial because that time DCGA had some problem. So essentially what happened that background care, standard of care, one arm got Trulicity injection once in a week, another arm got a placebo. And here we see the benefit. So for the 3-point MACE is concerned, MACE stands for Major Adverse Cardiovascular Event, which is MI, non-fatal MI, cardiovascular death and non-fatal stroke, which is better with dulaglutide in comparison to placebo. So we have some data for microvascular protection, good data for macrovascular protection, and we have the composite data point of HbA1c, lowering HbA1c and no hypo and weight loss. This is just another curve to show that most of the round dots you see left of one, which is in favor of dulaglutide. Now, this REWIND trial, one thing is very, very unique. So you and me, when we are in the clinic, not the cardiology clinic, in our diabetes clinic, type 2 diabetes we pick up, around 60% will be having a risk factor, no cardiovascular disease. Disease means either an angina or a PTCA or a CABG or angioplasty done or something like that. Only 32%, around 30 to 40% will have the disease. That's exactly, this is the reflection of the rewind data. That's why rewind is a very sort of a natural reflection of our clinical data. And interestingly showed that whether you have history of cardiovascular disease or not, your benefit is there. So people with a risk factor, no cardiovascular disease, have the equal benefit. People with cardiovascular disease had a MI before. Secondly, whether your HbA1c is less than 7.2 or more than 7.2, the benefit are same. So this is something like beyond glycemic control of the benefit is there. Additional benefit, we talk about some reduction, increment of LDL cholesterol, but also HDL cholesterol goes up, so that is a favorable drop in systolic blood pressure. Little tachycardia is known for all GLP-1 receptor. That's probably not that harmful. Ease of administration, very, very important. Injection technique, it is all of us, as we know that, we have the experience. How difficult to convince somebody for an injection, the people with the type 2 diabetes. But here, the pen, the instrument that we are using for this is one of the unique of that, because so many factors, the needle is not seen, but is an use and throw, and that's what it happens. So this is the patient survey showed that 99% Trulicity pen easily, very easy to use. 98% told is very convenient to self-inject. 97% willing to continue using the Trulicity pen. I think all the time we used to talk about the insulin pen benefit, but this is one of the wonderful things people who have used, you know that how easy to use. And we don't, advantage is that we don't have to see this picture like that when you are giving an injection. You always prefer that fast injection to given by us so that patient understand rather than sending to a pharmacy or somebody else how easy it is. I'm not recommending that it has to be given to hospitalized patient, but at least good news is that some data is there. Hospitalized patient, non-critical, okay? If they are on dulaglutide, they can continue that, provided they don't have a non-GI admission reason. So the multifactorial approach, the way I started, type 2 diabetes, roll up once weekly. You will remember the STENO2 trial, which showed that everything should be taken care of, lifestyle modifications, stoppage of smoking, glycemic control, lipid control, platelet inhibition, blood pressure control. Here we have a molecule which is good for a complex disease like a type 2 diabetes of any duration, of any HbA1c, and the vascular risk of which is maximum. So early intensive treatment of this type of people, this type of preferred molecule, once in a week injection, is actually very favorable. It is the first agent of this group to show the cardiovascular protection, highly effective in the glucose lowering agent, improvement in the weight, reduction of the cardiovascular event, as I told you. And because of once in a week, the compliance is very good. As you understand that once the compliance is good, the control essentially will be good. And this is very simple. The device is an additional point for this, using this. So truly more doses, more possibilities, powerful efficacy, potent cardiovascular benefits, simply delivered, sustained release, and then we can sit and relax and enjoy the benefit of it. Now, this slide actually given by Dr. Ganapathy is coming soon to talk, but I am very scared. I am decided to stay back with Disha for some more time. Thank you very much.
Thank you so much, sir, for an excellent talk on GLP-1 agonist, especially the dulaglutide. And I think it was a very interesting use of humor to get the message across. Now, I'd like to request the audience to have any questions, please.
How serious are the GI side effects, sir, in your patients? Not about that.
Exenatide, which we started using probably around 2001, 2002, was quite a bit of a problem. We used to give 2 injections, if not 3. Then when liraglutide came, probably a little bit was a bit better. Then once in a week is certainly good. So clinical trial-wise, around 5 to 10% get effect, GI side effect, but by around 4 weeks, this become less than 1%. Our experience-wise, it's one thing that we are very clear from the beginning only we tell that. So they expect that what to expect. They know that. So this is one thing that we tell, this is going to happen, this is one of the way this medicine works. And we are seeing very less, but very rarely I did have to stop somebody for side effect, but usually we give after metformin. So don't quote, my experience is that, or understanding is that people who do not tolerate more than 1 gram of metformin, probably better not to go to GLP-1. One patient happened that recently from once in a week, his injection, so we changed new tab, they read somewhere that oral GLP-1 came, so I have changed to them. And side effect is so much after 7 milligram, that is second month, came back and changed back to Trulicity again. 1 or 2 days, little bit discomfort I can tell. So in general, it's not a big issue, but some people, yes, it can happen.
Thank you, sir. I usually give it on Friday evening, most of my patients. So Saturday, Sunday, they are at home, they are comfortable.
Initially, correct.
Initially, so.
Correct. The
does that
Saturday,
make,
Saturday evening you are you are taking that. So usually we try to tell to not to take in the after meal because sometimes they vomit or something. And we, after giving that, we will say you adjust the dose. Only within 3 days you should not get 2 injections.
I had a question, sir. With the advent of the oral GLP-1 agonist, we are seeing quite a few patients who are on metformin with DPP-4 being added GLP-1 agonist. What happens when we use both DPP-4 and GLP-1 agonist together?
At this point, science doesn't allow it. We are supposed to stop the gliptin and get the GLP-1 receptor. We don't have any study which showed a combination is that, and scientific, conceptually, doesn't make much sense because once you are gliptin, you are putting the GLP-1 at the physiological level. But whenever you're using GLP-1 receptor analog, we are putting into pharmacological level. So automatically level is very high. I don't know the rationality, but licensing-wise, we are not supposed to use. I was asking a question. Okay.
Thank you. Thanks a lot for the excellent session. I request Dr. Sridhar to felicitate the chairperson and the speaker.
Luckily, Arpan sir didn't have my photo, and I won't go to him by chance if I develop diabetes to take Trulicity, not on a Friday night. So moving on to the next presentation, I would like to invite Dr. Suresh G. Kolhapuri, consultant physician from ISRO, to chair the session. And very important topic, I think Dr. Arpan was alluding to it, that we are moving away from glucocentricity. So in that line, like, the topic is preventing and managing cardiorenal risk of diabetes dyslipidemia. And Dr. Shrikant Shetty is the speaker. Welcome, sir.
Hello. Hello. First of all, I would like to thank Disha team for inviting me to chair this session on prevention and management of cardiorenal complications in diabetic dyslipidemia. I invite Dr. Shrikant B. Shetty, Senior Consultant, Head Department of Cardiology, Sakra World Hospital, to give his talk on the subjects.
Good evening, everybody. Respected chairperson and my dear friends. So it's a privilege always to address all of you, and I thank Disha for this opportunity. So I'm going to be talking about preventing and managing cardiorenal risks of diabetic dyslipidemia, or rather, the talk is about preventing and managing cardiorenal risks in diabetes. So this is a case of a young gentleman who's been newly diagnosed with type 2 diabetes, who has HbA1c of 8.4%, almost normal BMI, blood pressures in the pre-hypertensive level, LDL cholesterol 110. And how do we manage this patient? So he was prescribed metformin with dapagliflozin, and we will look at whether this is a rational way of managing cardiorenal risk in somebody who's newly diagnosed diabetic. So diabetes, we know, is a chronic progressive disease, and if I say that now, it would be cliched. So a lot of diabetics are diagnosed when they do not have any end organ manifestations. There are others who already have manifest vascular complications. Now, how do we approach these patients? Those who are diagnosed very early on in their natural history, are they really low risk? And by choosing the right kind of medication, how do we prevent their future cardiovascular and renal risk is what we are going to look at in this talk. So we know that heart failure, renal disease and type 2 diabetes often coexist. Heart failure itself has a very big global prevalence and in India as well, because as our population ages and with an increasing burden of diabetes, hypertension and coronary artery disease, the burden of heart failure in the country also increases significantly. And diabetes being a major contributor to coronary artery disease and heart failure, how we manage diabetes very early on in its natural history becomes very important. And we'll examine whether we can reduce the risk of future heart failure events for patients of diabetes at their onset of diagnosis. And kidney disease, again, a much bigger global prevalence than heart failure itself. And there is a very close interplay of heart failure and renal disease. It's a vicious cycle because one worsens the other, and the presence of renal disease in patients with heart failure complicates our choices and also significantly vitiates the outcome for patients with heart failure. And heart failure, we know, as it is a very a dreaded disease with prognosis much worse than most cancers, and there is still a lot left to be desired in the management of heart failure. So preventing heart failure should itself be a very important consideration in patients of diabetes. And 24% of patients with type 2 diabetes have heart failure as their first cardiovascular manifestation. This is very interesting because we often see heart failure as an end effect of chronic vascular disease, but in patients with diabetes, 24% of them have heart failure as their initial manifestation of cardiovascular disease. And 58% of type 2 diabetes in their lifetime develop CKD. So as far as cardiac function itself is concerned, there are several ways in which it can manifest. 1/3 of the patients with type 2 diabetes diagnosis, they have normal LV function. 16% of them have diastolic dysfunction, and 27% of them have systolic dysfunction, and 25% of them have systolic and diastolic dysfunction. So this is a combination which is almost always present. So 68% of patients who had type 2 diabetes had for a median of 5 years showed signs of LV dysfunction in the absence of even inducible ischemia. So diabetes itself can be considered to be stage B heart failure. So therefore, early diagnosis and management of asymptomatic LV dysfunction and diabetic cardiomyopathy becomes very important to prevent progression to manifest heart failure resulting in hospitalization or impaired quality of life. Now, this is a slide which is shown in probably every presentation here. So the 7-year incidence of CV mortality in diabetes versus non-diabetes. Those who have diabetes with no MI have the same risk of recurrence of vascular events as a non-diabetic with a prior myocardial infarction, and that's why we know, it has been said so many times now, that diabetes is considered to be a CAD equivalent. And in diabetics as well as in non-diabetic individuals, the CV event rate is linearly related to the level of LDL cholesterol, and this is more striking in patients with diabetes. Therefore, you will see that all the guidelines for management of dyslipidemia advocate a very aggressive management of LDL cholesterol in patients with diabetes. Now, it's been a while now since the advent of the classes of drugs, GLP-1 receptor agonists and SGLT2 inhibitors. Prior to that, adequate glucose control, while it is fundamental to the management of diabetes, did not seem to reduce the risk of heart failure events like what these trials trial showed. Now this has changed with the advent of the newer drugs. And similarly, optimal risk management, whether even when you control systolic blood pressure, diastolic blood pressure, HbA1c, lipid, or whether you are using ACE inhibitors or not, aspirin or no aspirin, what you find is that in diabetic patients with the conventional therapies, residual nephropathy risk continue to remain. So there is a significant residual nephropathy risk, so which means that there is a lot to be done in terms of reducing long-term renal risk. So in a patient like the gentleman I alluded to, the aims of therapy will not only be of treatment of hyperglycemia, but also to prevent cardiorenal complication and also aggressively manage lipids, because like we saw, there is a strong linear correlation between LDL cholesterol and cardiovascular risk in patients with diabetes even very early on in their natural history. So we will look at how dapagliflozin bridges this gap in terms of reducing CV risk as well as renal risk. In terms of efficacy, though this shall probably not be the most important part of my talk, for completion's sake, in terms of HbA1c reduction, most of the trials showed that as an add-on to conventional therapies, whether it is with metformin plus sulfonylurea, or with exenatide once weekly, or with dapagliflozin, sitagliptin, metformin, etc., or with insulin, dapagliflozin has additional benefit in terms of reducing the HbA1c. Therefore, it's a good drug to control hyperglycemia itself. And with all kinds of combinations, dapagliflozin helped achieve weight reduction. So what is the evidence in terms of prevention of renal risk as well as prevention of heart failure and CV death? Now, when you look at a trial like DECLARE, which had a large proportion of patients who did not have atherosclerotic vascular disease, meaning a fairly low risk population as compared to the trials that came later, like the EMPA-REG, which was almost entirely a CV trial, or the CANVAS program, or the VERTIS CV. So here, there were a significant number of patients who had no atherosclerotic vascular disease, almost 59%. Even in a relatively low-risk population or a population of diabetics who were very early on in their disease continuum, the drug was shown to slow down renal disease progression, measured in terms of the difference of sustained EGFR reduction by about 40%, or EGFR less than 60 ml per minute, end-stage kidney disease or renal death. So there was a significant reduction in patients who were treated with dapagliflozin in the DECLARE population. And it also had a favorable effect on albuminuria across the spectrum of baseline UACR categories, including patients with normal albumin excretion. And when you compare with the placebo, the probability that the albuminuria would improve either from micro to normo, or macro to micro, or macro to normo, or micro to normo, etc., was more likely to happen if you treated with dapagliflozin, and the deterioration from baseline was less likely to happen in patients who were treated with dapagliflozin as compared to those who were treated with placebo. And as would be expected, and as was proven in the subsequent trials on heart failure, even in this broad CV risk population, dapagliflozin demonstrated significant reduction of heart failure hospitalization and CV deaths, and fewer MACE events compared to placebo. Which means that very early on in somebody's natural history of diabetes, if you initiate this class of drugs, you can hope to slow down the progression of renal disease as well as reduce their heart failure and CV risk. And all these benefits are derived with a relatively good safety profile, as proven in DECLARE TIMI 58, DAPA CKD, as well as DAPA heart failure trial. So the entire spectrum of risk. And looking at the new evidence of dapagliflozin in the treatment of heart failure with reduced ejection fraction and CKD, and now even you have a trial of dapagliflozin for heart failure preserved ejection fraction as well, because till now we had no therapy, not even ACE inhibitors, ARBs, ARNI, aldosterone antagonists, none of them had proven benefits in preserved ejection fraction, but these class of drugs, SGLT2 inhibitors, have now been proven to be beneficial in preserved ejection fraction as well. So DAPA-HF was the first and the largest SGLT2 study in heart failure reduced ejection fraction, and it proved improvement in outcomes as well as symptoms. So there was a 26% relative risk reduction in the primary endpoint of CV death or worsening heart failure, and a reduction of all-cause mortality, which is very important. And DAPA was well tolerated in patients both with or without diabetes. So this trial included heart failure patients who were diabetic as well as non-diabetic. 55% of the patients were actually non-diabetic. So treatment with dapagliflozin reduced both first and recurrent heart failure hospitalization events, and quality of life also improved. There was a significant improvement in heart failure symptom improvement, and significantly reduced risk of CV death or worsening heart failure was noticed as early as day 28. So initiating therapy in hospitalized patients prior to discharge and maintaining it during follow-up is therefore very important, because you can derive early benefits in these patients. And we all know that patients who are discharged with a diagnosis of worsening heart failure or acute decompensated heart failure, they have a very high risk of repeat hospitalizations very early on after discharge. So introducing the guideline-directed medical therapies during the acute hospitalization is very important. And DAPA-CKD, this was the first and the only SGLT2 inhibitor trial for patients with CKD and with or without diabetes, and here it was shown to improve cardiorenal outcomes and reduce mortality. And this trial was stopped due to overwhelming efficacy, and this was the first trial to show a robust benefit of all-cause mortality reduction in patients with or without CKD. And also was seen in this trial heart failure hospitalization and CV death benefits in CKD patients, as seen in the DAPA-HF trial. So you have with the DECLARE, TIMI-28, DAPA-CKD and DAPA-HF trial, the entire spectrum of diabetic patients, from those with very early diabetes to those who have heart failure as well as CKD, showing benefit on treatment with dapagliflozin. So this is a summary of the findings of those three trials. And in light of this evidence, the current guidelines from different organizations recommend that in patients who have atherosclerotic vascular disease or indicators of high risk, you should use either GLP-1 receptor agonists or SGLT2 inhibitors, which have proven CV benefit. In those who have heart failure, definitely SGLT2 inhibitors would be useful. Similarly, patients who have CKD with albuminuria and without albuminuria, this class of drugs should be used. And in light of the evidence that is available from the DECLARE trial, it could also be used as an initial monotherapy in patients who are diagnosed with diabetes. Now coming to lipids, which form a very important part of the CV risk reduction strategy, we know this timeline of atherosclerosis, which is always spoken about, that you can either stop the disease in the primordial stage when you prevent the onset of risk factors, or you treat it in the primary prevention state when there is a normal artery. What happens mostly is that you will identify the vascular disease when it manifests clinically as an event, such as an MI, or when a patient undergoes an imaging like a coronary angiogram and the patient undergoes angioplasty or bypass surgery. What is most challenging clinically is to identify the patient. So the second one becomes secondary prevention. What is most challenging is to identify the patient when the patient is in the subclinical phase, which is something that runs for decades, and most challenging to identify because there is no external clinical manifestation, and you have to use certain diagnostic modalities which cannot be very expensive, and you should be able to replicate them regularly. For example, ankle brachial index, the carotid intima media thickness, maybe coronary calcium scoring, to identify subclinical disease. And if you manage risk factors aggressively at that stage, you can prevent their transition into the secondary prevention cohort. So we know that over years it has been recognized that treatment of LDL cholesterol has to be stratified as per the risk category of the patient. Now, so the ESC guidelines, for example, divide patients at vascular risk as very high risk, moderate risk, and low risk. And when you look at the patients who are deemed to be at high risk, this includes patients who have diabetes with target organ damage, or at least 3 major risk factors, and patients who have had an early onset of type 1 diabetes of long duration, more than 20 years. So in these patients, you have to try and achieve a LDL of less than 55 milligram per deciliter and a 50% reduction of LDL from baseline. So again, this is a category where there is no manifest vascular disease. And patients at high risk, that is diabetes without target organ damage and with diabetes more than 10 years or another additional risk factor. Here, you have to target LDL to be less than 70 milligram per deciliter and reduce LDL by about 50%. And moderate risk, these are young diabetic patients with diabetes less than 10 years and calculated score risk of between 1 to 5%. Here you will target the LDL to be less than 100, which means that pretty much in every diabetic patient, you have to get your LDL cholesterol to less than 100 milligram per deciliter. And statins are the recommended modality for bringing down the LDL cholesterol. So you should first try and achieve intensification of statin therapy, that is the best tolerated dose, before considering the introduction of combination therapy, that is ezetimibe, bempedoic acid, or the more expensive drugs like everloxumab or inclisiran, etc. So, and we know that there is a proportionate reduction of vascular event risk when you reduce LDL cholesterol, which means if you reduce the LDL cholesterol by 38 milligram per deciliter, you reduce the vascular event risk by about 21%. So greater the reduction in LDL cholesterol, greater is the vascular risk reduction. So you use a drug that is powerful enough to achieve the LDL target, then that translates into better vascular risk reduction. So in the Jupiter trial, rosuvastatin helped reduce LDL cholesterol by 50% in 1 year. And this results in a CVD risk reduction of about 44%. So if you compare the benefits of rosuvastatin against atorvastatin, it is found that rosuvastatin is more potent and helps achieve a better HDL to LDL cholesterol ratio. So in a patient like Vijay, so you start a drug like dapagliflozin along with metformin and achieve your HbA1c target, reduce weight, control blood pressure, and get the LDL cholesterol down to 72 milligram per deciliter for a better long-term CV and renal risk. So to summarize, dapagliflozin reduces hyperglycemia with low risk of hypoglycemia, and it has been proven to reduce vascular and renal risk at all stages of disease, can be effectively combined with other classes of antihyperglycemic, reduces weight, blood pressure, and provides cardiorenal benefit. And with respect to lipid reduction, rosuvastatin is a very potent statin with superior LDL cholesterol reduction and reduces vascular risk more effectively than atorvastatin. Thank you.
Hello. Thank you, Dr. Shrikant Shetty, for the excellent illustration. I invite any questions from the audience to Dr. Shrikant Shetty.
How quickly after the ACS we can start SGLT2? Patient is admitted with ACS, with heart failure, with the diabetes. How quickly we can start them?
So, if there are no the typical contraindications for using SGLT2 inhibitors, if the patient is not on IV diuretics, then it's a good time to start the SGLT2 inhibitor. The last dose of IV diuretic should be at least 6 hours before you initiate the SGLT2 inhibitors. In patients who are on Riles tube feed or patients whose nutritional intake is not assured, then in that situation you wouldn't use SGLT2 inhibitors because of risk of inducing ketosis. So otherwise, I think in stable ACS patients you can initiate SGLT2 inhibitors in hospital itself.
Thank you.
Can I ask you a question? What's your sequence of medication for heart failure? What is your take on that? MRA, beta blocker, ARNI, and gliflozin.
Yeah, this is a very important debate. So, in hospital, when we discharge a patient with ADHF, we have to make sure that the patient is on beta blockers, because beta blockers are the drugs which produce the highest reduction in sudden cardiac death. So, which is the most important endpoint with heart failure treatment. Now, but before you initiate beta blocker for hospitalized patient, you have to achieve a dry state. That means the patient should not be in congestive heart failure. And if your blood pressure allows, then you can add ARNI, and in hospital you can start SGLT2 inhibitors, because SGLT2 inhibitors are not so sensitive to the blood pressure. The other class of drugs that can be started in patients who have borderline blood pressure are mineralocorticoid antagonists. So the choice of deciding which drug will depend upon 1, the blood pressure, 2, the patient's renal status, 3, volume status, 4, and the electrolyte situation. All of these have to be considered, and then you have to individualize the therapy. But we have to make sure that the patient is initiated on most of these drugs prior to discharge. Because for each one of these drugs, it has been found that if the drug has not been brought on board, then the likelihood that the patient would be started on these medication and optimized during follow-up is very low. For example, trial shows that if a patient has not been started on ARNI at the time of discharge, then over 6 months, the probability that the patient will be on ARNI is very low. So, in patients who are hospitalized with worsening heart failure or decompensated heart failure, you have to keep the patient longer than probably you would like, because you have to have sufficient opportunity to initiate as many of these medicines as possible and make sure that the patient is stable on these medications prior to discharge. This is a little different from what you do with patients who are admitted with acute coronary events or even acute myocardial infarction, where you rapidly triad them to revascularization, and early discharge is known to be beneficial. But for patients with congestive heart failure, keep them longer in the hospital, transition carefully from diuretic infusions to boluses to oral diuretics, make sure that the patient is stable on oral diuretic dosages, add as many of these guideline-directed medical therapies prior to discharge. Low beta blocker dosage at discharge is better than no beta blocker dosage, because it is important to get the patient on beta blockers prior to discharge, because beta blockers are the one that have the highest effect on mortality. The other class of drugs that has the highest effect on mortality amongst heart failure patients, you would surprised, would be SGLT2 inhibitors.
Thank you.
Thank you so much.
Thank you very much. I would like to ask Dr. Vijay to felicitate the speaker and the chairperson.
So we'll move on to the next presentation. I would like to invite good friend Dr. Hem Kumar, consultant at Sakra Hospital, to chair the session. And an interesting topic, I think the way forward, if you were supposed to say, digital therapeutics and digitalization of clinical practice. I think that should be the rule possibly in the future.
Yes. So, good evening, everybody. And digital therapeutics is an interesting topic. So, the medical practice started with digits. So, we started using our digits to feel the pulse of the patient. And now, pandemic has pushed us into a situation where we use our digits to push the mobile phones and iPads and the computers to have our clinical practice. I invite my good friend, Dr. Raja Indana, consultant physician and diabetologist. He is the medical director, MFine, so to give his speech on the digital therapeutics.
Thank you, sir. Thank you for this warm welcome. I feel privileged standing in front of my teachers, Dr. Sanjeev Rao, Dr. Arpan Bhattacharya, sir, and Dr. Manohar, and my colleagues, Dr. Vijay and Dr. Hem Kumar. So it's been a couple of years. I transitioned a little bit into entrepreneurial journey. I am a part of MFine in the management team. MFine is a digital platform which provides consultation and blood tests and long-term care programs, health outcomes-based programs at home for the patients. So today I want to talk a little bit about digital therapeutics. Me being a diabetologist, I had an interest. While I was practicing at GVK Hospital, I happened to meet a patient of mine. He's been very regular, religious, coming for follow-ups, a diabetes patient, young 37-year-old patient at that time, has been on DPP-4 and also on insulin later, but his HbA1c was hovering around 8, 7.5 in better control times. Apart from smoking, he did not have any other problems. But he said, "Doctor, I'm doing everything. But why are my sugars not coming down? And this insulin I'm putting on weight, what do I do?" I just spoke to a couple of my colleagues. I said that, okay, let him continue. At that time, there was no SGLT2 at that point of time. So we have been continuing on the treatment. Apparently, after a couple of months, he had come to me with a spring in his walk. He was very happy, and he said, "Doctor, you see my report. HbA1c is 5.5 or something." And when I asked him, "How did you achieve this?" He said, "I happened to go on internet. I went to YouTube. I met this doctor called Jason Fung. He's an Canadian nephrologist. He's a Canadian nephrologist. And he talks a lot about fasting, therapeutic fasting. And later, I happened to research on this topic, got into multiple websites, and ventured into this area of reversal of diabetes. And there are so many people who are putting this. There is Dr. Tripathi, Pramod Tripathi. He promotes about this. There are a couple of all these doctors who are doing this. Then I saw, okay, what is it? Is there a scientific way? How do we do it? How do we achieve it? Then I've gone through this topic called digital therapeutics. So it's an evidence-based therapeutic intervention driven by high-quality software programs to prevent, manage, and treat medical disorders. So this intrigued me, and I went deeper into it. And then we started doing various things which are focused on not just pharmaceutical way of managing lifestyle diseases, but can we achieve a better control of diabetes or thyroid, weight, or mental wellness through digital interventions. We as clinicians, the time we spend on elaborating all these factors is becoming minimal, because next patient is waiting. The patient, if you start answering one question, they have hundreds of questions. "Doctor, can I eat ragi? Can I eat ragi with husk? Can I eat rice? Can I eat brown rice?" So the questions are endless. So is there someone who can handle this part for us so that we can focus on what are the better outcomes? Somebody is taking care of all these in the background. So then we started thinking, okay, what all are available? So all of us, we are aware that there are numerous studies that are done which demonstrate the effectiveness of intensive lifestyle changes to manage these lifestyle diseases better. So these are a couple of things. So what does this mean? What do we do? With this part, digital therapeutics means there is an app-based consultation that can happen where the patient can come online, be with the doctor for the consultation time, can finish the consultation, take the advice from the doctor, and continue the treatment with his team. There is a team of nutritionists, there are a team of wellness experts, there are psychologists who actually have a multi-pronged approach to the lifestyle diseases where they are causing these micro changes of behavior in the smallest level. For the patient, it is at his comfort of his home. This is leading to these changes and sustainable changes. So what we did is this, as and when we saw a patient, if we feel that the patient is suitable, we recommend them to get onto this program. The patient details are shared with MFine. And then once the patient is enrolled, a consultation is created to the doctor online and also to the dietitian and also to the psychologist online. So all these happen in parallel, and there is a tracking of his meal patterns. There is a tracking whether he's doing how many steps on a day. There is tracking of his psychological status. All this with the help of an app-based solution where this was the initial amount of carbohydrate that he was eating, and this has reduced, and here is the amount of rice that he was eating, and the meal plate changes. So this intense connect with the dietitian is actually helping the patient to follow these interventions on a regular basis. So this is the fitness sessions that happen. So most of the time, people say that, okay, I'm doing 8,000 steps, I'm walking. But if you see, upper body also needs exercise. I think there is one more topic about yoga, how this helps, because the utilization of glucose is better when both upper body and lower body are utilized. So we have designed wellness sessions with our fitness experts, making sure that whatever is available at their home, as simple as water bottles, can also be used in keeping the patients active at home. So these weekly sessions have brought a certain rhythm in patients' change of behavior, thus leading to better outcomes. This is a small set of patients which we have taken, and the average weight was 76.5, and post 3 months of participating in this program, the weight loss was 4.9 kgs, and HbA1c, which was at the start of the program, which was more than 7%, there were around 68% of people who were above 7%, which has come down to 32%. And diabetes, which was HbA1c, which was around 32%, which was less than 6.99 to 5.7 was 32% before the start, and more people from this more than 7% have come there, so it has increased to 50%. And non-diabetic range, it has come to around 18%. This is within 3 months study. This was encouraging for us, so we thought we should continue this, and currently we have more than 1,160 patients who have enrolled into it, and people we have been following up. Maybe in the next session or next meet, we will tell you about what are the studies on it. So at MFine, it's not just only a consultation-based app. MFine also does a lot of AI-based interventions. So we have a mobile-based BP monitor and SpO2 monitor, a heart rate monitor, everything on the mobile. So what does that mean? If you put your finger on the flash and camera, there is a signal called PPG, which goes and collects the data and brings it back, and the MFine algorithm assesses what is the BP in it, what is the heart rate, what is the saturation. Everything can come on your mobile phone without any additional device. You don't need to have a watch, or you don't need to have any additional device. Just on the mobile phone, these digital tools can be done. So at MFine, we are providing all this, and what we thought is this, okay, if we can empower doctors. See, there are so many apps outside available right now. You would have been seeing, like there is SugarFit, There are multiple apps that are saying that reversal of diabetes and all. So there is $35 billion of money that is being spent on lifestyle diseases on a year. In 2021 alone, the health expenditure on lifestyle diseases is $35 billion in India. That is huge, right? Diabetes alone is around $20 billion. So I'm talking about the top three diseases, which are like diabetes, hypertension, and heart diseases. So where is this going? Most of it, 80% of it, is going in the pre-admission or outpatient side, which includes pharmaceuticals, which includes consultations, which includes nutritional interventions. So most of it is going there. What we thought is this: can we empower doctors so that the care of the patient in a better way can happen through doctors alone, not from an external party? So that is the reason we thought, okay, it is good to have a clinic program. Can we help doctors digitalize their practice so that whatever the channel is being used outside the doctor, why can't it be through the doctor? So that was the intention, and benefits of this is you can have an extensive digital presence. MFine is available online and also for your offline patients, but by a private teleconsultation link, you can see your patients. We, as a team, can have better clinical outcomes, and there are real-time trackers for vitals, and also if any investigations or anything is ordered, the doctor is aware that these patients' reports will come to them. You can track the order real-time there. And yeah, so if you need more details, this is the contact person. You can reach out to her. She's our director who handles this part of MFine. So you can reach out to her. She can give you more details, and we can maybe have one-on-one appointment with you whenever you're comfortable, and yeah, take it forward from there. So a small info about what MFine has been. It started in 2017. I was in the initial part of MFine, started it along with the founding members, and have been a great journey. We have been seeing more than 3,000 consults per day online, and till now we did more than 1 million users who are using MFine actively. Yeah, thank you.
Thank you, Dr. Racha. Being in IT capital of India, so I think technology is the future, and we all should be riding the wave of technology from the forefront. A few things, it's diabetes reversal or remission?
Yeah, I would say it is remission, because most of the times in our patients also we have seen where people did not follow this certain kind of intense therapeutic behavior, they are getting back to diabetic range. It is a remission.
Okay. Have you met artificial intelligence?
Hopefully I shouldn't get the chance to meet.
And does your app is from China?
App is not from China. It is completely built in India.
Somehow patients are very unhappy when we tell them about the lifestyle modifications in our clinic. Many of the times they are upset that don't eat this, don't eat that, and they don't want to listen to us. But I have seen some of the patients coming back from these type of newer technological apps and their reversal programs or follow-ups. They seem to be much happier with the coach. Somebody is behind them always, somebody is guiding them through the day and night, and they are more responsive and happier to start with. I think so all of us should be, maybe may not see this type of digital therapeutics as a competition. Rather, we should utilize them to our advantage in our clinical practice and make the patient's life better, and also we should also benefit and give more time to our family and our own occasion, so we can reduce our clinical burden by such digital therapeutics.
Yeah, I want to add here one point, Dr. So what we have seen is this, there are patients who actually come and say, doctor, so many medicines, every time I come, you're increasing medicines. This kind of comments have come. With digital therapeutics, what we are doing is this: we were able to reduce the pill burden. More than 78% of patients, we were able to reduce at least one medicine in them. So the health coaches at MFine are not somebody who is a pharmacist or somebody. These are MBBS doctors who are trained in diabetology and who are aware of every situation, what the patient can go, hypoglycemia, how to handle it. So all this, there are junior doctors. They only handle your patients, and if needed, they will reach out to you and then only inform the patient if there is any changes needed.
I just wanted to know what is the dropout rate, because there can be digital fatigue, no? I mean, it's like
Yes.
you are like one more big boss watching 24/7,
Yeah.
or a spouse who says don't do this.
Yes.
So I think apart from when you hike your subscription rate, they may default. Otherwise, what is the rate when
So around 60% are sticking to us. Yes, definitely. We also are working on this. If I have to say, how many of our patients come back to us if we say come back after 3 months? So similarly, even at this situation, I would say that 60% of people sticking to this program and making those changes is significantly good.
it can work either way, no? I have got a good response, so why I need this program?
Yes.
I can leave.
Yes, yes.
I trolled for 3 months, no use of this app. I can go out. So it
Yes.
works either way.
Yes, 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 doctor.
Fantastic initiative that you've seen through your own personal studies, Doc. And probably being, as Haim said, the IT sector of the Bangalore population is where we all are practicing. And a well-informed patient is a more responsive patient. A well-informed patient is a more successful patient in achieving the targets that we have set for. And we need to ensure that they are pampered in one way or the other. Given our constraints that we have in terms of time, efforts, manpower, all these things, we definitely need to use technology which is available. Unfortunately, healthcare has been a laggard as far as adopting technology is concerned. And this COVID pandemic has really pushed that adoption in a big way. And it is high time that we as core physicians capture this $25-30 billion business that is happening across, which is done by non-core medical
Yes.
practitioners.
Yes.
So I think hats off to you, and I think this is a way forward, and all of us need to adopt this technology in one way or the other.
Yeah.
And hats off to you. Thank you.
Thank you so much, sir. Here also I want to say that we keep you as a clinician, if let's say if it is Dr. Hem Kumar who is recommending, it's going to be Dr. Hem Kumar's diabetes or whatever your clinic name is, Dr. Hem's diabetes care program. It won't be any MFine, or your patient will be seeing your name and your clinic name for this program.
Yeah, thank.
Always lagging to adopt things, but somewhere we are not sure about the data privacy. Like if I have a lab, if someone we ensure to get into some platforms, not necessarily only ones. So we are worried that okay, tomorrow onwards they ask to test there, or this is the practical question.
Yes,
what
absolutely.
Pharmacy
Yeah.
delivery happens because everything is getting centralized now.
Yeah.
So that is one big inertia what I think we as doctors face when we try and adopt this digitalization. So
Yeah.
how do we get reassured, or what is the way out of
I would say it's only trial and error, Dr. Manohar. If you feel that there are trust issues, okay, all I would say is this: you can try trial and error. If you're finding it within 2 months or 1 month, this is not working out, I would say it's better we opt out. But if I have to say from MFine point of view, it is only about to empower doctors' practice and improve his consultations and improve his outcomes. That is the theme that we started with.
The questions of finances come. I may lose out on my pharmacy and my lab is the concern. I'm just telling this is what happens actually.
Okay.
So some people may share, like, for example, I have a lab and tomorrow they start doing in your lab or in your accredited lab or whatever lab. So, so this is one real barrier for many of us to adopt to this.
Yes.
So
that
that
is
is where
that is
we need
definitely
to
there, sir.
address that. Unless we take that out, I don't think we can make a huge headway into the real day practice and acceptance by the doctors.
As you said, sir, see, why do we have a lab? Basically to keep the revenue within us, right? So if that revenue is shared with you, what is the problem? That is one thing. There are different options like that. So I am saying that because if it is trust issues, whether the platform or anybody whom we are adopting, will they take away the patients? Will they move the business to theirs? But if the platform is sharing that revenues with the treating doctor, how does it make any change?
If I can, just Dr. Manohar, there are some guidelines speaking about these privacy issues, which are these like our ethical code of conduct for our research patients. There are certain guidelines which are there for data privacy issues. And people have to follow them, whatever they have to be whatever they have acknowledged on the paper. And there are companies who actually audit them, audit them through independent auditors. So, so that kind of things, if some company does follow, so then you are on a reasonable good platform, which tells that probably your data will not be taken for a toss, and it is not going to harm you that way. One thing, very nice inputs there. Just a bit of scientific thing. This was just a pre and a post thing. We would love to see something on an RCT basis, randomized controlled trial, wherein there are two arms and something, probably a more robust data. And what was the average age of the diabetes patients? Your degree of personalization will actually add that extra zing to your whole of this process.
Thank you, Doctor.
Thank you, Dr. Raja, for your very excellent presentation. So,
I would request Vijay to felicitate Raja and him. Thank you very much. And from one end to another end now, digital. To chair this session, we have Dr. Satish. I would request him to come over to the podium. He's a lead psychologist of Manipal Hospitals, good friend of mine. We have done a lot of work, learned a bit of mind from him. And in the COVID pandemic, he has done a great deal of work to the nursing staff, paramedics, and to many of the doctors like me, and helped us publishing one of the largest study about mental health assessment in the COVID times. Please take seat, and I would also request Dr. Hemant Bhargav to take center stage, and very important topic for all of us, I think, role of mind-body medicine, including yoga in managing type 2 diabetes.
Thank you very much for the and a warm greeting and good evening to all of you. I am Dr. Hemant Bhargav. I am MBBS. When we see patients of T2DM, who have to take medicines for a long time, and then when they take medicine, patients come to us. I was doing it from Government Medical College in Nagpur. So there used to be huge queue of the patients in the morning in the OPDs. And then, I used to wonder how 200, 300 patients we are going to see in the medicine OPD. But then as an intern, my work was to just write continue same, because the medicines were available for free and there used to be huge queue. So then, in between patients would ask, sir, I'm taking this medicine, what next? So this was the question in my mind. We all know that lifestyle is very important, but then incorporating that lifestyle is a challenge. So therefore, I decided that I am going to explore deeper into the area of lifestyle, and therefore I did my MD in yoga and rehabilitation and PhD in yoga, and got interest into yoga research, and then conducted a couple of randomized controlled trials, one trial in diabetes 2, which has recently been concluded, so I would be sharing my results with you. So basically, my talk, this 20-minute talk, first 10 minutes, I would like to give you an orientation to mind-body medicine, especially to yoga, and then talk about the evidence base. So this is, the talk of the day. Illness was one thing, where medicine focused, but now everywhere people are talking about wellness. So patients come to us, they say that, doctor, you say that all my reports are normal. My HbA1c is in normal range, my sugar is in normal range, my thyroid functions are in normal range, but I don't feel good. Though my reports are normal, I don't feel positive, I don't feel enthusiastic in my work. So the quality of life matters a lot. So therefore, a emphasis is there globally on the wellness domain now. So this mind-body medicine aspects, the uniqueness is that apart from helping in getting the patient back to the comfortable zone, it can further be delivered even to a healthy person to move towards positive health. So here, the lifestyle, we know that it consists of diet, exercise, habits, and the mind plays a very important role. We tell patients, all the consultants practice holistic medicine now. It is not that only, the people who are doing traditional medicine. Even in modern medicine, we see that a lot of advices are given about, regular exercise, going for a walk, and what kind of diet has to be taken. But then we see in our clinical practice that patients are not able to adhere to them. So why, say, a person has diabetes and he knows that I should avoid sugar, I should avoid fat, but then he is not able to control his sugar levels. So somewhere, everybody knows what is to be done, what is not to be done. But why is it then the compliance with the lifestyle change is lacking? So here, the mind plays a very important role. So the mind of the person, the emotions of the person in that state are not being, the person is not able to manage. So we see that there are demanding situations in life, there are external demanding situations, there are internal demanding situations, some goals that I set for myself, and some that come to me from the environment. And it is here, the psyche of the individual is constantly under pressure. The allostatic load keeps increasing. The hypothalamo-pituitary adrenal axis always, is upregulated, and you see the continuous release of cortisol that keeps releasing. The sympathetic nervous system keeps getting activated. And here, that psyche, that stress, which is the speed of the thoughts in the mind, over a period of time, starts affecting different domains of the life. Stress accelerates the aging process. Stress affects the immune responses. Stress creates an imbalance in the autonomic nervous system, and therefore it acts as a very important contributor towards progression of the disease and lack of control, especially in diabetes over the sugar levels. Now the mind-body medicine, it is a discipline which has recently gained more popularity. So the National Center for Complementary and Integrative Health, US, and it defines it as a discipline that focuses on the relationship between the brain, mind, body, and behavior, and its relationship with health. The predominant components that are included under this domain involve yoga, tai chi, guided meditation, imageries, biofeedback, mindfulness. Basically, the concept is mind over the body. So how much of the disease component, is contributed by the effect of the mind over the body, and if I am somehow, able to manage my emotions, will this translate into the clinical improvement, in managing the sugar levels, in adherence to the medications, the modern medications also. So in that way, this particular domain works. Yoga is considered as a very popular and, emerging mind-body medicine discipline. If you see 2 decades back, yoga was not that popular, and if somebody would ask about yoga, it would be considered, as something which is very secretive to be done by sages who are staying in Himalayas. But now, after 2015, when the first International Day of Yoga was celebrated, we saw that 194 countries, including Islamic countries, are celebrating yoga, removing those, religious component from it and taking it in a particularly very scientific, secular way. It has emerged as a science of the body, breath, and mind. And number of, researchers now, if you go to PubMed and just put yoga, you see 6,500 hits. And randomized control trials, 27 randomized control trials in diabetes itself. None of the trials shows that it is not effective or it does not have any kind of positive effect. So now, if we go back to the roots, Now if we ask what is yoga, a figure that comes to our mind with imagination of yoga is some very lean, thin figure doing an advertisement in a television, Shilpa Shetty kind of a yoga. But now, if you look at the tradition, the fundamental goal for which yoga was designed was calming down the agitations of the mind. Now, is it not a major issue now? Is it not a major component, psychosomatic component in all the patients that you see? How many of our patients come with those non-specific complaints, for which we don't know what to do? So it is here the mind that is playing a very important role, and the sage Patanjali in 400 BC defines yoga chitta vritti nirodha, repeated patterns of thought which are charged with emotions, again and again repeating in my mind. Whether it is an interpersonal relationship related conflict with the boss, my pressure related to work, or my own demanding situation on my own perfectionism in my work. So these repetitive patterns of thought, there is no salvation. And especially with the current situation where we are exposed to, the mobile phone, so many WhatsApp group, Instagram, Facebook, there is so much stimulation to the mind every minute that there is no calming down. We call it as Abhimanyu syndrome. We know how to go deep into an issue, intellectually dissect the issue, have deep debates, but emotionally, when it comes to emotion, we are stuck. We just don't know how to come out. So it is here that this particular, the wisdom that is available in our ancient literature. So this Katha Upanishad is a dialogue between Yama and Nachiketa, where a structure of the body, the system is given. The chariot, kind of a parable, where the 5 horses are the 5 sense organs, and then the reins are the mind, which is connected to each of the sense organ. And the buddhi, the intellect, is trying to control these horses through these reins. And then there is an observer. There is a witness, a sakshi sitting behind, looking at the whole scenario. Now, if you look at this whole system, in current scenario, the horses are going haywire. What governs our life? What governs the direction in our life? These are momentary sense pleasures. Whatever our senses draw, we move towards it. Now you keep scrolling. Now earlier, in the newspaper in Times of India, if you go, the news would end, but now it continues. You can keep scrolling, related news keep coming. So we just keep getting drawn and drawn and drawn, and we don't know where to stop. Shut Clinic, Nimansa has started Shut Clinic, where every week we are getting 4 or 5 students, young students, getting addicted to internet, mobile phone, gambling disorder throughout the day. So from morning to evening, the person just comes out to have food or tea and goes back again. He just do not want to interact with anybody. So this is the situation of the youngsters in the country. And now here something is required. Our whole education system is drawing us out. Everything is drawing us out. But is there something, is there something that is giving me an equipoise and telling me that I have to turn within as well? Because the consciousness has a domain that moves out, that is in the external world. Consciousness has the domain that projects in the mental world or thinks. And there is a third domain of consciousness which turns inwards when I go into deep sleep. Now that is also a very important aspect of my personality, because there I get recharged for my functions. It is here that I get control over my emotions. Otherwise, if everything keeps drawing me out, the vehicle will cross a certain threshold and accident is bound to happen. So here comes the science of yoga, which says, take a pause, come back to the present moment, and then turn inwards. So turning inwards is focusing on this Atman, this consciousness. Bhagavad Gita describes that the model in which this human body should function is the consciousness, which is the witness, the sakshi, has to be cultivated by active efforts. In Vipassana meditation and other meditations, they cultivate this kind of non-judgmental observership. And then that gives the freedom and power to the intellect to control the mind, and the mind controls the senses, and then the body is governed in a particular direction. So there are different schools of yoga. Now unfortunately, branding of yoga has made yoga also lose that essence. We see now power yoga, even beer yoga getting popular. So it is very important that the essence, what our sages told, is retained. So the whole essence of yoga is you turn within, you take a break. So there are schools of yoga that have come up. Some focus on the body related aspects, some focus on the breathing related aspects, some exclusively focus on the mind, others use all of them together. But the ultimate aim of all these schools of yoga is to slow down the speed of the thoughts in the mind. And that is done by using the body, the breath, and the mind directly in the same sequence. You start with the body, then go to breath, and then prepare yourself for meditation. So this is a very common thing, in our practice. It is very easy to go to gym, to tell them to go for a 45-minute walk. American Diabetes Association also says every 30 minutes you do some 5 minutes of, movement, exercises. So why yoga then? Why yoga if exercise can suffice? So what is happening here is that the steadiness aspect of yoga, the mindfulness aspect of yoga, whichever part of the body that is stretched, the mind goes there. The breath coordinates with the body. So the coordination of the body, breath, and mind together in one sync is not happening when you go for a walk. What is happening to the mind? Even if I am walking on a treadmill, I am going for a walk, the mind keeps wandering. That loop, that chitta vritti is not breaking. So it is here that yoga brings back, using the body, using the breath to the present moment first and then turns inwards. So is there a connection, between body, breath and mind? Which posture would a person adopt, when he is very sad? Which kind of posture would a person adopt naturally, subconsciously, when he is very happy? Any comments? Sadness, what it does to the body? There is flexion. There is drooping of the shoulder. Everything goes down. But happiness opens. The head opens up, chest opens up. So a person who is sad, a person who is happy, there is a particular change in the body posture with the emotions. Now, will it work the reverse way? If a person is depressed and if I tell him, do hands in and out breathing. Breathe in, gentle smile on the face, breathe out. Now this is the breathing of happiness. It gives a feedback to the brain that my mood is changing, I am becoming positive. As simple as this. So all our yoga modules here focus on the backward bend, opening of the chest, especially in chronic diabetes where depression is a common comorbidity. Similarly, breathing patterns are associated with different kind of emotions. Researchers have now clearly demonstrated that the shallow breathing, which is more thoracic, activates the sympathetic nervous system continuously and a vicious cycle comes up. The noradrenaline, cortisol keeps releasing. Just take a pause and observe how are you breathing. Is your breath more shallow or more deep? Is it more abdominal or more thoracic? So what kind of, breathing brings a state of parasympathetic dominance instantly? It is very simple. You have to shift it from thoracic to abdominal and reduce the rate to less than 6 per minute. And inhalation is to exhalation ratio of 1:2. Just do it for 15 breaths and you are bringing a shift in your nervous system. So we all know how important it is to bring vagal dominance for the function of the, endocrine system. So there are different beautifully, designed pranayama techniques. They all come from US now. So it is, very disheartening. They take this kind of breathing technique and call it as cardiac coherent breathing, and there is no mention of Patanjali, no mention of Hatha Yoga Pradipika, and then they patent it and they say that, yeah, this is the breathing that we have developed for anxiety and for reducing the blood pressure. So therefore, this kind of passion is there that more research has to be done using our traditional techniques. Now researchers have clearly shown that the right nostril, which was traditionally called as the Surya Nadi Pranayama, if you just sit and breathe in and out from the right, it activates the sympathetic nervous system. If you breathe in and out only from the left, it activates the Chandra Nadi, the parasympathetic nervous system. If you do alternate nostril, it also activates parasympathetic, but lesser than the left nostril breathing. So there is a clinical application of these kind of breathing techniques. Now researchers have clearly shown that there are receptors at the internal nasal meatus which are connected to the hypothalamus and thereby to the autonomic nervous system. Researchers have also shown that if you breathe in through the mouth, it does not have that impact that you breathe in through the nose. So through the olfactory bulb also there are connections to the different brain networks now. So this I was talking about, that the slow paced breathing, less than 6 per minute, and prolongation of the exhalation. So here we see that the pain threshold, with the pain threshold goes up, people can tolerate pain better. Also, it is the locus coeruleus activity in terms of pupillary dilatation has been shown that if you exhale longer, then you can reduce the sympathetic activity. On the other hand, there are faster cyclical breathing practices as done in Sudarshan Kriya Yoga. You do Bhastrika Pranayama, Sohan, fast hyperventilation breathing. That has been acting like a ECT. You know, in depression we found that hyperventilation of this Bhastrika Pranayama, it has some unknown mechanism, but suddenly you see that very quickly patient starts reporting improvement in the mood. So fast breathing practices can be utilized to bring, you know, arousal to a patient who is very fatigued, dull, drowsy, whereas the slow-paced breathing can be used to bring calmness to the sympathetic nervous system. So this is what I was talking about. Another mechanism through which it works is by enhancing the interoceptive awareness. And there is a definite effect of slow-paced breathing on emotion regulation as well. This is a study, this was my MD thesis, where, you know, I used patients with schizophrenia and healthy controls and asked them to do a particular breathing technique, very popular technique called Kapalabhati. You know, it involves flapping movement of the abdomen. So I was wondering why sages called a breathing that involves flapping of the abdomen as Kapala Bhati, forehead shining breath. So therefore use this FNIRS device. You know, it is called as poor man's MRI, because you just keep a belt here and it can take up the oxy and deoxyhemoglobin changes in the prefrontal cortex. So it allows that flexibility of doing various yoga things and still, you know, able to get some data. So observe that during this breathing, performed at a rate of 90 to 120 per minute, there was oxygenation in bilateral prefrontal cortices. So probably, you know, sages understood something, that the flapping of the abdomen is doing something to my forehead, something to my brain, and that bhati was actually oxygenation of PFCs. So this I observed in healthy controls, and it was not observed in the schizophrenia patients. Similarly, another study that we did at Nimhans, where people under the MRI scanner chanted Om, O and Ma in the ratio 1:2. It was predominantly the humming component. That actually stimulated the auricular branch of the vagus and brought a deactivation of the limbic system. So this study was replicated again on a higher sample size, and it was observed that by chanting Om 10 times, you bring limbic deactivation. And we know that limbic area is associated with a lot of, you know, negative ruminations and the emotional imbalances. So here our sages, they talk about, Patanjali's Yoga Sutra says, Tataha pratyak chetanadhigamo. You can overcome the obstacles by turning the consciousness inwards. So this is written 2000 years ago in Patanjali's Yoga Sutra, and very much applicable right now. From the practice of turning the consciousness inward, you can overcome the obstacles of whatever emotions, agitations of the mind. So therefore, we actually used these three components of Om, A, U and Ma separately, because another yogic text called Mandukya Upanishad says that the state of wakefulness comes with the sound A, the state of dream comes with the sound U, and the state of deep sleep comes with the sound Ma. So we wondered, you know, it is considered as the gem among all the Upanishads. It has only 12 sutras, and if you put in Google, it will not take more than 5 minutes to read it. But it is considered as the topmost Vedic literature, Mandukya Upanishad, telling that the human consciousness has 4 legs: wakeful, dream, sleep, and transcendental. A is wakeful, U is dream, Ma is sleep, and the silence between the Om is the transcendental Turiya Sthiti. And it says that it is this Turiya Sthiti that gives us mastery over wakefulness, dream, and sleep. So the application here is, every personality is different. Some people are more drawn towards wakefulness, and these people are called as Rajasic personality, A-dominant personality. Some are more thinkers than doers. They are called as the U-dominant personalities. Then the third are the people who are, you find it difficult to take initiative, who are socially withdrawn. They are Ma-dominant personalities, sleep attached. So people with A dominance are more prone towards anxiety, whereas people with Ma dominance are more prone towards depression. So in this way, these sounds have been utilized clinically by us, and when we put them under the scanner, we actually found that with the sound A, there was involvement of more attentional networks, whereas with the sound ma, the default mode network shows the higher activation. So there is some biological basis, to these sutras, and there is some clinical application of these sounds and mantras. So some sounds can make you extrovert, some can draw you in. So the ma sound, if somebody is not getting sleep, I would advise do gentle humming, because it naturally withdraws, cuts you off and takes you inside. Ma sound we subconsciously also use when we go inward. Say, all of you may be hungry now, and you get your favorite dish, say a pastry, a chocolate pastry, and you just put it. When you are very hungry, you say, So part is something that I am turning in and I am enjoying it. Whereas, when I have to lift a very heavy weight, my consciousness moves out. Is the sound you naturally put in whenever ouch sound goes, when the consciousness moves outward. So therefore, we use these particular sound techniques to balance the consciousness. So therefore, you can use the activating areas of the brain, the stopping areas of the brain by using certain breathing techniques, certain sound resonance technique, and certain bodily postures. So this is the introduction I wanted to give you about how the mind-body techniques are designed. So now coming to the scientific literature, you see first RCT of yoga was on biofeedback hypertension, compared it in 1975. After that it was very sparse, but then from 2000 onwards you see exponential rise, in the number of RCTs. This is only RCTs that have been done. India definitely is leading, but then many Western countries, especially US, is contributing the major chunk in the yoga research, followed by UK, Australia, Germany, Canada. And these are the areas where maximum number of RCTs have been done. So, people thought that yoga is only for prevention, but then, especially in stage 4 breast cancer patients, lot of quality of life improvement, rehabilitative measures, reduction in the side effect of chemotherapy medication was found. Then we see asthma, and then the depression and diabetes, then of course low back pain. So these are major areas where this has been tested and applied. Now coming to the yoga and type 2 diabetes per se, 27 randomized control trials, 13 meta-analysis. And what does it conclude? Number one, it can enhance muscle strength and cardiorespiratory fitness. That is all known. But clinically, there is reduction in HbA1c as well as fasting blood glucose. And what is the extent of reduction? The mean reduction in all these trials, it is a recent 2022 meta-analysis, says that on an average, 12 weeks of yoga intervention is average in all the studies. So there are studies beyond that, lesser than that. 0.84% reduction, 12 weeks of yoga intervention can bring as an add-on effect to the modern medication. And this meta-analysis also concluded that every additional day of yoga practice per week added a differential advantage of 0.22% reduction. So there was a dose-response kind of a relationship. So now quickly, going through major RCTs that have been done, this Nagratna et al., I was also involved here, 9-month yoga study follow-up where there was a comparable exercise program and the therapist and client interaction were matched. Physical activity calorie levels were matched. And still it was observed that the control was better in the yoga group, therefore there was a greater reduction in the hypoglycemic agents, and HDL levels were better. Similarly, not only in India, there are studies done in US, there are studies done in Australia where it has been observed that BMI reduced, weight circumference. These are between group results which I am putting. The third study, it was observed that both the groups showed reduction in FBS levels, but lesser than the control group which just followed usual routine. Another study, it was observed that HbA1c levels reduced from 7.05 to 6.86 in 12 weeks in the yoga group, but it was to a lesser extent in the control group. Vaishali et al., when they did the trial, they found in elderly, type 2 diabetes patients, 6 weeks of yogasana and significant improvement in HbA1c lipid profile as compared to control. Kher et al. Showed, in this study, in US and in Western countries, if you see, the intervention is usually given on the weekends, whereas in India, the common pattern is 5 days per week. So here people want to do it more regularly. And insulin requirement was lesser in the yoga group. So these were all poorly controlled patients. So insulin requirement was lesser in yoga as compared to exercise group. Similarly, in this study, we find that Hatha yoga practice for 2 hours, once a week for 24 weeks. So HbA1c, albuminuria, and these factors reduced. And clinically, the hypoglycemia and hyperglycemia episodes were also lesser. So there is something in yoga which is called as samatvam yoga uchyate. So yoga, even with blood pressure studies, we see that sometimes result doesn't come significant. But when we properly look at the data, it is observed that those with high blood pressure, their blood pressure comes down, whereas those who have low blood pressure, their blood pressure goes up. So there is something in the practice of yoga that it brings you towards homeostasis. It is not unidirectional. This is the trial that we did. Unfortunately, the COVID-19 pandemic happened between the trial. So 160 patients randomly divided into two groups, yoga and physical exercise group. And what we did was, in the first month, we gave them 20 supervised sessions in our yoga center. We collaborated with Dr. Govind's Diabetology Clinic and Sagar Hospital for this. And what we observed is that these two groups, we followed them up for 1 year. First 20 sessions were given in a supervised way. After that, they were asked to join us through telemode. And we conducted live sessions every day morning for both the groups for continuously, for 6 months. And after that, shared a video with them and asked them to, the tele-yoga sessions were continued for 11 months, 45 minutes per day. But after the 20 sessions, we shared a video where whenever they cannot join our live session, they would do using the video. And of course, it was a COVID-19 pandemic, and we had more than 50% people who dropped out, at the end of 12 months. So started with 80, but we ended up with 28 and 23 in each arm. And the yoga intervention that was given was a yoga for diabetes module that has been developed by the Ministry of Ayush. So we would start by hand stretch breathing, then we would go with the practice of forward, backward bending, twisting, Sarvanga Pushti, that is the rotation, then 10 steps Surya Namaskara. After that, they would perform the twisting in the lying down position, Shashankasana, then the Pavan Muktasana, wind releasing pose, Viprit Karni, where the legs are up, then Bhujangasana, then Dhanurasana, then Mandukasana. These are specific asanas which yoga experts recommend for diabetes. Then lying down and then performing flapping of the abdomen, that is Agnisara Kriya, Nadi Shuddhi, and Brahmari, and then of course the Ah Uma chant. So this was a complete module that was of a duration of 45 minutes. And the control group was given exercises, which were matched with the yoga group, and we continued it. And this is how the tele sessions were continued. And what we observed was that the HbA1c levels, from 8.10 came down to 7.30 in the yoga group at the end of 6 months, and then to 6.40 at the end of 12 months. So mind you, it was a time where people were highly stressed and there was very less physical activity. So these sessions were giving them that. But with the exercise, we observed that after the 6 months, there was an increase. One of the reasons, that we could think of is that people found doing tele exercise boring. Yoga had so many, practices like breathing practices, relaxation technique, chanting, but just doing exercise, same exercise every day on a tele mode was not very much, interesting for the patients. In the same way, though we found that the BMI and the waist hip ratio reduced in both the groups, but there was an advantage. Now looking at the scientific mechanism, two approaches are there. One is the top down and the second is bottom up. In the bottom up approaches, it is mainly, you flap the abdomen, you do all these breathing techniques. It is the vagal efferents which are getting stimulated. Whereas the top down, we see that it is mainly the control over the autonomic nervous system, parasympathetic dominance, and number of studies, 3-4 studies have now shown that yoga practice can enhance GABA levels. So centrally, it is the enhanced GABAergic tone which is reducing the anxiety. Yoga has been found to be as safe as usual care and exercise. Yoga is cost effective. You do not require any equipment. It can be delivered in groups as compared to, other mind-body interventions like CBT. And it is simple and easy to teach. And people feel more connected and people feel empowered that they are doing something for their own health. So this is the slide which I always put in my presentation, because being a modern medicine doctor, I believe in integration. So this is the Brazil team. The people who are bending, are center forward. People standing behind are the defense. So the center forward is modern medicine and the defense is mind-body medicine, and they have to come together to win the match. So these are the slides where the patients are undergoing yoga sessions here at Nimhans. We are continuing these tele-yoga sessions during the whole pandemic. We continued this and people asked that we should continue that even if the pandemic is over, and this is 2 years now that every day these sessions are going on, and all of you are welcome. These are sessions for stress reduction and well-being. We conduct them from 6:50 a.m. to 7:30 a.m. and you just have to put this Zoom ID and this passcode, and there is no registration required. And we have, taught these many people. This is a recent textbook that we have published. It is available on Amazon that describes all the principles and especially focusing on mental and neurological health care. So in collaboration with Indian Psychiatric Society. So in future, we have to focus on the preventive aspect of diabetes. We have to understand the mechanisms of mind-body medicine more deeper and develop tools that can catch. All our tools follow linear model, but the effects that these techniques produce are so subtle that you need tools that have quantum mechanics, to assess. And other unexplored area, definitely we need more long-term follow-up studies. So yoga is scientific mind-body practice with strong philosophical basis. It can help enhance the wellness component in the patient and adopts a multidimensional approach in the multifactorial problem of T2DM, and therefore can serve as a very useful adjuvant in clinical practice. Thank you. Thank you very much.
Thank you very much, Dr. Hemant. So yoga is not only about asanas. There are a lot about yoga. Any questions, please?
If I refer you a patient for a yoga session for lifestyle modification, what would be the minimum time your prescription for yoga?
So minimum time is if the patient comes to me, I will assess him. So I will assess the lifestyle in detail. I will also assess from the yoga point of view the sattva, rajas, tamas, uma component, and then a program will be decided in the OPD itself. We have a yoga hall where we will teach him the practices then and there, orient him to the online practices that we are taking, and from next day he will join our Zoom sessions and start the practice. So this is all free of cost. So Nimhans being a government institute, so it takes 45 minutes of consultation and another 30 minutes of orientation to the practices, and then they join the live session. If they cannot join, then we share a video with them.
Anything about various meditation techniques has been done? You told about Sudarshan Kriya, there are Vipassana and other types of meditation practices. Whether those things has been studied or added up in these studies, RCTs, what has been done?
So most of the RCTs, if you look at, especially in diabetes, the RCTs that are there, the majority of them are focusing on Hatha Yoga related aspect, the physical aspect of yoga and the breathing. There is a component of some mind sound resonance or this thing, but purely meditative practices where you just observe. The trials are very less. So there is one trial which we can see in Sahaj Yoga. Sahaj Yoga also is a very meditative kind of a practice. So because naturally the person feels that he should not just sit, he should do some physical activity. So only mind related aspects, the studies are less.
One or two quick comments.
I think this is probably one of the best ever lectures that I have listened to in the last 25 years related to the science behind yoga. A huge applause to you, Doc. We know that it is ancient, it works, but you've shown us how it works and what's the science behind it. You've taken us through the modern viewpoint of this, which is definitely what we as modern practitioners need to know on how it can be integrated into our mainstream practice. And I hope and wish we are able to pass on these benefits to more and more number of patients to get the maximum benefits. Hats off to all your contributions.
Thank you. So we have a big team of yoga therapists which have been trained, in Swami Vivekananda Institute in Bangalore. There are a lot of MSc, PhD yoga that have passed out. Now is the time, clinicians like you start hiring them. If you need yoga therapists, please mail me. I will instantly connect you to a person in your own area. Okay. Thank you. Thank you.
That was a wonderful session, Dr. Hemant. I just have one small bit to add up on this. As we went through a very enlightenment session now, and very rightly you compared the mind, and mind as known is, though we have evolved from monkeys, we still have monkeys in our mind. So that's how the monkey jumps from one aspect of one subject to other one. Very well defined. I just have one question to ask you, sir. Now, you mentioned about the westernized yoga, like we have bear yoga, we have doga where they do with the dogs. People who do in snow, they call it a snoga. So what is your take on this?
So this, really, it brings a lot of pain, because when I read Patanjali's Yoga Sutra and see their vision, and see that a beautiful, wonderful science of yoga also gets distorted, so it is very disheartening. So therefore, the approach in all our researches is, another important point is branding. We see that in medicine, we encourage generic practice. So therefore, in all our studies, we reveal the components of yoga. We reveal what dose was there, which practice was there, for how many rounds it was there. So therefore, in fact, we have written a paper on this in the International Journal of Yoga and Physical Therapy, where we said that in yoga, the generic component should be promoted, because when ancient sages taught it to their students, they were just open to whoever who wanted to learn them. So, yeah, thank you.
Thank you, Dr. Hemant. Well, everyone knows me, how restless I get when time is not maintained. But I was the first one to go and told them to switch off the timer. I think this is I have done for the first time in my life. And I second what my friend Dr. Pradeep told. It was a fantastic session. And wherever I have been made to write the scientific session, we'll definitely work together on that. And I was always thinking yoga is the way forward. He showed us that yoga is the way inward, actually. Thank you so much for that. And my apologies for the next speakers, because I think all through the day, everyone was complimenting that we were doing in time. But it was worth the wait, I feel. Thank you. No problem. It's our pleasure. We enjoyed it. Yeah. Prem, good to you. Quickly moving forward, and apologies for the delay, but I think, as I said, it is worth the wait. We'll go to the Novo Nordisk Symposium now. And the first talk is Science Behind Obesity. I would like to invite Dr. Pradeep Kumar, my good friend, consultant physician, CEO of Brookfields Medical Center. And to speak on this topic, Dr. Abhijit Bograj, consultant endocrinologist. Over to you. And we'll try and keep up or make up some time.
I'll keep that in mind, Dr. Manohar. Putting a context to this particular lecture of this fantastic lecture by Dr. on yoga, we know that there are 1 billion people who would be suffering from obesity by the year 2030. There will be 1 in 5 women and 1 in 7 men who would be suffering from obesity by the year 2030. The prevalence of obesity is as much as 40% in our country. And South India happens to be the highest. We have the second highest obese children population in our country. And we know it is a sedentary lifestyle and junk food that is a cause. But is it just an imbalance between energy consumption and energy expenditure? Or is it more behind this science of obesity? We have this topic to be deliberated by none other than my good old friend, Dr. Abhijit, who is a consultant endocrinologist at Manipal Hospital, Bangalore, with 15 years of experience with research papers and clinical trials of 25 papers. And he's been awarded as the best doctor and inspiring endocrinologist of India in 2018. And he's also got a medtech startup of the year 2020 to his credit. Over to you, Doctor.
Thank you, Dr. Pradeep. Thank you, Manohar sir and Team Disha for giving me this opportunity. And before I start, I just wanted to add a point on yoga because we already had a few aspects. The sad part of it is majority of us sitting here do not practice yoga. And I started at the age of 40. And what I realized, Shavasana is one of my favorite asanas. And but to discover that favorite asana, I had to understand what the movement and what it does to our patients. And I'll be adding few points about that in my talk today. And these are my financial disclosures. So I'll be covering the pathophysiology of weight regulation, the pathogenesis of obesity, and what are the benefits of weight loss, and what are the components of weight gain. Why are we seeing all these complexities? So to start off very simple, as sir already mentioned, it is between this interplay of intake and expenditure. And when we talk about this intake and expenditure, these points are governed, some within our control, some out of our control. Just to talk a little bit of intake, definitely what we put in will have its benefits. But when you talk about the nutrient absorption, we're not looking into gut microflora. And when you don't have that right balance of the microflora, you're going to have variations and again leading to obesity. So it is that complex. The aspect of obesity is complex. Expenditure, well, again, very simple. The more you move, the more you burn. But there are other governing components which are already preset into our genetics, already preset in the way our body is structured. So that when I look at the thermogenesis and when we talk about NEAT, NEAT is a very neat concept, I would call it, because this is the burn that is happening when we are not exercising or we are not moving. So it is not related to exercise and the thermogenesis that is happening. And this is again governed by preset values, how your body is structured. So the weight gain is obviously determined by the energy balance, the food, BMR, and resting metabolic rate. And once you keep this balance, you are going to achieve this weight gain or weight loss as what we see in obesity. So how do we structure this? Main component of energy intake will be coming in from our food. The expenditure, which is governed by external processes. Your resting metabolic rate, again, these are things that body has already set into one particular point. And we need to understand, when we treat obesity, we need to understand what is this set resting point for each individual. What is the requirement? Then you have the diet-induced thermogenesis. Again, this can be regulated by what we put in. Certain foods have certain changes in the way your body processes these foods. And these are, again, very important, and these are learnings that we get from different types of diets that have been done and what we have seen over the past few years. The next important point is from the physical activity. As I mentioned, the thermogenesis from non-exercise activity related basis. Again, when we talk about yoga, it improves muscle tone. And when you have improved muscle tone, this improved muscle tone is constantly burning, and to keep that muscle tone, it's burning energy. So some people have more, some people have less. So this is what we need to assess when we evaluate for obesity in our patients. Definitely, exercise-induced thermogenesis is pretty straightforward concept. And more we exercise, the right kind of exercise, again, looking at improving muscle tone, balance between the type of exercise, whether it is weight training or cardiogenic exercises, all of these play an important part for us to achieve this overall weight gain or weight loss when it comes to the energy balance for all of us. Next comes the complexities of obesity. So let's start off with looking at multiple regulatory aspects of our appetite. So this is the main component of what goes in. And these are again governed by central and peripheral mechanisms, which the central mechanisms located in the hypothalamic. You have anexogenic and oxyrogenic regulatory peptides and hormones that affect our system. And peripherally, it could be in the gastrointestinal tract, the pancreas, and the adipocytes. All of it have multiple components. Now, each of these individual components, again, the defects in which these peptides and hormones function are again regulated by our genes. Almost 50 to 60% of the genetic defects when we talk about obesity, it is linked to our genes. And that is what is governing these complex appetite regulatory systems. And it is not simple, but we are still learning how complex obesity could be as a subject. And it is a big important point in when we are looking at treating obesity. When we look at the focus in which our obesity plans, obesity management plans, again, it all underlines in these aspects in which we govern our eating. Appetite regulation, again, it goes back to the hypothalamic neurons which are stimulating it. So when we look at this complex mechanism, it all starts at the arcuate nucleus. And the POMC and the CART nucleus, and as well as the neuropeptide Y and agouti-related protein, all of these things are your initial first step. Now these are centrally governed. Now these centrally governing nucleus are again stimulated by peripheral processes, whether it is the satiety peptides or the hunger signals like your ghrelin. All of these are either stimulating or suppressing one of these neurons to be active or inactive right through the process to regulate the process of feeling hunger or satiety. So with the POMC and the CART are directly linked through the MC3R receptors, and they govern the satiety reducing appetite. And with the external signals, whether it is the ghrelin or adiposity signals from insulin as well as leptin, through the neuropeptide Y and AGPR, we are regulating appetite and hunger, suppressing hunger through these increased appetite and stimulate these processes. Next, we have your processes which are governed from your autonomic nervous system and the brainstem region. So these are again vagal efferents as well as satiety peptides like amylin and GLP-1 stimulating these processes which kind of regulate the feeding, gastric emptying, and metabolic rates. So when you look at all these complex factors from a central aspect, from a peripheral aspect, and having effective end function, it is definitely obesity. We cannot just look at it from what we eat and how much we exercise. So there are multiple aspects to this whole aspects of how we are managing obesity and how we are understanding obesity. The role of the brain, definitely, as we mentioned, there are multiple, it starts off right from the central aspect. So when you look at eating, they can be homeostatic eating, that is eating for hunger, and these are regulated by these peptides as well, the GLP-1, peptide YY, the pancreatic peptide, amylin, ghrelin, again, it increases hunger. So one is a stimulatory, one is a suppressive aspect. Then the hedonic, which is based on your dopamine and opioid cannabinoid receptors. So these are again stimulating factors. So these are again external factors which changes in which we see, understand, like food. So it's like a reward behavior. When we start to see food, the body starts to produce these changes in the brain and gives you that sense of feeling good, gives you that motivation. So that's why quite a lot of people during depression, they choose hunger, they choose to eat to reduce those kind of cravings. Again, looking at history of the individual when we are dealing with obesity, all these points are extremely important. The other function, whether we decide to eat, again, these are your own thoughts, your feelings, your behavior, how your day has been. All of those things play an important part. And when you sit together and you put all of these together, there are multiple governing factors. So we spoke about the peptide hormones and then the brain, from a brain aspect, these components which are controlling our appetite. So we're starting to see obesity is a complex aspect. We can't just look at it from a simple standpoint. So now moving on to the etiopathogenesis of obesity. Again, to make it simple, yes, we do have to talk about these two basic aspects of energy intake and energy expenditure. The remaining aspects, it is again multifactorial. So these multifactorial aspects that can affect an individual who is coming to us for assessment could have multiple central areas in which we are dealing, which and needs to be addressed. It could be medication. As I mentioned, genetics, almost 60% of the times it is the genetic predisposition which leads them to have obesity, gut, pancreatic or adipose tissue, whether with regard to leptin. All of these things are important aspects. The next a part of, again, what is governing obesity in all of us and why we are starting to see is environmental. We don't give this importance, but again, the kind of exposure to chemicals, the kind of changes that we are having to our genetics because of these, exposure to these hormones which are making changes to our endocrine system. All of these are important components. To focus a little bit on genetics, again, there is a high heritable component of body weight, and the genes in the hypothalamus, whether it is leptin or the melanocortin pathways, and whether there is a single change in nucleotide polymorphs that we are seeing, monogenic obesity. Again, these are very, very complex aspects. And the important point when it comes to genetics, usually the history gives you a fair clue. The presentation in which we are seeing these cases also will give you a fair clue of what is going on. So this was one scary question. When I saw this slide, it kind of got me back flash memories of, write about monogenic obesity in the exams. And so this is the level of complexity of what the topic that we are dealing with. And when we were studying for that topic to write it in our exams, yes, we didn't do as much justice, but then again, when we are dealing with obesity, when we see it in our clinical practice, it becomes more and more evident to us. So there are almost 300, single gene defects that are there based in 250 loci around, which are associated with obesity traits. And each of these components of changes in the genes can again be linked to certain types of obesity that we are seeing, whether it is BMI related, whether it is extreme obesity, whether it is birth weight related. So if there is low birth weight baby, then they are again higher chances, because at that stage when these genes are altered at birth weight, the body has come to a set point which it kind of maintains. And because of these alteration in these genes, we do see obesity in these individuals on a higher rate. So again, history gives you that answer. Asking about eating patterns, asking about where the weight gain is happening, all of these kind of gives you a clue. And we know the genetic components are a large impact. And the CNS expression, almost 97 loci, which regulate total BMI, and then genes from fat distribution, almost 49 loci for waist-hip ratio. So we are learning more, and this science of how we are dealing with obesity is getting more and more advanced. We will be able to address these changes in time. Specific therapies for specific mutations is what we will be seeing. And more than 100 genes and genetic loci are associated with obesity, and these are enriched for expression from the brain central nervous system. So that is where we are seeing the focus. Next, inherent factors predisposing to obesity. So these are within our control. The genes, obviously we don't, but it's important for us to identify somebody with a genetic problem and what are the environmental factors. Again, when we change our focus in our approach to the management, all these points become extremely important. So there could be socio-cultural factors, tradition, beliefs, peer pressure. People want to skip meals. People think only eating fruit throughout the whole day. So many differences in what they are consuming. Look at food environment. When you look at why rural India, we are starting to see abdominal obesity on such a large scale. Well, people find only eating carbs is good. There is no balance in their food. So these are important aspects when we are dealing with assessing somebody living with obesity. What are the kind of plate that they're doing? How are they balancing their balancing their meals? All of these become an important aspect. Availability of inexpensive, highly palatable foods. Swiggy, Zomato, big killer for all of us. So it's a big learning. And pandemic was also an important learning. People who were very physically active now became inactive, now coming with so much of body weight. The rate in which they were gaining weight, all are important points in our history when we, what we need to take when we are managing these cases. So these are our learnings, and these are thankfully factors in which we have control and which we can address. So now let's look at what it means to live with obesity. Again, we don't give enough importance when we are at a certain stage, and there's so many changes that are happening in this individual who is dealing with obesity, which is absolutely painless. So when you look at metabolic changes, we can look at non-alcoholic fatty liver disease. Now we are starting to see more and more of these silent killing changes that are happening. Infertility, PCOS, again, this is now becoming rampant in most of our cases that we present to us. And the obesity may not be so pronounced. So these are points that we need to be looking at when we are assessing that particular individual. What are the challenges that they are facing? What are the problems? Where is the focus? What is the risk that living with a higher BMI is going to affect for these individuals? Definitely diabetes, pre-diabetes. Let's focus on pre-diabetes, because pre-diabetes is something that we can put the disease off if we address it early. Rather than telling that individual, look, you have pre-diabetes, you need to make changes. Let's become more proactive before they get into the next stage, before they become full-blown diabetic. So let's look at all these components. Definitely obesity, if making changes in body weight, will make a big impact in that particular individual's life. So then moving on, mechanical changes, sleep apnea. Again, some things which we are not assessing and we need to look at it more frequently. Incontinence, osteoarthritis, all are definitely components in which majority of our cases come to us. So these are challenges because of obesity. And if we are not addressing it, then it becomes permanent. Mental changes. Quite often we kind of, miss these important points. Assessing their mental well-being. Living with obesity could be stigmatic for some, could be problematic for some, but we fail to assess these aspects in our clinical assessment. So these are the complications. It is multifactorial. Disease is multifactorial. Complications is multifactorial. So now let's look at how making this change in weight reduction is going to help us. So what are the benefits of 5 to 10%? This 5% is a feel-good aspect. 10% you will start to see changes on the numbers, on the scale, and whatever the values that you measured initially. So you start to see these changes. So reduction in risk of type 2 diabetes, CV risk, mortality, lipid profile, all these positive changes you're going to see with weight reduction. The magic number for us to achieve is 15%. Once you start achieving that 15% change, you're going to see the remission stage of diabetes. You're going to see changes, them dropping their blood pressure medications and even reducing their overall levels for lipid control. So you're going to see multiple changes, and the magic number for us to achieve is 15%. So what have we learned with multiple studies that have been done where they used low-calorie diets? And what we have seen in the pre-treatment, post-treatment, the sustenance of weight reduction is a hard component. And what we have to understand, once we put them on a low-calorie diet, we also need to make a plan for them how to maintain this body weight, because the body is constantly trying to get back to a higher weight. So when we do diet-induced weight loss, these are the changes that causes increased energy storage as well as increased food intake. So because of these changes in diet-induced weight loss, you are seeing these changes, and these are constant. So the minute you stop your dietary changes, the body, because of these changes, we are going to see weight gain in most of our cases. So what the point we need to make is the weight regain that we see has to be also prevented. So once they do a particular type of diet, we also need to make a plan for them which is ongoing, whether it is increased physical activity or whether it is the addition of medication. to manage their obesity along with diet and lifestyle, which is going to be a constant thing. So it is going to be a constant effort. And the learnings from The Biggest Loser, 16 participants were studied in this study. So this was a famous show in America where they used diet, exercise, and weight reduction. So they followed up these people to be constant. So to summarize what we have learned, obesity is a multifactorial problem. We cannot just look at obesity with one particular cause. We need to look at obesity as a whole. And once we do lose weight, it is a constant effort that we need to make to keep that weight loss persistent. So this is the last slide, and thank you for your patient listening.
Fantastic and lucid presentation, Doc. So now we know when someone comes back to us and says that obesity runs in my family, the answer is just not that it just doesn't run in your family because no one runs in your family. That's the reason that we were talking about. It's not as simple as that.
Yes.
And also, the various questions that anyone would have on why another person responded to the pharmaceutical the interventions that we were giving. Some of them responded to the surgical treatment options for obesity. We know the complexity that is there in this. So my question to you, before I throw it open, how would you individualize the approach for a patient who's obese to get rid of it?
So the first step is to start off with their existing lifestyle. See the challenges that they are experiencing with the lifestyle. What is the changes that they can make in order for us to improve the physical activity and maintain a certain type of diet for the rest of their life? Once you achieve that, then you start the pharmacotherapeutic interventions. If one succeeds, then add on another. If another fails, then add on another. So that is the process in which it will be trial and error, and the journey will take time. It is not one size fits all. We have seen it in most of our cases. So it's a question of starting therapy, discussing what are the pros that they can affect, what are the cons. Definitely all therapies will not be accepted. How the body reacts to certain therapies, again, makes a difference. So it will be trial and error, and making a plan and then sticking to it and letting know the user this is what we need to achieve. And if we have failed, then it is a question of moving on to the next or combining two things together. So that's how I would approach the management of obesity in a clinical setting.
Thank you so much, Doc. Yeah. Oh, Doc.
I wanted to put certain things in perspective. Obesity is unknown in animal kingdom. It is only seen in human beings and domesticated dogs and cats. Every animal knows what to eat, when to eat, and how much to eat, except human beings. We are the only species who eat even when we are not hungry. We look at the time and then we eat.
100% Logan.
Yeah. Every animal is directed to food by hunger. We are directed to food by taste and craving. Now, this forms the basis. I'm going 2 steps behind from the science of obesity. We don't eat food in its natural form. If you eat food in its natural form, I don't think anybody has to tell you not to eat more. Nobody tells you don't eat more salad. You will not eat. We have changed every aspect of food. The look, the smell, the taste and texture.
And the mode in which it is delivered now.
Yeah, that is there. And we have accepted a fact, we have created a narrative wherein we say food has to be tasty, food has to be appealing. Now, when you start eating tasty food, you end up eating a little more than what your body needs. And this, when it happens over decades, it manifests as obesity and a disease. Food is essentially, what is food? It's a basic existential need. We have made it into a science, art, philosophy and business. And we are paying a price for it.
100% right.
Very true, sir.
If this aspect of diet is understood, we talk about lifestyle diseases, and if we really understand that it is a lifestyle disease, we have to understand that these diseases, whatever we have spoken about, we need to address the lifestyle.
Very true, sir.
Without addressing the lifestyle, and the question is, why should we be talking about lifestyle when no other animal in this world talks about lifestyle, no animal talks about mindfulness while eating, disciplined eating. That is only because they eat food in its natural form. We refine the food, we process the food, we cook the food. And we are willing, we have accepted the fact that we are willing to give away the nutrition for the sake of taste. More tasty food you eat, you end up eating more. Over a period of time, it will manifest as obesity. I think this part of obesity needs to be addressed.
True words of wisdom from the senior most physician that we have. And on that note, I'll close the session for want of time. Thank you very much, Doctor, for a wonderful lecture.
Thank you, sir. I would request Dr. Pradeep to felicitate the speaker and the chairperson. And thank you for a very good talk on the science behind obesity. The secret behind obesity is, I'll tell 3 B's: beer, biryani, and bedtime. So, and with that note, I would like to welcome Dr. Kashinath Dixit to chair the next session. The session is about a 2-in-1 solution for insulin initiation, the growing wall of real-world evidence from India. And the speaker is Dr. Vijay Sarathi. Please.
Yeah, 2-in-1 solution. Dr. Vijay Sarathi is an endocrinologist. He has got his own center, Sarathi Diabetes Endocrine and Nutrition Center. And in addition, he is a professor and head Department of Endocrinology in Vaidehi. He has got a lot of achievements. So without wasting much time, I request Dr. Vijay Sarathi to tell us, enlighten us about this 2-in-1 solution in insulin initiation. It's over to you, sir.
Yeah, thank you, sir. At the outset, I would like to thank Disha team as well as Novo Nordisk for this opportunity. So I'm going to talk about a 2-in-1 solution for insulin initiation. In fact, like building evidence, the 2 real-world evidence from India to support this 2-in-1 solution. So this molecule is nothing but IDEG-ASP. As all of you know, it contains 30% of short-acting insulin, that is insulin aspart, and 70% of an ultra-long-acting insulin, that is insulin tegludec. So whenever, it's a reality that like majority of the patients in India, despite being on multiple oral anti-hyperglycemic agents, still are not able to meet the glycemic targets. So obviously, there is a need to initiate insulin in these patients as a first. But whenever we consider insulin initiation in these patients with secondary OHA failure, we have additional challenges in India because the Indian diet, as already discussed, like is very much rich in carbohydrates, and obviously that leads to significant increase in the postprandial glucose levels. Also, that whenever we are choosing an insulin, people always demand for like only one time an insulin which can cover up both fasting as well as postprandial, or max 2 times a day. When we ask them to take typical basal bolus regime containing 3 or 4 times a day insulins, always there is some amount of resistance. Right, so if you look at the profile of the IDEG-ASP when given as a single dose per day, there is a coverage for 1 meal, that is 1 prandial coverage, along with the basal coverage. If it given twice a day, it covers up 2 meals, that means prandial coverage for 2 meals, and also the basal coverage. So what does it say? So it's not only can be used as an insulin for initiation, but also can be used for uptitration without much of hassles. A lot of data has come up from the randomized controlled trials to support the safety and efficacy of IDEG-ASP. But what I'm going to today discuss is more on the real-world evidences which are pitching that are supporting the safety and efficacy of the IDEG-ASP. Why we are looking at the real-world evidence, though we have a lot of RCTs, it's basically because the real-world evidences are the ones which are closer to our hearts, right? Because in RCT, what happens is that there's a controlled environment. Whatever happens, whether it may be diet, whether it may be exercise, the patients are getting controlled. But there's many factors, the variables, which actually we can't control in our clinical practice setting. So it's always been good to know how a molecule performs also in a given clinical setting. So the RCT tells whether a drug really works or not. And the real world data says whether the drug works for our setting. So if you look at the real world evidence that is building from India, there are several data which have popped up in the last 6 years, starting from 2016 till 2021. So I'm going to take up a few of these. The very first one is from Dr. Kalra and Dr. Manas Barua. One is from North India and one is from Eastern India. That was like a bicentric study. It was a smaller study, included only around 48 patients. The baseline A1C was around 9.3. The mean age of the patients was around 54. So when we looked at the data, so the hemoglobin A1C reduced significantly by a factor of around 2%, not only at 6 months, and it was maintained even at the end of 12 months. A glad part is that it did not come at the cost of increased dose of insulin. Rather, there was a scope to reduce the dose of insulin despite the A1C got reduced. So a second data coming from Dr. Jyotidev's center. The study included around 152 patients. Majority were males. The age was again a middle age of around 53 years. The duration of diabetes was around 11.5 years. 1/3 were on OHA alone, whereas the 2/3 were on OHA plus insulin. That means it was a insulin initiation for 1/3 and insulin switchover for almost around 2/3. If you look at the data, there was a significant reduction in A1C by a factor of around 0.9%, whereas the fasting plasma glucose reduced by a factor of around 44 milligram per deciliter. And again, when we start insulin, always we think that the patients would usually gain weight, and it has always been considered as one of the negative stigmas attached to the insulin initiation. But here, as you could see, instead of weight gain, there was a small weight loss. No, may not be a great weight loss of 0.8 kg, but at least I could urge that it's going to be more of weight neutral. So despite the treatment being continued for around 10 months and almost around 150 patients, only around 5 hypoglycemic episodes were reported, and none of them were actually severe. So in fact, Dr. Jyotidev provided a little more extensive data, in fact, with almost like a similar baseline characteristics, including around 291 patients. Again, here we had an opportunity to analyze like how this IDAG-ASP insulin behaves in subset of patients based on their baseline therapy. For example, those who were previously treated only on OHA versus OHA plus insulin. If you look at the OHA alone group, in fact, they had a relatively higher baseline A1C of 9.32, and again, there was an evidence to support that an A1C reduction of almost 2%. Even in patients who are already on OHA plus insulin, where the IDAG-ASP was used as a switch plus uptitration, there was an A1C reduction by a factor of around 1%. So another interesting study by Chaudhary and group. So in fact, what they did, though it's not a randomized controlled trial, they tried to compare the insulin glargine U100, insulin glargine U300, and the IDAG-ASP. As you can see here, there is a very good response in terms of HbA1c reduction in the IDAG-ASP group, where it was reduced from 9.61 to 8.09, whereas the reduction in A1C in the glargine U100 group was from 9.61 to 8.56. At least a benefit of 0.5% in A1C was observed, whereas the lowest A1C reduction was probably noticed in the U300 group, which I'm going to discuss a little bit later. So, whereas if you look at the change in A1C, the difference was definitely higher in the IDAG-ASP group. Let's individually analyze. So what happens to the fasting plasma glucose and the postprandial plasma glucose? So as we expect, typically all of them have a basal coverage, so we should expect a good fasting control in all the 3 arms. But if you look at the statistically significant difference, it was significantly better in both IDAG-ASP and as well as the glargine U100, but was not so great in the glargine U300. If you look at the change in PPG, obviously, as we can expect, it was significantly better in IDAG-ASP because it also has a coverage for at least 1 prandial coverage. Sometimes if they're used as twice a day, it also has prandial coverage for 2 meals. Again, if you look at the insulin dose requirement, so though the euglargine 100 did as good as IDAG-ASP in control of fasting plasma glucose, that came at a cost of a higher insulin requirement, but not so much in the IDAG-ASP group. Whereas if you look at the proportion of patients reporting hypoglycemia, statistically it was not different. But one small point I would like to highlight here is that though it was not statistically significantly different, the U300 had apparently lower incidences of hypoglycemia. Probably that could also be the reason why the U300 did not fare well in terms of fasting glucose control also. Both of them indirectly indicating probably a intensive uptitration was not there in patients who received U300 compared to those who received U100 as well as the IDAG-ASP. But nevertheless, IDAG-ASP did well, much better in the postprandial glucose control. So moving on to more data on real-world evidence in a prospective manner. So the first one is the RISE study, a Rhizodec initiation and switch effectiveness study. It's a multi-center prospective non-interventional study investigating the clinical effectiveness of IDAG-ASP in people with type 2 diabetes in the real-world setting. In fact, the study lasted for around 26 to 36 weeks, though the inclusion criteria were physicians' decision to start treatment with IDAG-ASP, age more than 18 years, diagnosed with type 2 diabetes, and being on any other antihyperglycemic agent other than IDAG-ASP, and having a A1C within the last 12 weeks. In fact, it's a multinational study, so with a good number of around 1,100. So India was also being a part of it, including around 185 patients. So it's very good to see a great reduction in A1C of around 1.4% in the global data and 1.6% in the Indian subset. Similarly, fasting plasma glucose was also reduced significantly in both the global as well as the Indian subset. Again, looking at, based on the pre-treatment baseline therapy, whether the efficacy is going to differ. Those who are already on insulin and then switch to IDAG-ASP, especially when they were uncontrolled on the basal insulin therapy, those patients, when they were switched to IDAG-ASP, there was an A1C reduction of almost around 2.1%. When it was initiated as an insulin initiation, so in those patients who are not getting control on OEDs alone, the A1C reduction was 1.9%. Not too different. So but basically, we can conclude that in either group, the IDAG-ASP was very effective in the real-world evidence. Looking at the hypoglycemic episodes again, there was a marked reduction, in fact, like almost by around 60% in the global data, whereas the reduction was almost around 80% or more in the Indian subset. So we can definitely urge on this IDAG-ASP whenever we're looking at reduction of hypoglycemias in our patient cohort. So it's also so for the severe hypoglycemic events as well. The last set of data I would like to present is actually the SMART, the study of management of diabetes with Rhizodec treatment. Again, it included diabetic patients who were more than 18 years who were scheduled to start treatment with IDAG-ASP based on the clinical judgment of the physician, and the duration of the study was 12 months. If you look at the reduction in A1C, again, it dropped from 9.5 at baseline to 7.7 at 12 months with an effective A1C reduction of 1.8%. Again, when we look at the subgroups based on the baseline therapy, those were insulin treated, in them A1C reduction was 1.8%, whereas those who were uncontrolled on OED alone, where insulin was used as an initiation therapy, the A1C reduction was 1.7%. The fasting plasma blood glucose level was reduced by 50%, whereas the postprandial blood glucose levels, the reduction was around by 82 milligram per deciliter after breakfast and around 74 milligram per deciliter for lunch. Again, the confirmed hypoglycemias were markedly reduced during the IDAG-ASP therapy, whereas there was not even a single event of severe hypoglycemia during the IDAG-ASP therapy. To summarize finally, so whenever we are having a type 2 diabetic patient, we need to consider IDAG-ASP. So especially when patients are failing to achieve glycemic control despite optimizing the non-insulin therapies, that is as an insulin initiation. In patients who are already on insulin, or even when we are considering as an insulin initiation, those patients who have postprandial glucose spikes, or those patients that are at increased risk of hypoglycemias, even those including a nocturnal hypoglycemias, those patients who are demanding for reduced injection burden as well as less complex regimes, or those who request for flexibility in the timing of insulin dosing, these are the subcohort of patients who should preferably be treated with IDEC-ASP. Coming back to the real-world evidence, it's important because it often provides a more comprehensive understanding of how a therapeutic option works in the real world, rather than via the standard RCTs alone. The real-world evidences of IDEC-ASP complement the data from RCTs and also supports the established effectiveness and safety of IDEC-ASP. IDEC-ASP is a simple and convenient solution which offers total control of postprandial plasma glucose as well as fasting plasma glucose, and definitely is one of the very preferable insulin for initiation as well as easy intensification. Thank you so much.
Any questions? Dr. Vijay Sarthi, no doubt this co-formulation of IDEC-ASP is better than premixed human insulin or basal insulin. You have showed it. It brings down HbA1c, it brings down fasting, it brings down postprandial.
Right.
Sita, Wilda, and DAPA have become off patent past 2-3 years. Lot of our patients, they are on these molecules. This IDEC-ASP, is it a monopoly of Novo Nordisk, or will it become off patent or generic in future? This is a question to be asked to the Novo people, but still, just for curiosity, because the way we have seen the success of Wilda, DAPA, and Sita, if it becomes off, because it's, if I am correct, it's about 4 times expensive than human premix, human traditional premix. So if it becomes off patent, more and more of our patients will be on this molecule.
True. Definitely, so probably when we talk about its advantages over the basal, definitely it is there. Because whatever the advantage we are going to get with a basal plus, we are going to get with the one single shot of IDEC-ASP. Obviously, like we always counsel our patients to cut down their diet, but if I ask them to cut down all the 3 diets when we are giving a basal alone, there will be a lot of crippling. At least I allow them to enjoy one meal with carbohydrates, at least put limitation on the other 2. They're more accepting the diet pattern and also still giving a good control. But when it comes to a comparison with premix, definitely I would like to have a little complex opinion. The advantage of the premix is that though it gives a lot of fluctuations, a lot of hypoglycemias and hypers, it's a relatively better control for the post-lunch glucose levels, which is not very well so with the IDEC-ASP. So that's one disadvantage. But looking at all other aspects of like risk of hypoglycemias and their consequences, so obviously still IDEC-ASP may score over the premix insulin. But okay, coming to a third question, definitely I don't want to take it up. So let the Novo people answer if they would like to, if it's all if it's going out of patent sooner or later. Novo would like to take
questions?
up?
Yeah. Thank you, Vijay Sarthi,
so
for
much.
excellent. And thanks to Disha people for these wonderful arrangements. Thanks a lot, especially to Manohar, who is a good friend of mine.
Thank you, sir.
Thank you.
I invite Dr. Shekhar to felicitate the chairperson and the speaker. I would like to welcome Dr. Balaji Jaganmohan, consultant diabetologist, to chair the next session, and also Dr. Ganapati Bantwal to give the next speech.
Thank you, Dr. Manohar and the entire Disha committee. Nice to see a lot of colleagues here after a long time. So it's indeed a pleasure to chair this session. Having Dr. Ganapati Bantwal sir as the speaker, I think he requires no introduction. In fact, this particular session is interesting because we know that this is the first of its kind oral GLP-1 receptor agonist that has been available since the last 8 to 9 months. And all of us have gained some amount of experience with this drug. And we have sir to throw some light about the molecule, about the pioneer trials, and how it fares compared to the other GLP-1s that are there in the market. Over to you, sir.
Thank you, Dr. Balaji. Thank you, Disha team, Novo Nordisk for giving me this opportunity. So I think before I start, I will start from where Dr. Abhijit left. So obesity is increasing. Why? Rightly told by sir that we are eating more. It's not that if we do exercise, we lose weight. It's not possible. It's basically we are eating more and more and more. Say, I think previously, just an example, French fries, 220 calories, now 650 calories. How do you make up for that? 400 calories, 3 hours more exercise. Will you do? No, never. Genes, he was talking about genes. The most commonest gene is FTO gene. It actually increases by only 3 kgs weight. That's the most commonest cause of obesity. But then the environmental factors see that you gain around 15 to 20 kgs. So that's the reason we tend to put on more weight than what is required. And then when you start losing weight, it's a yo-yoing phenomenon. Somebody is 100, you came down to 95. Now at 95, if you eat the same food, you'll go back to 100. That's because your basal metabolic rate has come down. So that's the reason from 95 to come down to 90, you must eat still lesser or exercise still more, another 15-20% more and another 15-20% less intake. So only then you will start coming from 95 to 90, so it will keep on happening. Otherwise, it's not possible. Now, how do you control the hedonic component? That is the pleasure of smell, all these things which will drive us towards food is probably by these type of drugs. So this is my disclosure. I have been supported by Novo Nordisk for this. So what is the role of GLP-1? What is this? This is an endogenous incretin hormone secreted in the gut in response to food intake. So it's an insulin secreted from the intestine. So the native GLP-1, what does it do? Increases insulin secretion. This is glucose dependent and reduces glucagon when the blood glucose is high. And approach, so when the blood glucose comes down, the glucagon increases and the insulin shuts off. Reduces hepatic glucose production, decreases gastric emptying, increases satiety, decreases food intake, and beneficial effects on the CV. Probably you find the right balance in efficacy and safety by using this drug. So I told you what it does. So it has a very good efficacy. Like for example, if you use semaglutide, even 2.4, 2.5% decrease in A1C can happen. Anti-hyperglycemic agent, low risk of hyperglycemia, significant weight reduction, and cardiovascular benefits. So the cardiovascular benefit is atherosclerotic reduction. So unlike SGLT2 inhibitors, you get the benefit within 17 days, 23 days. That's for the heart failure. Not so much on the atherosclerotic component. Here, it's acting slowly, but then it's probably reducing your atherosclerotic component. So what are the cardiometabolic effects of GLP-1? So improves insulin function from the beta cells. So at the level of the heart, decrease cardiovascular risk, improves the cardiac function, decrease systolic blood pressure, decrease inflammation. At the level of the kidney, improves or increases the natriuresis. At the level of brain, I have told you. So liver also same. So all these things, what does it do? Decrease risk of MACE, decrease risk of myocardial infarction, stroke. So in fact, GLP-1, many other molecules also, they have found that it reduces risk of stroke consistently. So decreased risk of death from CV causes, decreased risk of hospitalization due to heart failure, and renal GFR decline is actually reduced. In fact, you can use this up to a GFR of 15. So that's the reason all the guidelines have come out. Suppose you have a patient with type 2 diabetes with ASCVD or very high CV risk, that is target organ damage or multiple risk factors, consider adding a GLP-1 receptor agonist with a proven CV benefit. Say he doesn't have this ASCVD risk, then also you can use it for other reasons, for weight reduction, for reducing blood pressure, so many things. So you could actually, you could use this drug. So GLP-1 receptor agonist or SGLT2 are recommended in patients with on metformin with ASCVD or high or very high CV risk, irrespective of HbA1c. Suppose somebody is on metformin and SU, you actually down titrate the sulfonylurea, add this drug, so that if the HbA1c is around 7.5. So the ADS tells the same thing. So the first line therapy depends on comorbidities, patient-centered factors including cost and access consideration, and management needs, and generally includes metformin and comprehensive lifestyle. Now is oral semaglutide. So till now we have had only injectables. We had a liraglutide, which was once a day. It was a good one because it was acting for 24 hours. Before that we had exenatide. One of the problems with exenatide was we are using it twice. And another problem was we are using it only in the morning and in the night. So the patient used to eat more in the afternoon. So postprandial breakfast is good, post-dinner is good, So post-lunch was very high. So I used to make it 5 micrograms thrice daily. I used to use my own regimens. Then they used to eat all the 3 meals lesser. Then we had the dulaglutide once a week, and now we have oral. Because one drawback always is, why an injectable? The first thing is, the moment you tell it's an injectable, tell, is it an insulin? So many explanations, all these things required. So this has 94% homology to GLP-1. So some substitutions like at 8. So this, we'll see that it's protected against DPP-4 mediated degradation. And then you have a spacer. So Novo Nordisk does this type of always acting. See, in degludec, you had a C16 hexanoic spacer. Here it is an 18 amino acid difatty acid. And then at 34, amino acid substitution at 34 prevents this C18 fatty acid binding at the wrong site. How do you use it? First thing in the morning. This is a little bit problematic. Some of them tell, should I wait for this 30 minutes? Why should I take it early morning? The moment you get up, take it half an hour. You shouldn't eat anything, 120 ml of water, and see that the other molecules are not taken in this time. For the first month, you use 3 milligram. The second month, you use 7 milligram, and then finally up titrate to 14 milligram. There are trials now going on for obesity, where they use 25 and 50, so those trials are going on also. So now coming to the clinical efficacy of oral semaglutide, the pioneer studies, all the studies of semaglutide oral are pioneer, that is peptide innovation for early diabetes treatment. So with diet and exercise, it was pioneer 1, with OADs, pioneer 2 with SGLT2, with DPP4, it was pioneer 3, GLP-1 and placebo with 1 or 2 OHAs, pioneer 4, pioneer 7 with DPP4, and then insulin use as pioneer 8, 5 was with renal impairment, 6 was the CV safety one, and Japanese you had the 9 and 10. So overall, if you see the 1 to 5, 7 and 8, change in A1C and body weight. So you can see here roughly around 1.5. So it's around 1.3 to 1.5 reduction in A1C. And if you see the weight, approximately around 3 to 5 kgs weight loss also has happened if you compare it with others. What is the maximum? So efficacy of oral semaglutide according to baseline A1C. So if you have started with the HbA1c more than 9, the A1C has reduced up to 2.6 also. So in the Pioneer 1, you can see it came down up to 2.6, Pioneer 2 versus empagliflozin 2.9. So many people ask, why should I use this drug, which is more expensive? Why not I use empagliflozin? Weight reduction is more with this. Yeah, okay, 1 or 2 kgs less makes no much difference. But then the percentage of patient achieving an A1C less than 7% or 6.5% is actually more with the semaglutide, or for that matter with other GLP-1 receptor agonist also. In the Pioneer 3, up to 2.2%, 4, 2.4, this is including versus liraglutide. So this doing better than even liraglutide. So 90% of the patients with type 2 diabetes are obese. Even if you're not obese, we have more fat. And as you know, it increases the risk of stroke by 1/3, 50% CAD risk, 71% all-cause mortality. So across the Pioneer studies, you can see weight loss of more than 5%, Dr. Abhijit told. See, we tell a drug is efficacious as a weight-lowering agent, at least 5% weight loss should happen. You shouldn't aim for 20%, 25%. The first aim is 5% loss, because this will see that it produces a lot of metabolic changes. So 5% is the first target, and then you should go, because many people, 100, 120 kgs, 5 kgs loss is nothing for them. They want 20%, 25%, that we achieve only with bariatric surgery, and probably now with maybe the step 2 programs and the step 3 programs with the injectable semaglutide, where I think around 25-30% had more than 20% weight loss. And I think the dual cretins, the Monjaro, that is also produced significant weight loss. I think they are the ones of the future. So 1 in 2 patients achieved more than 5% weight loss, that is decreased up to 5 kg weight loss across clinical trials. So a significantly greater number of patients achieved weight loss of more than 5% with semaglutide 14 milligram compared to placebo. So not only weight loss, it also reduces the waist circumferences also reduces blood pressure, because we know a 5 millimeter decrease in blood pressure is associated with a 13% risk of stroke, 7% decreased risk of IHD, 14% for heart failure, and 5% for death related to diabetes. And the same thing, so semaglutide has been found to reduce systolic by around 5 millimeters mercury versus diastolic, which was around 2. Typically a reduction varying between 1 to 6 millimeters of mercury. Improves also lipid profile. So as you know, most commonest cause for cardiovascular disease is lipids, hypertension. These are the two most commonest cause, and semaglutide can improve the lipids. So you can see a 0.04% decrease in LDL cholesterol. And all of them, when you control the glycemia, the triglycerides also come down. The moment the triglycerides comes down, the HDL improves. And the small dense LDL also starts coming down when you reduce the triglycerides. Improves vascular inflammation also. So why this happens? Hyperglycemia leads to oxidative stress. That leads to damage to the arterial walls and drives atherosclerosis. So here they looked into an indirect marker. So they looked into hsCRP. So oral semaglutide 714 milligram versus placebo. And you can see if you compare with empagliflozin also, this had at least a 4-fold decrease in the hsCRP compared to empagliflozin. So then it can also reduce the risk of atherosclerotic events in the cardiovascular outcome trials. So semaglutide increased the number of years free of new or recurrent MACE in people with type 2 diabetes and high CV risk. So you can see the mean absolute CV risk reduction of around 6% and a mean increase of 1.7 years, which is free of cardiovascular life years. So this is the pioneer study. So here, the first time to occurrence of CV death, the 3-point MACE, non-fatal MI, non-fatal stroke, was around 21% reduction. Of course, it did not reach statistical significance. That doesn't mean that is mainly for superiority. So what this trial says is it's neutral. Maybe we have the SOUL study, I think. So that results will tell us the actual outcome. So why was this? So the next slide will tell us. So SUSTAIN 6, we are also a part of SUSTAIN 6. So but we could only recruit 2 patients because the time limit was very less. So here the follow-up time was 2.1 years, and you had a 26% reduced risk of MACE. Whereas here, 21% reduced risk, but the follow-up time was 1.3 years. Probably that could have been the reason why you didn't get a superiority aspect compared to placebo. As I told you, this reduces the risk of stroke, and this is statistically significant. Majority of I think this will come in the guidelines, that if you have somebody having a stroke or to prevent stroke, probably we'll have to use this drug. And another drug which has been found to be beneficial is pioglitazone from the IRIS trial. So if we do a pooled analysis for renal effects, so you can see in SUSTAIN and PIONEER combined, semaglutide showed significant reduction in the worsening of renal function, eGFR. So we use it up to a GFR of 15. The only caution is at 30 and below, the patient can develop nausea, so you have to be very cautious, gradually up-titrate these doses. I have a few patients who are having a creatinine of 2, 2.2, eGFR of around the 20s. They're still continuing to use it, not semaglutide, the oral one, the liraglutide. They're doing extremely well. In fact, the creatinine has come down from maybe 2.7 to 2.4, 2.3. They're stable for the last 3 to 4 years. So you can use, but a word of caution, nausea if at all worsens, dehydration, GFR worsens. So this thing you have to keep in mind when you use this. So to summarize the pioneer studies, A1C reduction in the various trials, oral semaglutide superior versus empagliflozin, sita, lira. Weight reduction superior versus sita, lira, and empa. Cardiovascular safety confirmed for oral semaglutide in pioneer 6, 21% reduction, non-inferiority. And end of trial, oral semaglutide demonstrated significant greater A1C and weight reduction versus sita, empa, and lira. Overall safety, well tolerated, safety profile consistent with the GLP-1 receptor class agonist. The most common adverse events was mild to moderate nausea. Efficacy was established when given early in therapy, late in therapy, and regardless of renal or hepatic impairment. One word of caution, somebody is having a proliferative diabetic retinopathy, be cautious in using this drug. We don't know why. One of the explanations they gave is what is known as a re-entry phenomenon, like what happened in the DCCT. In the DCCT, you know, when they started using the basal bolus regimen, intensive regimen, the patient in the first 4 months, they found there was a worsening of the eye disease. They got worried, the DSMB got together, what should we do? They told, okay, well, let's wait for another 1 more month or 2 months and then see, and then otherwise we'll halt the therapy. Another 2 months, they found it started stabilizing and in fact started improving. So we call it as the re-entry phenomenon, and the same probably concept is also applied here. So addressing cardiovascular risk factors, oral semaglutide addresses cardiovascular risk factors via multiple beneficial effects, significant A1C reduction, 1.5, and in some instances up to even 2.5%, weight reduction up to 5 kgs, systolic blood pressure reduction 6 millimeters, improvement in lipid parameters, waist circumference decreased by around 4.7 centimeters. So to conclude, GLP-1 are among the most effective medication for type 2 diabetes, which have been shown to reduce A1C, body weight, composite outcomes, and even pill burden. It's a scientific breakthrough in innovation to bring efficacy of GLP-1 receptors agonist in convenient oral formulation. Across global pioneer trials, oral semaglutide proven its efficacy in achieved A1C reduction up to 1.5 and weight reduction up to 5 kgs. Has found to reduce A1C more than an SGLT2 and DPP4 when added to 1 or 2 oral drugs, and reduces A1C when added to insulin-based therapy. With baseline more than 9%, A1C reduction up to 2.6%. CV benefit, non-inferiority. If you compare both of them, combine both of them, Pioneer and the Sustain, significant reduction. So efficacy of oral semaglutide established when given early in therapy, late in therapy, and regardless of renal or hepatic impairment. Thank you for patient hearing.
Thank you, Dr. Ganpati, for that wonderful, comprehensive, but yet a very lucid talk. If you were given an option, if cost is not a barrier, would you use an SGLT2 or a GLP-1?
Okay. Suppose if you have a heart failure type of patient, then probably I'll use SGLT2. If you have an atherosclerotic cardiovascular disease, or for that matter, no heart failure, I will prefer to use this drug. See, when you use SGLT2, there also you'll have to talk a little bit more. You will tell, okay, you will pass more urine, genital hygiene has to be maintained, and then if you get this, what you'll need to drink more water, be cautious. So you'll have to talk to them another 5 minutes more to tell about the side effects of the SGLT2. Whereas here, the only thing I'll have to tell is you may get some nausea, and that's why we are building it up. And the other thing is take it first thing in the morning, like we tell for thyroxine. Don't take anything for 1 hour. You'll tell us the usage of oral semaglutide, and cardiovascular benefit is also there. So, yes, if cost is not a factor, this will...
In fact, this is a very comprehensive GLP-1 program. They have up to Pioneer 12. The remaining 9 to 12 are still ongoing. They also have a trial in the teenage population, only for the Pioneer studies. So anyway, now the floor is open to the audience. If you have any questions, any comments, suggestions.
Yes, sir.
Just wanted to know, GLP-1 analog has been found to be useful in ASCVD risks, but not in heart failure. SGLT2, when you see, it benefits both. SGLT2 inhibitors, they promote ketosis, whereas this inhibits the glucagon and they stop the ketosis. Could this be GLP-1 analog as well as DPP4 in heart failure?
No, it's basically because of the increase in the heart rate. If you have an increase in the heart rate of more than 5 or 6, the heart failure increases by 17%. So this is what we have learned from the EVA-BRAD studies. So if at all a risk is there, it's actually based on the increase in the heart rate rather than other things. So the ketogenesis could be both. It could be good because it will stimulate glucagon, and produce this. But the other way around is you may develop a DKA also. So we have to maintain a balance between.
Regulated ketosis. In those patients, when I said ketosis, regulated ketosis, where insulin is there, the benefits of SGLT2 have been seen immediately within the first
No,
week.
that is mainly for the heart failure. The benefit is heart failure. So by the 17th day, you are finding it. So it's heart failure. Without any doubt, all the whole class of SGLT2 is mainly for heart failure reduction, without any doubt.
When do you foresee Rybelsus being approved as an anti-obesity drug? Any reason?
These guys have to give the regulatory approval, the data, Indian data and all, then they'll get it. Once it is approved there, it will get approved easily here. So they have to do it. Another thing is maybe they are waiting for the trials of 25 milligram and 50 milligram because 20% reduction, that's a big number.
Yeah.
Otherwise here always 3 kgs, 4 kgs, people are not happy, 100 kg persons and all. That 20% is really good.
That's a killer.
Yes. I think, see, the dual creatine, Ducretin, that has actually come already. Monjar is available in UAE also.
Right.
So if that comes, these are all game changers for obesity.
I would like to give an observation. So I had a patient who was wheelchair bound, a 44-year-old gentleman, due to a RTA, diabetic wheelchair bound, and he was on a SGLT2. He was on Motivist, Cana 300, and the moment Rybelsus was available, so he volunteered himself I want to take this also. He
You
was
combine and give.
122 kg he lost 18 kgs in 3 months time period, which was a very excellent weight loss for him because he was finding it difficult to attend physiotherapy sessions because of weight gain and all. So once he was on both these drugs, almost 20 kg down, and he very motivated gentleman, but it was a good eye-opener in that
No,
way.
I've had many patients say 108 to 88 kgs. So 20 kgs. I just told Balaji when another lady, I sent her to bariatric surgery. She was not fit for that. Obstructive sleep apnea, can't walk. I was surprised to see her last week lost around 20 kgs. I had only put her on, of course, there I had used dulaglutide because it was an injectable once a week. I can't recognize her now because 20 kgs down, she is now coming happily walking inside. To walk also was difficult and not fit for bariatric surgery. They're doing extremely well. So it does make a lot of difference when you use these type of molecules.
Thank you, sir. If there are no more questions, we will wind up the session. And Dr. Pradeep, kindly felicitate the chairperson and the speaker, please. To chair our next session, I would like to invite our friend Dr. Raja Selvarajan to the dais. And for the next talk, I would like to invite Dr. Mahesh.
Very good evening. At the outset, I would like to thank Dr. Manohar, Team Disha, my colleagues, and all the delegates present here for this wonderful occasion. Well, we have been running through the latest advances in the management of diabetes, just finished with pioneering the pioneer trials and probably assimilating the benefits of semaglutide in the type 2 diabetes management. And now we have another interesting topic to be pioneered by Dr. Mahesh, wherein he would throw light on how could interchangeable glargine, that is a biosimilar, how will it make a difference in terms of management of both type 1 as well as type 2 diabetes, probably cost effective, and how does the evidence translate to real world evidence? Let's hear it from Dr. Mahesh. Dr. Mahesh doesn't request much of an introduction. He's a consultant endocrinologist from Aster. So over to you, Dr. Mahesh.
Thank you. Thank you, sir. At the outset, I thank the organizers of Disha for this wonderful meet, which has incorporated many different aspects of our clinical practice, and it is not only science but beyond science, and helping us to enrich our knowledge. So I'll be talking about one of the insulins that we are all using in our clinical practice,
what is the evidence and benefit of biosimilars. Usually, there are many molecules that are there in the market, but we rarely see a biosimilar study being done in a very rigorous way. So this is one of the study that indicates that how actually we need to go about, or when we see somebody telling that, sir, this is equivalent to the best molecule that is there, this is the innovator equivalent. So you ask them for 2-3 aspects. Do you have a PKPD study? Do you have a study which has shown that when you switch the patients from the drugs in between, do you have any study which is looking at those 2 aspects? These 2 questions will help you know whether the molecule is really working or not. Let us see the data as to what we see. So biosimilar glargine has been approved in major markets, and in India it started in 2009, and we got the approval in 2020 from the US FDA. So in this process, the studies that have been done are the Basalog phase 1, that is comparing Basalog with the European Lantus and the US Lantus. Then the InStride 1, that is a phase 3 trial on type 1 diabetes. Then InStride 2 is phase 3 trial on type 2 diabetes, and InStride 3 is phase 3 trial in type 1 diabetes, which is a switch study. So the 2 important studies are global PKPD study and the InStride 3 study, which actually gives us the, you can say that with confidence that if these 2 data are available, then the molecule is, whatever the data shows, that is what the data is, whether the molecule is similar or there is some difference. So again, the global trials have included in many countries across the world, patients around 1,900 patients across 20 countries, 7 clinical trials. So this study was presented in the 77th ADA in 2017, looking at the PKPD, that is the pharmacokinetics and pharmacodynamic study of the biosimilar glargine with the reference insulin glargine in type 1 diabetes patients. So for any PKPD study, we need to do something called as a clamp study. So in this study, 114 patients with type 1 diabetes were looked at, where the bioequivalence measurement was done between the biosimilar glargine and the European Lantus and the US Lantus or the US glargine. It is a single center randomized double blind control 3-way crossover. It is a hyperinsulinemic euglycemic clamp. Patient received a single subcutaneous injection of 0.4 units per kg of each trial drug. So you give insulin subcutaneously and you continuously give glucose, and you have to keep the glucose level steady and give the insulin dose. So for all practical purposes, if the glucose rate is similar in the patients, the insulin given also should be similar. Then you will say that they are biosimilar. So here you can see that the randomization screening was done. In 28 days, the first clamp was done. Then again, second clamp was done after another 28 days. And that is around 4 weeks period. Next, again, fourth visit and fifth visit. So you had 3 visits which are looking at the clamp data, because you have to change the insulin every time to the same patient. So the one patient would have received all the 3 drugs over a period of time. But that's why it has to be, you may ask why it cannot be done in multiple centers. It has to be done in a single center because you need to ensure that all the parameters are equal. Then only you can study the pharmacokinetic or pharmacodynamic studies. So here you can see that there is a smooth insulin profile of all the 3 drugs which are over a period of time in the next 24 hours. You can see here the insulin increasing and at the same time peaking and then coming down in all the 3 groups. Again, you can see here, this is the plasma M1 profile. M1 is nothing but metabolite 1. Glargine turns over into a metabolite M1 and M2, and this is M1 metabolite. Again, the metabolites are also similar in their peak values, and when it is coming down also, you can see the concentration coming down with the insulin glargine preparations were similar. So this is the glucose infusion rate. Glucose infusion rate has to be smooth and which has to be parallel to each other. So you can clearly see that the glucose infusion rate is parallel with the 3 molecules. So this suggests that when the insulin is given, 3 insulin given for the same patient at 3 different times, you are likely to get similar peak values, and the glucose that is infused into the patient to maintain the glucose level at 100 milligram per deciliter is similar across the time period. So this is, you can say, nearly superimposable. Therefore, you can be confident that when the insulin is given into the body, the patient's insulin level will reach similar in all the three insulins. So bioequivalence of biosimilar glargine, US glargine and European glargine was demonstrated in patients with type 1 diabetes for both primary PK/PD endpoints, that is pharmacokinetic and pharmacodynamic endpoints were equal, and the insulin was well tolerated and there were no safety issues. So this led to doing the phase 3 INSTRIDE 1 study, which is looking at non-inferiority of Biocon's insulin with the insulin glargine in type 1 diabetes. So INSTRIDE 1 was presented in 2017. So this looked at, the objective was to see whether once daily glargine, that is Biocon glargine, is non-inferior to the reference glargine. It was a multicenter trial, 558 type 1 diabetes with HbA1c less than 9.5 at screening. Patients were 18 to 65 years, treated with once daily glargine for at least 3 months. The initial screening period was here 4 weeks, then run-in of 6 weeks, then 1:1 with 1:1 ratio. The patients were divided and Biocon insulin and reference glargine was given and followed up for 52 weeks and then again follow-up of 4 weeks. So the primary endpoint was looking at the HbA1c change from baseline to 24 weeks. The non-inferiority margin was defined by upper limit of two-sided 95% confidence interval for difference in mean change from baseline to endpoint for HbA1c should be not greater than 0.4% at week 24. So this is, they use something called as MMRM, that is mixed analysis of repeated measures where you are measuring HbA1c multiple times in the same patient. So for that, it is very difficult to do a randomization when you are doing that for using the routine trials. So they use something called as an MMRM to make the analysis. And after that, you should get, if the endpoint says that the non-inferiority margin should not be greater than 0.4% at week 24. So at the end of week 24, the difference should not be more than 4% between the two HbA1c values. Though you will measure multiple times, but you will conclude that it is non-inferior only when at the end of 24 weeks, the difference is not more than 4.4%. That is, very, very less. The secondary endpoints were looking at HbA1c from initial to the 52 weeks, then change in fasting plasma glucose and change in the insulin dose. And secondary endpoints, which is very important, safety, hypoglycemia, and any adverse reactions. And immunogenicity, that is anti-drug antibodies, short form used as ADA, but it is anti-drug antibodies. So you can see here with the first chart showing the HbA1c, at week 24 and week 36 and 52, the HbA1c or the confidence interval between the two glargines, the reference is red and the blue is test. Both are very similar. And when you look at the fasting plasma glucose, they are also similar. The goal was to keep the fasting plasma glucose between 70 to 130. So the conclusion where there was no statistically significant difference in the actual HbA1c profile between the two groups. Both basal and bolus insulin doses did not differ between the groups, and the rates of hypoglycemia and other adverse events were comparable between the two groups in patients with type 1 diabetes. So in type 1 diabetes, the Biocon glargine has similar efficacy, safety and immunogenicity as the reference. So this led to doing the study in type 2 diabetes patients. Again, screening was done for, this was on 560 type 2 diabetes patients. Screening was done for 4 weeks, then they were divided into 1:1 groups with around 280 and 277 patients, looked for 24 weeks and then followed up for 4 weeks. Again, the non-inferiority margin was defined by the HbA1c change should not be more than 0.4% at 24 weeks, and similar secondary endpoints, that is efficacy and safety, were looked at, which included the insulin dose, fasting plasma glucose and hypoglycemia and antibodies. Here you can see the overlap is excellent between the Biocon glargine and the reference glargine. At the end of 24 weeks, there is hardly any difference between the two HbA1c values. So, which means that after type 1 diabetes, even in type 2 diabetes, it is non-inferior. So, biosimilar glargine, the non-inferiority margin should be 0.4%. Here, the difference was 0.06%, which is excellent. So when you looked at the change in the glargine dose over time, in all patients, the level was 0.124 units per kg increase over a period of time. And in patients, these are all patients, in those patients who were not on insulin, the increase was 0.236 in biosimilar glargine, that is Biocon glargine, and the reference glargine increase was 0.24. So the change in the insulin dose was similar in both the groups of patients who received the two glargine molecules. So again, HbA1c was similar in both the groups. Glargine was non-inferior, Biocon glargine was non-inferior to reference glargine, and the fasting plasma glucose were similar in both the groups, and the rates of hypoglycemia were comparable. So again, in type 2 diabetes, safety efficacy is established. But to be 100% sure, we need something that we call as switch trial. Unless you have a switch trial, you cannot be sure that the response is good, because you know that the treatment with insulin is not similar to treating with drugs. Treating with insulin, there is more control because you can keep changing the dose. You can give 10 units, you can give 24 units, you can give 36 units. Whereas in drug, you have to stick to the dose that has been mentioned. You cannot go beyond the dose. You cannot undertreat or overtreat the patient. There is no undertreatment or overtreatment for insulin. The only thing is, when you give a higher dose, you think that there is high insulin resistance. So anybody who is receiving more than 1.4 units per kg were excluded from the study. So the switch trial was done. In this switch trial, patient Biocon insulin glargine plus Lispro was given for 12 weeks. Then the patients were switched over to reference insulin glargine plus Lispro for next 12 weeks. And again, in the last 12 weeks, Biocon insulin glargine plus Lispro was given. At the end of the trial, that is 36 weeks, patient data analysis was done and followed up for next 4 weeks. This is adequate switch periods were maintained, that is 12 weeks. This was done again. There was another group which was taking the reference insulin glargine plus Lispro continuously for 36 weeks. So this was patients who had completed the INSTRIDE 1 trial and who were taking the molecule regularly. So in those patients, randomization was done and the switch was done. The first switch was here, the second switch was going back to the reference glargine, third switch was coming back to Biocon insulin glargine. So here you can see that there is some difference, which is good, because biosimilar cannot be 100% same. If it is 100% same results, then you should always have, see, when something is 100% same, then there is something wrong. You cannot have 100% same of everything. So the difference should not be more than what we call as 0.4%. If the difference is more than 0.4%, then we say it is non-inferior. The difference is between 0.4%, then you can clearly say that the molecule is similar but not same. So you can see here the HbA1c looked at is 0.05. That's why you can see a big difference, but this is very, very small. 0.05 is the change in the HbA1c, which is marginal. Even if you do the same test in the same lab twice, you will see the HbA1c change in the same patient, even the sample is given in the same day also. So this difference is acceptable. It is statistically non-significant. Therefore, even after switching the patient, you can see that the difference is not much and the patients are doing well. The red line is something that the patient, the different group, the other group which the patients were continuously taking for a period of 36 weeks. So again, if you look at the hypoglycemia, this is the blue is after switching and the non-switching sequence is the gray line. Again, you can see similar at all times. The hypoglycemic events were similar between the two groups. No severe hypoglycemic events occurred at any point during the study. So finally, immunogenicity data, looking at the cross-reactive insulin antibody percent binding over time during the period. Again, the cross-reactive insulin antibody binding was similar between the two groups, which shows that there is no extra antibody that is produced because the molecules are not those biosimilar. So it may, if they are prepared in a way where there may be some immunogenicity excess, then you may think that the quality of the molecule may be an issue for using long term. So here you can see that after switching to Biocon insulin glargine, there is no change in the immunogenicity. So again, it was looked at both in INSTRIDE 1 and INSTRIDE 2 studies. Both in INSTRIDE 1 and INSTRIDE 2 studies, you can see that there is hardly any difference in the change in the cross-reactive of the insulin antibody percentage was not much, was similar in both the groups. So there was no statistically significant changes from baseline in cross-reactive anti-drug antibody percentage binding between treatment groups at any time during the entire study. Again, the total cross-reactive insulin antibody response was similar in both the groups, around 69 in biosimilar glargine and 71 in reference glargine. In INSTRIDE 1, that is type 1 diabetes. In INSTRIDE 2, that is type 2 diabetes, you can see that the cross-reactive insulin antibody response is almost similar. So there is comparable immunogenicity profiles in the two groups, both in type 1 and type 2 diabetes. Majority of the patients were negative for antibodies in type 2 diabetes patients, and in type 1 diabetes patients, there were positive for total anti-drug antibodies, and it was consistent with previous studies indicating a prevalence of insulin antibodies in type 1 diabetes patients, and proportion of patients who tested positive for anti-HCP antibodies were similar in both the groups. So in summary, the world's first interchangeable biosimilar glargine, that is from India, Biocon, made in India, has shown that it is similar to the molecule that is there with us for almost 20 years. And we can ensure that giving the Indian insulin will give high quality insulin at affordable prices, helping to improve adherence and provide quality care for our patients with slightly reduced economical burden, therefore probably increasing the compliance in our patients. Thank you.
Excellent talk, Dr. Mahesh. Going through this data which you presented, INSTRIDE 1, 2, 3, all the primary and secondary endpoints were similar with glargine. So there was no much of a difference between a biosimilar and the natural glargine which you're using. Do you feel that, even including the autoimmunogenicity, you said it is similar in comparison, comparing even the type 1 and type 2 as well. But there is also an indication that, contraindication that the biosimilars cannot be used in acute conditions. Say if it's a patient is having a DKA, why is it that we are not able to use a biosimilar where it has all the characteristics which we expect from a good insulin, but still it's differed? Do you have any reasons behind it?
So the initial fear was always that the patients with DKA are, we always reference them to be a type 1 diabetes who is likely to have antibodies response that is very high. So if we give something that is likely to produce an antibody response, because the antibody study is very, even in the newer molecules, they hardly produce any antibody data to us. So unless we had the antibody data, we were not able to, and they were not done the trials. So in acute conditions, nobody had done the trials. So for a clinician, when we want to write something in acute condition, we want not only that it is effective, but also it is done in that particular group which will receive that drug. So unless we had that study, we were hesitant to use biosimilars, because biosimilars means that they will usually be done in stable patients. So they will not take the risk of doing it in acute conditions. So in acute conditions, because in acute condition you are looking at very high morbidity. If somebody goes to medical legally, goes and tells that studies have shown that DKA with mild to moderate DKA with bicarbonate levels more than 10, patient has been managed with subcutaneous insulin. Studies are there which have shown that in semi-urban areas or rural areas where there was no ICU condition, insulin infusion pumps were not there. What used to happen is that they used to give IV insulin with the tube, and initially they were you have to discard the insulin because the tube will absorb the insulin. So and then to maintain the rate of the insulin is very difficult. Patient moves his hand, patient used to get into hypoglycemia, and all those issues were there. So people did studies using subcutaneous insulin for mild to moderate DKA, and they saw that it is still patients do respond with IV fluid is enough, because dehydration is the first killer in patients with type 1 diabetes. Even if you are able to just hydrate him without insulin, you can achieve 10% reduction in the glucose levels with just IV infusion of just normal saline or even half normal saline. So that initially was there, but then for a patient who is having mild to moderate decay bicarbonate more than 10, you can still manage them in a ward with the basic monitoring parameters. So for a mild decay, you need not even admit to the ICU. You can just manage with subcutaneous insulin with IV fluids. So that you are right that the initial we never used any subcutaneous insulin for acute condition. When the insulin for the patient and see the results that the patient is, he will not. The company is not going to worry about one acute condition. If they don't use, okay, no problem. Do you right? I will not use. They don't mind. So there are multiple issues why they don't.
Okay, thank you, Dr. Mahesh. Before we conclude, with the costs being slightly probably 50% lower than the existing glargine which we are using, do you feel this is going to be another game changer in management?
Yes, sir. I think we will see the rural areas, semi-urban areas using basal insulin more often beyond the just premix insulin. Excellent. And reduce the hypoglycemia.
So thanks for the wonderful delivery. Over to the organizers. Thank you.
I would request Dr. Shekhar to felicitate the chairperson and the speaker. I welcome Dr. Manohar to chair the next session. And also the speaker for next session is Dr. Vasan.
Hello everyone. Thanks for being patient, and I think one of the most important topics, important, I don't know. But I don't know how many of us routinely ask all our diabetics that, do you have any sexual dysfunction? Honestly speaking, I don't know whether we really ask everyone at all. So that's the most damaging statement, which is a harsh reality. To speak about that, we have Dr. Vasan, uroandrologist, CEO and Medical Director, Ankur, Bangalore. He's been associated with me for so many years, and most of the Disha programs. It's one of the highlighted speaker for us. Over to you, sir.
Thank you, Dr. Manohar, and thank you, Disha. I think this is a wonderful opportunity to see you all again. I think I've been fighting with diabetologists to include some of the basic things of sexual dysfunction evaluation in the practice. And I realized long ago, because I was associated with diabetologists for many years, that in their busy practice, probably privacy was an issue because there are a lot of female diabetologists who take the history. And also diabetologists perceived sexual dysfunction as a complex history-taking process. So this was what my observation was. And also the third was, there was probably no monetization ability. So that is what drives practice. So I realized this, and this talk is basically to empower you to see that that your patients benefit as a holistic treatment, and probably help also in your quest for improving clinical excellence. So there are various reasons people present to you with. It may be erectile dysfunction, it may be premature ejaculation, but history is very important. If you don't ask the history, many men, Indian men, especially I've seen this dialogue when you have retinopathy, when you have neuropathy, when you have proteinuria, what is sex all about? So there is always that fear that you have multi-organ involvement, and consequently sex takes a backseat, especially if wife is there. Wife will also say, forget it, what are you talking about sex? But this is a quality of life issue. So what we believe is that most of you are perceived with the burden of complex history taking. So I head the South Asian Society for Sexual Medicine, and we debated this and said that how do we make it very simple for everybody to ask a question? And that's why we have come up with a 6 question format, which we believe is a very simple questionnaire which you can incorporate in your practice, which gives you an overview of what the patient wants, whether he has an erectile dysfunction and whether he has a premature ejaculation. And also, mind you, in diabetologists, especially we are talking about cardiometabolic diseases here, we all know that metabolic syndrome is a significant biomarker for erectile dysfunction, and probably a young patient with diabetes who presents with erectile dysfunction, we call it as a sentinel marker of a cardiac disease. So that is where the dialogue goes. So these are the 6 questions which we have, which we can circulate to you, where you can ask this question and then decide whether he has a combination of only erectile dysfunction, or he has a premature ejaculation, or he has both. I know that the reason is that, one, you need to treat the condition and also treat those who are not responding, and also understand whether there is a cardiac risk. So one of the barriers which I found initially was, is there a significant risk for any of the PDE5 inhibitors we use? Because there were some reports of some mishaps which happen. So one of the things which all international societies have come out is that what is an exercise ability? An exercise ability is the amount of stress you put on the heart for a given sexual activity, and that is calculated as Bruce treadmill protocol. And if your sexual activity is equivalent to walking 1 mile flat in 20 minutes without breathlessness, and or briskly climbing 2 flights of stairs in 10 seconds. So if you are able to do that, then you don't require a cardiac evaluation in any given individual. So this is the algorithm we follow, that not all patients require to be evaluated. So this is a simple protocol which you can incorporate. And post that, what happens? I will get back to what are these new tools of evaluation and all that. Most of us start treatment empirically, and only failures will need a detailed assessment. So what is the treatment plan? So you have a married man with erectile dysfunction who comes to you with difficulty in erection, either penetration difficulty or he loses the erection during sexual activity. First is the history, which is directed to understand whether it is primarily an erectile dysfunction or he has premature ejaculation also. What is more predominant? Because if there is a combination of both, you always treat erectile dysfunction first, not premature ejaculation. So, and next is establish medical control over the comorbidity. Obviously, if he has got a HbA1c of 11 or he has other problems, then obviously he is not going to respond to any medication. And some local and regional, because we don't want phimosis or something, balanitis, which affects some of these men, especially in diabetes, which might take away the performance and things of that sort. Then is to assess whether he can climb 2 flights of stairs. These are all questions. You don't need to, have a, biophysical assessment. This is just a questionnaire where he can climb 2 flights of stairs in 20 steps in 20 seconds without breathlessness, or 1 mile 20 minutes without breathlessness. If he says he meets this criteria and is safe, then you go ahead and prescribe a PDE5 inhibitor. Now, what PDE5 inhibitor? We always give sildenafil 50 milligram on demand. We always start with the lower dosage, despite knowing that diabetic response might require higher dosage, because most Indian men are worried about side effects. The moment they get a side effect, the wife will ask to stop the tablet or he will stop the tablet. So nobody likes side effects. Though the Western literature quotes highest dose and then reduce the dosage, we prefer the other way around. So short-acting PDE5 was suggested to reduce the side effects. And if after 2 tablets it's a demand pill, so you take it whenever you need, usually you require some amount of sexual stimulation. You can't take the tablet and watch a TV and hope to get a response. So many of us may not have this eroticity in our life as we age, and that's why we recommend a gentle penile massage, just like a masturbatory massage, and increase it to 100 milligram if 2 tablets don't work. And if at this stage, even after 2 tablets of 100 milligram, he's not happy, then of course he would require advanced investigations. But if he is happy, then you just continue him on demand therapy, whatever is the dose. As long as you control the comorbidity, he will continue to respond, though there is an element of tachyphylaxis which comes in, but that's at a much later date. And along with demand therapy, you always look for lifestyle changes and control of comorbidities and so on. If he does not respond to 100 milligram, either you evaluate him further if you want to, but if you think that your practice is too busy and you don't want to get into the depth of erectile dysfunction evaluation, at that stage you could refer to a specialist. So this is a simple algorithm, and if he can't climb 2 flights of stairs or he has got breathlessness, then of course either you do the cardiovascular assessment yourself, most of you are competent enough to do that, or you refer him to a specialist to see whether you can grade the risk in terms of the cardiac morbidity. So the other domain which you get is premature ejaculation. That means there are people who say that my erection is okay, but I ejaculate too early, or I penetrate. Usually it is after penetration. Very rarely you will see at your practice penetration before sexual activity, which usually happens in young men or very old men where the erection is not sufficient. So that's why I put it as PME and coitus, or PME. Sometimes Indian men also come back with PME on masturbation. So here you start with whether there is an associated erectile dysfunction. And like I said, if there is an erectile dysfunction associated with a premature ejaculation, though the patient is complaining of premature ejaculation, you always treat erectile dysfunction. That is the algorithm. But if you think it is pure premature ejaculation, then you start on depoxetine 30 milligram on demand. So depoxetine was chosen as the first line therapy because it is an on-demand therapy and has minimal side effects. And again, you give him a pack of 4. He takes 2 tablets, 30 milligram on 2 occasions, doesn't respond, then he increases to 60 milligram. A pack of 30 is given that so that he can take 30, 30, 60, 60. And if he is happy, he continues to take depoxetine 60 milligram. And if he is unhappy or he is not responsive, obviously at that stage, he will require further evaluation. So if primarily there is an erectile dysfunction component and not a premature ejaculation, like I presented in the last slide, you start him with sildenafil. And then if he gets relief of premature ejaculation with sildenafil, then you just continue sildenafil, though his complaint is premature ejaculation. But there are some people who will come back and say they don't have that much relief, though their erection is slightly better, but they're still having premature ejaculation. In that kind of a scenario, you start adding sildenafil to along with that, you add depoxetine. That means you give them a combination of sildenafil 50 milligram, depoxetine 30 milligram. I would recommend strongly not using a combination drug which are available in the market, which does not give you the titration ability. So it's dangerous to use these drugs because sometimes you want to down titrate sildenafil to 25 milligram and depoxetine to 30 milligram, and that doesn't, that combination drugs don't permit. So we always use separate drugs. It doesn't matter if the patient has to take 2 tablets. There is hardly any financial benefit he can get by using 2 tablets. It's not very expensive, so that is what we do. So consequently, this is the algorithm where you have a very clear algorithm which is defined, which anybody can incorporate in their practice, and it's very easy to do because it'll make your treatment more comprehensive. And the way I have seen some of the diabetologists do is they put these charts outside that there are, obviously all of you have these charts where you display what are the side effects of certain things and all that. So subtly, if you convey the message that this erectile dysfunction is a problem and it could be treated and there are various options to treat, then yes, there are a lot of people who would come back and tell you that this is what they have and probably initiate the dialogue and take the treatment. So simply to summarize that if you have a coexisting problem of both premature ejaculation and erectile dysfunction, you always treat erectile dysfunction. And if erectile dysfunction improves but premature ejaculation still persists, then you add depoxetine. If it is only premature ejaculation, then you initiate tools, which is your stress tests and echo, which you could do to evaluate. But we are more concerned about people who have established problem. So we are looking at endothelial dysfunction, which is a much earlier problem which sets in So there is this group of population where there is a lot of gamut of tests which are evolving, which you could, if you want to incorporate in your practice as tools, those people who have all these high risk factors, which is what is your patient population, which you see. So there are non-invasive tests where we require, these are all endothelial dysfunction assessment and all that. And these equipments do not cost you more than 3-4 lakhs. So consequently, what happens is you are able to pick up endothelial. This is very valuable tool because if you are starting them on medication, you could probably see whether the medication, there are a lot of people who we believe in India have this sudden cardiac death. Probably they feel nice that they are very healthy, but they suddenly drop dead. So these are individuals who there is a lot of theory and hypothesis to their endothelial dysfunction. One is to look at lipid profile and say my lipids which were 300 has dropped down to 200 and I'm very happy. But at the end, arterial level, whether it has made a difference, whether it has made a difference in the pulse wave velocity, whether it has made a difference in the endothelial dysfunction. So what is a process care model? This is a very simple model where we believe that we ask the question, 6 questionnaire, which is called the ALLO algorithm, wherein we allow the patient to talk. It's also an acronym, cardiac risk yourself, referral if you need it, start oral medication, and many of your patients may not require psychological input because you don't see that, and then you have the lifestyle modification. Now, the second part of the question is there are a lot of patients who are more sexually active. What is an ideal drug? I already told you we start with sildenafil, but if this is with the presumption that you don't have multiple partners, you have not have a sudden partner who drops in at 2 o'clock and suddenly you are asked to have sexual activity. So, or you don't have those kind of demands. So that's what is a predictable partner. If you are one of those individuals who had a non-predictable partner, that means you don't know when you are likely to have sexual activity. It might happen in the afternoon, it might happen in the night. Those are individuals who benefit better with, there as high sex drive individuals, and we give them tadalafil 5 milligram on a daily basis, plus an on-demand whenever they want to have sexual activity. So that is the brief way you this thing, and always start with the lowest dosage. In case of sildenafil, it is 50 milligram. In case of tadalafil, in a diabetic population, it is 10 milligram. Non-diabetic population may be lesser than that. What do you do for non-responders? You have given 4 tablets and a patient has not responded to sildenafil or tadalafil. What do you do? So now we believe, whom do we classify as a non-responder? If we have given 5 doses, earlier we thought 8 doses CD5 inhibitor at the maximum dosage. That means what is the recommended maximum dosage for sildenafil is 100 milligram, tadalafil is 20 milligram. Then you consider it as a non-responder, controlled, and then you need to take care of the comorbidity. The other, the most important thing is lack of adequate sexual stimulation. That means you don't have the eroticity in your life, or you are just mechanically performing sexual act, or you are trying to take the drug and you have not given some 15 minutes effect and all that, at least to give it 45 minutes to 1 hour, because the digestion in the stomach varies from person to person. And failure to dysfunction and local factors, neurogenic factors, which may further add to the problem and you may become non-responders. So what are the common comorbidities we are worried about? One is the metabolic syndrome. Whether the drugs for comorbidities cause ED, yes, some of your hypertensives cause ED and antipsychotics cause ED. Whether comorbidities are corrected by PDE5 inhibitors, of course, tadalafil is supposed to significantly improve ejection fraction among ED patients, and hypertension patients, there is a sub-selective cardioselective action. The only contraindication is nitrates and some amount of ketoconazole, itraconazole, which is your antifungal drugs, and erythromycin and so on and so forth. What comorbidities are aggravated by PDE5? Only non-arterial ionic optic neuritis, sudden hearing loss, your Stevens-Johnson syndrome, exfoliative dermatitis, and fixed drug eruption. These are the only conditions where you should not be prescribing a PDE5 inhibitor. So this is a brief summary where I thought it will be very useful to incorporate this into your practice, because this is what we do. And the more you treat, the more you will get interested in the subject, because now the question is, there was an era where people said that when Viagra was introduced in 1998, people thought that they had all the answers for erectile dysfunction. Now we believe Viagra is not the answer for erectile dysfunction. It's just like a Dolo 650. You're taking a Dolo 650, your headache doesn't go away, your primary problem doesn't go away. Now is there of regenerative medicine. So we are looking at why are we testing the endothelium? Because most of us are living longer and our quality of life is improving and our financial ability is improving. So consequently, sex plays a very important emotional well-being role. It may be once a month, it may be once in 2 months, whatever the duration depending on the individual. So he wants to have as natural an erection as possible. And that is possible now if I identify stem cell therapy where you can incorporate this in your practice. It's a very simple tool, just like you have incorporated your eye checkups, armamentarium of treatment, which will benefit a lot of patients. Thank you very much, ladies and gentlemen.
Excellent, crisp and clear, sir, as usual. So a lot of this medicine from you. So one question before others ask, when do we say it is premature ejaculation? Many people come with it.
Yeah, that is a patient definition. It is like you don't decide. There are couples who have what we normally ask is, nowadays if you want a research tool, it's called intravaginal ejaculatory latency time, IVELT. Now, there was a study which was done where the wife keeps the stopwatch and asks the husband to start and then stop and then measure the IVELT. But I'm sure in a sexual activity it becomes very difficult. So, challenges with premature ejaculation is we all have to realize that there are women who are orgasmic with vaginal sexual activity. There are women who are not orgasmic with vaginal sexual activity. But luckily, you don't have that population. You have a population who has been normally sexually active. Find that earlier he used to ejaculate in 2 minutes or 1.5 minutes or whatever it is. It varies from person to person. There are people who reach an orgasm in 30 seconds. There are people who may not reach an orgasm in 33 minutes. So a premature ejaculation for a given individual may be even 2.5 minutes is premature ejaculation for me. For another individual, half an hour, 3 minutes may be a premature ejaculation. So it's a patient-defined term. So we don't get into the concept of measuring and things of that sort. If he says it's premature, we accept it.
One is there any age restriction in terms like in a particular age group over 60, 65 sometimes? Patients do come like saying that they are having such kind of a problem. So is there any such kind of a protocol? Second is, if the weight of an individual is a particular baseline, should the dose vary accordingly?
Weight of the individual?
Yeah. Suppose if 100 kg
male. To answer your first question, it's mind over body. If on a Saudi patient who was 90 years, who wanted to be sexually active for his 4th wife. So that was the need and he came. Of course, we did a prosthesis. So obviously, none of our Indian patients probably will be looking at that. Second question, obesity, what are the challenges you have? You have prepubic fat. So the penis gets buried. So the penis becomes very small in most of these men because of excessive prepubic fat. Where does the fat sit? We all have abdominal obesity and we have prepubic fat. So the penile length hardly is existing for these individuals. If you see their penile length, it will be a stub which is coming out, and you will have to really, when you want to catheterize, you have to dig into this. The moment they crouch on the bed, probably the penis will retract somewhere and they will not be able to. So one of the things in that group is, if they want to increase their length non-surgically, one is to give them a vacuum device. There are various tools, just like you have similarly, you have a vacuum device which stretches the penis back to its original length, which you can give it. It costs about 3,000 rupees or so. They can buy it on the internet also, or do the sexual activity in the standing position. That is what is recommended for them because they lose the length, and that is their primary concern. And many of them don't realize simple technical changes in their sexual activity would give them some amount of relief than trying to do that.
Thank you, sir, for a wonderful talk. For definition of non-responders, you said 5 times tablets if they use and they're not able to see any difference. This will be for the maximum dose.
Yeah, the maximum.
And there was a mention of using 5 milligram daily for those who do frequently requiring sexual activity. I don't know whether I have tried using some patients where I've told them to take daily. The non-responders have turned to responders. I don't know whether it's...
Yes, you can. You need to evaluate them. I didn't say that they will always be non-responders. So
No,
one of the things I said is that group of patient might require one additional test to find out why they are not responding, whether it's comorbidity management, whether it's lifestyle, whether there's endothelial dysfunction, and then you for some of these group of patients, where we give tadalafil on a daily basis, and then add sildenafil when they want to have sexual activity. Yes, you are right, we do that. But that's a little...
You made a very pertinent points in this discussion. Post these questions to the patients, they feel the heart pours out whenever you have those discussions. And they would never let you down, and then they would probably bring in a bunch of patients to you in your clinic. So that's one gratifying thing that we have seen. The question that I had for you is, how does this choice of molecule actually bring about an effectiveness and change? That was my first question. Second question was related to regenerative medicine. So the EECPs that that has been used generally, how effective it has been, and when do you start using that as a therapeutic modality of choice? And also the third question was, able to pick this up 10 years ahead, and then you're able to intervene. Obviously, the cath labs would run out of business.
You touch my heart. Use because sildenafil has a short shelf life, half-life of about 4 to 6 hours, and tadalafil has for about 24 to 36 hours. That is the logic for using a baseline tadalafil and adding sildenafil at the time. So he has a continuously primed endothelium. I think regenerative medicine. So in terms of regenerative medicine, I have done extensive work. What are the tools available for you, which is sound-based therapy, which there are a lot of machines available. Now, the question is, in which patient concept is you can't measure the penis, and you are having this as a surrogate marker of a similar size diameter. So if there is endothelial dysfunction, you should go for platelet-rich growth factors. One of the challenges in terms of autologous, where you use the patient's blood. We did a study with Shivaraman Blood Bank in Manipal, where we found that you need 500 ml of blood and synthesize that blood and get the VEGF, and that amount of VEGF you have to inject. So there is some amount of trial which is going on for homologous, where we segregate this. One of the challenges in homologous is the transmission of viral factors and so on and so forth. And of course, it is still not an approved therapy as of now, but homologous shows wonderful results because you can control the patient reports dramatic improvement in his erection. The only thing is the effect may not last more than 18 to 24 months, and he might require an injection. Third we measure is the central aortic pressure, and what we measure is the pulse wave velocity and the transmission time. What we are looking at is elasticity hardening of the endothelial dysfunction, so mild, moderate, and severe. So if you have started endothelial dysfunction and your velocity is, the pulse wave velocity is becoming faster, that means the vessel is more stiffer, then your biological versus chronological age changes. So then what is men's health all about? See, one of the concepts of andrology is now moving into men's health is men, especially between the ages of 40 and 60, are very busy with their, which has sudden cardiac morbidity and problems. So we have a program where we assess the vascular risk by simple non-invasive tools, and we assess along with sexual risk and put it as a package. So all these packages, I'm not saying that these packages are not mandatory measure. If your malignancy risk is low, if your bone is good, and you're sexually active with a lot of money, you will live longer.
Thank you very much, sir. Here I would like to tell. Yeah,
absolutely. See, one of the things is these are all collateral medications which we use. Basically with the hope that than nitric oxide synthase activity, which is one of the prime movers of in priming the endothelium for the PD5 cascade. What is an ideal dose of these kind of things, and whether it can be a food supplement? So I've been working in the nutraceutical segment, so I have brought out my own nutrition function, Luckily, it works very well, and some company is interested in taking it over. So let's see. But I'm just saying that is the concept. The concept is there are crack that, and we have been able to assess as a food supplement. So it is necessary, just like people used to take. Of course, I don't know how relevant it is taking an aspirin or taking a. Don't want to go into that. But in this case, I think endothelial maintenance, there is no doubt that you should take it because it is harmless and it protects your body. At endothelium, everywhere, if it gets damaged, the first thing is that organ suffers, whatever the organ may be.
Take-home messages. One, usually there is a saying, when the second is tadalafil. James Bond requires tadalafil whenever he comes to your clinic. So unpredictable this thing. That's a good take-home.
Yeah, I agree with him. I don't believe anyone I used tadalafil and short acting in between.
So you have an energetic population, Manoj. That's why.
Is ischemic heart disease a relative contraindication for PDE5 inhibitors? Or when do you make a choice?
Like I am saying, per se ischemic heart disease is not a contraindication, but otherwise no.
Thank you very much,
and
sir.
Only recent MI of less than 6 months is a contraindication. That's one thing we don't want to. And other than that, the take home, if anybody is interested in adding regenerative medicine in their practice, please contact me.
And sir does some courses for...
You asked me that. He asked me day before yesterday. I got very busy yesterday.
Because
I had my Andrology Society meeting. So we have launched online programs for education. But more importantly, I think most of you don't require that kind of education because you are all very senior and I think you have the sufficient knowledge. What, of course, I will share with you. I will share everything with the Disha group. But more importantly, I think we are in the process of empowering. It helps everyone. Everybody grows with that. So that's the way, that's the logic. So if anybody is interested, because one of the challenges I found is all of you.
The premature ejaculation, I don't know, but this is what I'm expecting from him. So short and crisp talk. Vijay have that problem. It is only with respect to the talk I'm saying that it is. So over to me, we will talk on the old wine, pioglitazone.
Yeah, I think coming back to diabetes from the previous talk, okay, I'm here to talk about the, I think, largely scared molecule possibly nowadays after those rosiglitazone issues and all. Pioglitazone has gone backwards in the treatment, in our management of diabetes. So today my talk was to talk about pioglitazone, and because it was a time-tested molecule. But before, rather than that, I would say, whom do we have to treat with pioglitazone and whom not? So that would be my basis of this talk. So with this, let's start with knowing what is when we look at diabetes, it's the insulin resistance that starts as a basic pathology, and the prevalence, if we see in Indian population, we have a huge number of population, higher incidence, about 11.2% compared to most of the other ethnic groups. And this, in spite of the lower BMI, the Southeast Asians has got more abdominal fat, more insulin resistance, hyperinsulinemia.
Since you are the organizer, you won't get anything. And I would like to call on Dr. Sridhar for the customary vote of thanks. I have always been accused of finishing it off there on stage, but now I remember and I called him. Over to Sridhar.
Thank you. Good evening, everyone. So as there is a saying that everything comes from in, any good thing has to come to end, but in Disha, this is not the case. Like, though today is the closure of the summit, but the continuation of the education still continues, and we look forward for future participation, and you have really been patient in sitting the whole day and making this summit a grand success. So I would like to thank the delegates. I would like to thank the faculty. I would like to thank, though I'm a part of Disha, I would like to definitely thank Team Disha to effortlessly trying to make this event more and more successful year on year. And special thanks to Dr. Manohar, who is my friend, classmate, batchmate as well, and all the Disha members who have worked day and night basically to ensure this summit becomes a success. Special thanks to the pharma companies. I would like to read out the company names: Abbott, Micro, Nova, USV, Novartis, Biocon Biologicals Limited, Cipla, Merck, Astra, Torrent, Jarun Pharma, Jouster Division, Mankind Specialities, Empower Life Sciences, Sun Pharma, Micro, Carizon One Division, Zydus Life Sciences. So thank you so much for your cooperation. So we look forward for future participation, and thanks once again.
Most importantly, the bar is open and we have dinner served next to us. Thank you so much.